to the stage. Thank you. The one sitting, please come close. Saudi Center, and we are pleased to have you today. So, ladies and gentlemen, distinguished guests, and esteemed colleagues, welcome to the concluding day of the 4th SPSC International Patient Safety Conference. It has been an accelerating journey filled with knowledge sharing, collaboration, groundbreaking insights. As we gather here today for the final day, let's reflect on the wealth of information we have acquired, the connection we have forged, and the collective stride we have made toward enhancing patient safety. Over the past few days, our conference has been a melting pot of ideas, experiences, expertise, all converging with a shared purpose to empower patients and providers. We have dived into crucial topics from diagnostic safety and patient empowerment to the role of technology and the impact of culture, leadership, and governance. Our esteemed speakers have been architect of the intellectual symphony, guiding us through the entities of health transformation, sharing a real-world challenges, and envisioning future where patient safety is not just a priority, it is an aim. Today, we wrap up the conference. Let's not just celebrate the knowledge gained, but also relationship formed and collective commitment. We extend our heartfelt gratitude to all our speakers, moderators, sponsors, and each one of you has contributed to the success of this conference. Starting our day with our keynote session about Global Patient Safety Action Plan presented by Dr. Neelam. Dr. Neelam heads WHO flagship, A Decade of Patient Safety 2021-2023 at WHO headquarters, Geneva. In this role, Dr. Neelam leads global efforts in providing strategic leadership on patient safety within the extent of universal health and health security. This includes implementation of World Health Alliance Resolution Global Action on Patient Safety. Let's all hear and learn from Dr. Neelam. Thank you very much.
Good morning, colleagues. Thank you, Lamia, for the kind introduction, and such a pleasure to be here. And before I start with my presentation, I would like to convey my sincere thanks to Dr. Ali, Dr. Abdullah, and all the leadership of the Saudi Patient Safety Center for giving me this opportunity to be amongst you and to learn from you, and also to share with you some of the global developments over the last couple of years. I presume that some of you are aware of what I'm going to present, but even at the risk of repetition, I think it's, as Lamia mentioned, that it's not a priority, it's an aim. It's a passion and life objective for many of us. So it is such a privilege. And thank you to Saudi Patient Safety Center for the invitation and for your very kind hospitality. Nobody can match Saudi hospitality, so I'm really, really impressed, and thank you so much. So before I start with my presentation, I was reflecting on the theme of this conference. And I was really impressed with from awareness to action, empowering patients and providers for safer care. And all of us who are in the room, we are already patient safety committed individuals. So we observed the 5th World Patient Safety Day in September, so on the 17th, and with the theme of engaging patients for patient safety. So from the awareness which World Patient Safety Day generates to the action which all the leaders and healthcare professionals bring forward. So this room is really for action. How do we really take forward the awareness which we have created through World Patient Safety Days the last 5 years, and also building on to the success of the several global initiatives? How do we really translate that into action? And from action, taking it forward to bring about the change we want to see at the point of care in people's lives. And ultimately, it's, although it looks like very, I should say very broad objective, saving lives, but we are all here so that we can save lives of patients and families and the agony they suffer if harm occurs. So we are all committed to addressing avoidable harm in healthcare, because no harm in healthcare is acceptable. So with that commitment and that personal passion, all of us who are working on patient safety, it drives our agenda to improve lives of patients and families who come to access the healthcare system, and they have trust in the system. So how do we maintain their trust and ensure that there is no harm in healthcare? So I'd like to walk you some of the slides, and this is to share the journey which we've had since last couple of years. Although harm in healthcare has been recognized for several years, but I would say never before there had been such momentum to address this issue of harm in healthcare, particularly harm which does not need to happen, which is unnecessary and which is totally avoidable. How do we take action on that, and what are we trying to address? Sharing with you a couple of statistics which we have been able to generate and to gather. So there are several studies which demonstrate that adverse events are one of the top 10 leading causes of death and disability globally. A huge burden of harm in healthcare which is avoidable. And if you look at what actually is happening, even in high-income countries, this 1 in 10 patients are harmed. If we look at global figures, similarly in high-income countries, 1 in 10 patients in hospitals are suffering from harm, which is avoidable. And particularly in low and middle-income countries, there is disproportionate harm happening because of weakness in healthcare systems, and also because of several challenges of resources and capacity. It is estimated that up to 134 million adverse events take place in hospitals, in LMICs, which lead to so I think I'll stay here. These 135 million adverse events which have been estimated through the global So I'm sharing the figures with you that although the issue of patient safety is global in nature, all countries in the world, high-income countries and low-income countries, are equally affected. The low and middle-income countries are disproportionately affected because there's a huge body of avoidable harm happening in healthcare systems. It is estimated that 134 million adverse events happen every year in hospitals, and which is almost every minute 5 patients are dying in hospitals in LMICs. which is about 2.6 million deaths. And if you look at global figures, it is estimated about 3 million patients die every year. And more than half of this harm actually is avoidable. So this issue has been recognized by political leaders, and particularly in the UK and Germany, the political leaders recognize that this issue of patient safety needs to be addressed and brought to the global attention. And that led to an unprecedented momentum and initiation of an annual global ministerial summits on patient safety. And these summits galvanized action, brought together political leaders and policymakers and experts to look into what is the state of the art and what needs to be done, particularly where political commitment and will is required to bring about the change. So you can see on the screen, there have been so far 5 ministerial summits which have taken place from 2016 in the UK to 2017 in Germany, 2018 in Tokyo, and 2019 we were in Jeddah under the leadership of the Saudi Patient Safety Center and the government. This event was organized, which was really a remarkable event, bringing together several ministers of health, and also led to the Jeddah Declaration on Patient Safety, which paved the way for a landmark resolution on patient safety. And after a gap of 4 years due to the COVID pandemic, in 2023, which is this year in February, Swiss government organized the 5th Global Ministerial Summit. And WHO has been a strategic partner with the political leaders and governments in this initiative, and has been providing as a collaborator as well as a strategic partner and a support in this initiative. So as I mentioned, the global ministerial summits have led to a momentum which created the support of the governments from around the world, and a landmark resolution was adopted in 2019 on global action on patient safety. This was the first time when the World Health Assembly also recognized patient safety as a global health priority and established a World Patient Safety Day to be observed annually on 17 September. And extremely important that the Assembly also asked WHO to work with member states and partners to develop a roadmap for 10 years, which is a global patient safety action plan, which provides concrete strategies and actions which need to be taken by different stakeholders to move the needle on patient safety, to bring about significant and sustainable change in patient safety. And aligned with that, WHO responded by creating an initiative, the Decade of Patient Safety. And this flagship initiative, a Decade of Patient Safety, brings together, again, concerted efforts of WHO through its 3 levels of the organization, the headquarters, the regional offices, and country offices, to work with ministries of health and develop guidelines and protocols and tools, and also work with governments and partners to implement these tools to bring about a change. So a couple of important programmatic elements of this Decade of Patient Safety, which I'm heading, include the World Patient Safety Day, of course, which is developing a global campaign and facilitating the identification of topics every year for World Patient Safety Day. And this year, as I mentioned, the theme has been on engaging patients for patient safety, and subsequent years we'll be bringing forward extremely important topics for World Patient Safety Day. The Global Patient Safety Action Plan, the development of it, and as well as implementation of the action plan. An ongoing global patient safety challenge on medication without harm to address unsafe medication practices and medication errors. Global Patient Safety Collaborative, working with the UK government, established a collaborative mechanism to work with low and middle income countries in strengthening patient safety systems, as well as we've created a very interactive global patient safety network. And several of you who are in the room are members of this network and generate a lot of discussion and share information, particularly a series of webinars which have been organized by the Saudi Patient Safety Center are very well disseminated, and people are informed around the world to participate in the different activities. developing patient safety standards, guidelines, and tools on different topics, such as reporting and learning systems, and also recently we developed on implications of COVID-19 on patient safety and several other tools and guidelines. And finally, patients and family engagement. How do we empower patients and families so that they can contribute to the safety of health systems? So I just want to walk you through, considering I've been given about 45 minutes, so I thought I'll take you briefly through the journey of how the action plan was developed. It took us almost 2 years after the 2019 resolution was adopted by the 72nd World Health Assembly in May 2019. From 2019 to 2021, during the COVID time actually, we were working with partners, and that is a time when virtual world really came in existence. And we had several important initiatives to make it happen. Of course, we went through a scoping and literature review, relevant global and strategic documents, existing action plans, and then we had several rounds of internal consultation within WHO. Before actually COVID pandemic started, we had one in-person meeting which was really exemplary, and several of you actually participated in that. This was in February 2020, a global expert consultation where we selected 12 thematic areas under which we then developed recommendations which provided the framework for the Global Patient Safety Action Plan. Then we went through a drafting and review task force which drafted the action plan. The first draft was actually kept for public consultation for 2 months, and we had several rounds of consultation through member states as well. In WHO Geneva, we organized member states briefing very regularly, so dedicated briefings were organized for this action plan. And then we had the final plan which was submitted to the World Health Assembly and adopted. And Dr. Tedros, WHO Director General, himself launched the action plan in August after it was adopted by the World Health Assembly, and you can see the decision which was taken by the World Health Assembly in May 2021 that the Assembly decided to adopt the Global Patient Safety Action Plan and also requested the Director General to report on the progress in implementation of this action plan every 2 years for at least 10 years, which is 5 World Health Assembly. So the last report of this action plan is due in 2031 to report to the World Health Assembly. So this is aligned with the Sustainable Development Goals. As you can recognize that this action plan, which is for 10 years, goes up to 2030, and the report of this, the last report, would be due in 2031. And I want to highlight the title of this action plan. We spent a lot of time and deliberating and consulting with partners and member states that we want to actually reach zero harm. And in the end, there were several debates whether zero harm is achievable or not. And then we somehow had a global consensus on calling it eliminating avoidable harm in healthcare, which basically it's a mindset of policies of zero harm. But this action plan has a vision of moving towards elimination of avoidable harm in healthcare. So just to share with you the broad vision, which is a world in which no one is harmed in healthcare and everyone receives safe and respectful care every time, everywhere. And with a mission to not only build on policy strategies and science, but also look into the patient experience and system design and partnership to eliminate all sources of risk as well as avoidable harm in healthcare. And to patients and health workers as well. And with the goal to achieve maximum possible reduction in avoidable harm due to unsafe healthcare globally. The action plan is very well structured in 7 strategic objectives and 5 strategies each. So it's a 7x5 matrix, so that we have a very systems approach to addressing patient safety. It's not seen as vertical interventions, but truly looking at all aspects and all components and building blocks of health system, and specifically where action is required to reduce harm in healthcare. So these 7 strategic objectives relate to policies for zero patient harm, high reliability systems, safety of clinical processes, patient family engagement, health worker education skills and safety, information research and risk management, and synergy, partnership, and solidarity. And you can see from the spread of these 7 strategic objectives, it really touches upon all components of the health system. This is the 7x5 metrics I mentioned, and for each of these strategic objectives, there are 5 strategies which are very well structured, and under each of these, we then have specific actions for different stakeholders. So I'll go through very briefly on what are these, what key strategies are covered in these 7 strategic objectives, very briefly. So for policies to eliminate avoidable harm in healthcare, which is about make zero avoidable harm to patients, a state of mind and a rule of engagement in planning of delivery of healthcare everywhere. And this covers need for national patient safety policies, resource allocation, patient safety legislation, development of minimum standards for safety, and some special initiatives of WHO like the Global Patient Safety Challenge, as well as the campaigns of World Patient Safety Day. And I presume that you're all aware that there have been 3 Global Patient Safety Challenges which WHO has developed. The first one has been still ongoing as part of the Infection Prevention Control Program, was on Clean Care is Safe Care, which brought the hand hygiene guidelines. And for the first time, hand hygiene really was recognized as a very important intervention for preventing infections in healthcare. The second, and that was in 2004. In 2008, the second challenge was launched, which was on surgical safety. Safe surgery saves lives, and surgical safety checklist was launched at that occasion. So in both first and the second challenge, the effort was to give vertical interventions and focus on the implementation of these vertical interventions. But the third challenge, which was launched after a gap of a couple of years in 2017, is on medication safety, or the slogan of medication without harm. And that actually takes a very systems-wide approach into addressing medication errors and medication practices. So moving on to the next strategic objective. I think there's maybe one slide is missing. So strategic objective 2 relates to high reliability systems and how do we bring leadership, governance, and culture, and also patient safety in extreme adversities, as well as in FCV settings. Strategic objective 3 is on safety of clinical processes, which is assure the safety of every clinical process. And this covers medical device safety of the use needs to be addressed. Special programs on medication safety and infection prevention control, primary care and transitions of care, and mental health. The strategic objective 4 on patient-family engagement, which is about engaging and empowering patients and families to help and support the journey of safer healthcare. And this relates to making sure that patients and families are provided education and training about the health system as such, the healthcare, and particularly the importance of patient safety, learning from patient experiences, and co-developing policies and guidelines with patients as patient partners, and also developing the capacity of patient advocates and champions, as well as having policies on incident disclosure, sharing with patients and families what has gone wrong in their care. Number 5, related to health workers' education, skills, and safety, so that we inspire, educate, and skill health workers and protect health workers to contribute to the design and delivery of safe care systems. And in this specific objective, strategic objective, we are looking into how do we expand the opportunities for health workers and their education. So identifying centers of excellence, as well as looking into the curriculum designs, and also developing curriculum guides for education and training, developing patient safety competencies, and linking these patient safety competencies with the appraisal systems, and providing a safe working environment. Number 6 relates to information, research, and risk management, particularly ensuring a constant flow of knowledge and information to drive the mitigation of risks, as well as for avoidable harm and improvement in safety of the care. And this primarily focuses on reporting and learning systems. So how do we capture what has gone wrong in the system, near misses, errors, as well as harm, and making sure that whatever learnings are there from reporting learning systems, they are actually able to bring changes in policies and practices. And patient safety surveillance, research, and also application of digital technology for patient safety. And finally, looking into the synergy and partnerships and solidarity by developing and sustaining multi-sectoral and multinational synergy, partnerships, and solidarity to improve patient safety and quality of care. And we do that through common understanding, to engage our stakeholders, through creation of networks and multi-sectoral initiatives and alignment with technical programs, such as primary health care, quality of care, looking into the universal health coverage broadly. So wherever there are linkages in the health system, we link with these programs and also develop multi-sectoral initiatives. So this was the broad outline of what the 7x5 strategies framework is and what do these strategic objectives contain and what actually is the approach and the actions which are related to these strategies. So we have identified in the action plan, there are 4 categories of key stakeholders whose action is absolutely vital to bring about the change. And these stakeholders primarily are government and government agencies. And then we have healthcare facilities and services where care is provided through all levels, through all settings, not only physical health but mental health settings as well, and looking through all range of service provider through different facilities and care facilities. Different stakeholders, which are patient organizations, professional bodies, academic institutions, research institutions, industry, so any other stakeholder who is not governmental, but through different approaches, particularly professional organizations and patient organizations and several other institutions for education, training, and research, and industry, as I mentioned. And WHO Secretariat, through its 3 levels of the organization, also taking forward its action through the decade of patient safety in particular. So I'm just going to share 2 slides with you on these 10 key actions which we are urging countries to take, which are aligned with these strategic objectives, so that we can move ahead with implementation of the action plan. Because action plan is not a document, it's a vision, it's a roadmap. Now we have to walk that road as well. And for that, we really need concrete actions to be taken. And not only actions taken, also measured and reported, and so that we can show incremental improvement in patient safety systems. And in some countries, truly transformative changes can also be brought forward with these initiatives. So the first and foremost, have a top-down approach, have something very concrete as a patient safety action plan. Now, it need not be a standalone action plan, it could be linked with existing action plans, but all the 7x5 metrics and 35 strategies which have been identified somehow should be linked to the action plan. And most of the countries now are developing National Patient Safety Action Plan. And we have examples of several countries which I will share with you as well. And then number 2, establish incident reporting and learning system so that we can learn from errors and harm, and as well as also look into risk management approaches. So both safety 1 and safety 2 elements to be embedded. But if we haven't established any reporting and learning system, we are never going to learn, and we are going to repeat those errors and that harm which is avoidable. So establish patient safety incident reporting and learning systems. Then implement and participate in the ongoing challenge of particularly medication without harm challenge which is undergoing. Celebrate World Patient Safety Day, which is linked to a theme every year, but then we really hope and work towards that the action which is taken each year gets embedded into the routine and it becomes a normal ongoing activity, and it's not seen only as projects. So celebrate World Patient Safety Day to initiate and sustain change on a specific topic. And this, I just want to mention, I'm sure you're aware that several topics have been selected over years related to health worker safety, safe maternal and safe childbirth, as well as on medication safety, and this year on engaging patients for patient safety. Then operationalize the National Patient Safety Network, a network which brings together all the stakeholders and partners at national, subnational, global level. This could be aligned with the Global Patient Safety Action Plan, where we can discuss issues of concern in real time and collectively find solutions. And I must mention that most of these actions are also linked with reporting requirements. So we are requesting countries to report on these, how we are progressing on implementation of these actions. And then incorporating patient safety curriculum in medical and nursing professional education, particularly on leadership capacity as well as also human resource capacity on patient safety. Then reporting on progress on patient safety through the member state survey, institute a policy of having a patient representative in the governing boards, which is in a way creating mechanisms so that we formally can have inclusion of patient representative on governing boards in healthcare facilities, as well as prioritize and provide resources for patient safety programs, and strategize patient safety as a force multiplier for health service improvement programs, aligning with existing programs on primary health care, on quality of care, as well as on universal health coverage in particular. So you would see that on both these slides, I have shown a lot of pictures, which are existing resources which WHO has developed to work on these areas, and all these resources actually are available on WHO website in case you are interested. In addition, we also issued a consensus statement, which was outcome of a policymakers forum which we organized last year, and it's a virtual forum where we had more than 90 countries participating and almost 400 participants who joined. This actually developed the role of policymakers and healthcare leaders and what they need to do for implementation of the action plan. An extremely important, very short document gives actions which are required by leaders and policymakers for the action plan. And as I mentioned, we also issued implications of COVID-19 for patient safety and what needs to be done to develop safer and resilient systems in future. So as I mentioned that there's a reporting requirement for WHO to report every 2 years to the World Health Assembly. And last year we started a member state survey for the first time on patient safety. And we developed a tool which is very much based on these, the metrics of 7x5. And for each of these 35 strategies, then we developed criteria so that we can assess how countries are progressing on implementation and give a very simple gradation, which is fully achieved, partially achieved, or not achieved. And this survey was rolled out in October last year. Till April of this year, we collected data from 110 countries, and we reported to the World Health Assembly. An interim report was issued, and also an exhaustive, full global patient safety report is under preparation. And I'll share some of the key data which emerged from this interim report. And they are actually 10 core indicators which we have provided as part of the Global Patient Safety Action Plan, asking member states to report on the 10 core indicators, and they are in a way embedded in these 35 strategies as well. So we've extracted this data, and I'd like to share with you that if we consider 100 as a benchmark, that we want to reach 100 in all these indicators to show progress, we are very far away from reaching that. And I really hope, and we work together to make sure that we are able to show improvements over years. And this particular one in 2022, and this which we reported this year, is more of a baseline where we are globally in these 10 core indicators. So you can see that 27% countries reported that they have developed a national patient safety action plan or equivalent. And 13% countries have a patient representative on governing board. 18% countries publish an annual report which demonstrate their accountability and transparency. 36% countries have implemented a system of reporting of never events. 20% countries incorporate patient safety curriculum in education programs. 31% countries have established national targets on reducing healthcare-associated infections, and only 18% countries have established national targets for reducing medication-related harm. So this Health Worker Safety Charter, which you see that only 18% countries have signed up, is a charter which was launched in 2020 on the occasion of World Patient Safety Day, dedicated to health worker safety. And I think in a long way to go for even signing up to the charter, and we are urging all countries, all partners to sign up and to implement. 22% countries have established a national patient safety network, which shows active engagement of all stakeholders, and 31% countries report that most of their facilities, more than 60% of the healthcare facilities are participating in some level of incident reporting and learning. So this is a snapshot of these outcome of these 10 indicators and the baselining of these 10 indicators. So some examples of policies which I would like to share with you, and again, these are going to be made available on WHO website. And I'm delighted to share with you, maybe some of you are aware that the WHO organized a global event this year on World Patient Safety Day, and we also launched a global platform for knowledge sharing on patient safety, which is being hosted by Singapore Institute for Patient Safety and Quality. And this will have all the resources which we are collecting from different countries. And if you would need examples of patient safety policies, for example, in different countries, you can go to this a particular platform and you can find these different examples and tools available. So some of these examples of policies related to Sri Lanka. So several low and middle income countries have taken actions on this, including Sri Lanka, Nepal, Kenya, you can see, and high income countries, UK, Ireland, as well as Finland, and also some middle income countries like India and Malaysia. So there's a range of countries which have developed policies and strategies. I haven't put an example of Saudi Arabia, but Saudi Arabia is much ahead in the curve. And most of these indicators are very highly advanced in Saudi Arabia. So just to walk through on the World Patient Safety Day, from advocacy to action after it was established. The first year was Speak Up for Patient Safety, then we went on health worker safety, on Act Now for Safer Respectful Childbirth, medication without harm, and then also engaging patients for patient safety. As I mentioned, we organized a global conference this year to commemorate World Patient Safety Day, and we had huge in-person participation. And I'm really honored to have Dr. Ali, Dr. Abdullah, and other colleagues who participated in this in person. So we have about 120 participants from about 40 countries, and then we had more than 3,000 who registered. And in the end, I think more than 1,500 who participated online as well. And one of the uniquenesses of this conference was that we also proposed a patient safety rights charter, and we're working on a patient safety rights charter which is linked with the theme of this year. And in addition, we also are working on a couple of tools like WHO Patient Safety Storytelling Toolkit, Engaging Patients for Patient Safety Advocacy Brief, as well as the Patient Safety Rights Charter. And some other materials we have developed as part of technical series on safer primary care. We've also developed patient engagement as a monograph. So, very delighted to share with you how the world has been celebrating and participating in a global solidarity for World Patient Safety Day by lighting up monuments in orange. And just last week, I was reporting on this to the Steering Committee of World Patient Safety Day on how the day was observed this year. And I'm delighted to mention that there were several examples coming from Saudi Arabia as well, where several initiatives were taken on World Patient Safety Day and several important buildings lit up. But this is amazing when you see around the world, countries are lighting up monuments to demonstrate their commitment to patient safety. And baking up cakes. I mean, absolutely impressive. For the last 5 years, the Jet d'Or in Geneva has been lit up in orange as well, which is, again, demonstrate the commitment of all authorities, all stakeholders for patient safety. It's a huge global momentum created by World Patient Safety Day. So this is my last slide, and I was going through the program, and I saw there was a session on patient safety from vision to reality. And that really resonated in my mind in 2021 when UK government had the G7 presidency. WHO and the UK government together also organized an event bringing together the leadership of G7 countries on what they have done for patient safety. And the session was titled also Patient Safety from Vision to Reality. Because it is extremely important for now for us to see that creating vision is extremely important, but we have to walk the talk, we have to implement, we have to take action, and then we have to change the reality. And I truly believe that healthcare leaders have a very vital role to play in this. So the leaders have a role in realizing the global vision to improve the safety and in reducing avoidable harm, because they are central to actually prioritizing patient safety at every level. Healthcare leaders at every level, from facility to political leaders, to prioritize patient safety, to promote a safe and just culture which is dedicated to protecting patients from harm, and taking every opportunity, creating mechanisms to make healthcare safer in all settings and at all levels. And we need to build leadership capacity so that we can strengthen patient safety systems and develop a culture of safety and transparency, and also measure improvements and report improvements on that. So I look forward to working together with you to realize this vision, to make it a reality of zero harm in healthcare. Thank you so much for your attention. Happy to have your questions, which we will be taken in the panel discussion. Thank you.
Thank you very much, Dr. Neelam. Thank you for this presentation in sharing the steps that the World Patient Safety aims to achieve by 2030. And I would like to invite everyone to scan the barcode and write your questions, and the questions will be answered through the panel discussion. So take a moment to scan the barcode and writing your questions. أدعو الجميع أن يصور الباركود، يكتب السؤال راح ينتجاوب عليه في البانل ديسكشن بعد الكينوت سيشنز. Thank you. So for our next keynote speaker is Dr. Zakaria Al-Attal, and he will be presenting Moving from What We Know to What We Do, Actionable Change in Empowering Patients. Dr. Zakaria Al-Attal is a senior consultant for organizational development and international accreditation at the Ministry of Health UAE and the Director Quality at Emirates Health Services. Before joining MOH and Emirates Health Services UAE, Zakaria was the Director of Quality and Performance Management at Dubai Health Authority. He is recognized as a trainer and a certified professional in health quality, CPHQ, as well as a certified professional in patient safety by Institute of Healthcare Improvement, IHI. Dr. Zakaria trained more than 3,000 healthcare professionals on CPHQ and CPPS and other programs. Zakaria works as an independent consultant with the Joint Commission International since 2006. Welcome, Dr. Zakaria, for your presentation.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. Thank you very much for the team in the organizing committee and the leaders of the Saudi Patient Safety Center. And thank you for being here to attend my presentation. My presentation is matching very well with the theme of the conference, is From Awareness to Action. And that is really something very interesting, and congratulate you for selecting this theme for this conference this year. These are the things that I'm going to share with you. I'll focus about our experience in Emirates Health Services in UAE, about how we make things happen when it comes to patient empowerment and patient safety in general, and we have some specific components in relation to the model that we follow, and we are going to talk about some of take-home messages. So moving from what we know to what we do, the ideal situation is to have what we believe happen in the workplace. People, they want evidence to believe in what we say and what we imagine. And it's very critical to bridge the gap between how work is imagined and how work is implemented in the real life scenarios at healthcare services. And I do believe that the secret always is in the execution. and the excellence is in the execution. Strategies, themes, plans, all are available. I can call them as commodities. We can have them at any point of time, but the art is how we make things happen in an appropriate way, relevant to what we do every day in our healthcare organization. So I will emphasize on what our leader from WHO talk, do no harm. So I'm sharing this with you. It's not a surprise. Maybe all of you went through this report. And this is from the National Health Services in UK. They have a very good program about transparency and sharing the never events reports on an annual basis with the public. It's not a surprise to see these things still happening in good hospitals in some of the good countries around the world. NHS is one of highly ranked systems, healthcare systems by WHO when it comes to access to care, continuity of care. And honestly, it's one of maybe the largest healthcare system in the world with more than 1 million employees working there. Still, we have so many serious events happening. And the surprising thing, when you do nephrectomy on the wrong side, or when you do eye surgery on the wrong side, or when you do a surgery on the wrong patient when he is not in need for that surgery, is still happening in our era with all technology and all what we do. The same scenario is happening also in the US. This is Joint Commission report in 2022. Similar things, not surprising, unfortunately. And always we talk about zero harm. And I do believe zero harm is in the hands of all of us. I don't mean that it's our accountability and responsibility to achieve it tomorrow, but it's about keep striving and working for it and consider it as our vision to achieve. Especially when things, as we always say, things are doable and preventable. There are certain things embedded in the healthcare system maybe we cannot avoid. This is another report which is supporting the same concept. The president of the US, of course, has a lot of consultants around him and some group of consultants providing a report about patient safety on an annual basis. The same thing in this report, 1/4 of every American patient admitted to healthcare system, there is a possibility to get harmed there. And the report is really very helpful, very informative. I like two things about the recommendation. One recommendation is about promoting the just culture, and the other important recommendation is about empowering patients, which is our title of this presentation and discussion. And the report talking about patients are the most interesting people to improve patient safety because it's about them. It's about their lives, it's about their souls and their minds and their hearts. So 1 out of 4 hospitalized people in the United States, they get harmed, and 1/3 of these harmed are really serious, either serious adverse event or a sentinel event. This is a driver for all of us. It's about from awareness to action. Allah subhanahu wa ta'ala da'ana innu alladhina amanu wa amilu. So if we don't act on what we believe, if we don't work together and to make what we believe in action, still, I don't think we can achieve what we want to do. People in quarters, in corporate levels, in central departments of different systems, like our systems, we develop policies. We decide about how we want the healthcare services to be implemented. We design the work for physicians, nurses, technicians, how to do it. And maybe not necessarily we involve them in this process. And we face a lot of challenges about making them happen. But still, I say execution is the secret. It's about the important thing where we can achieve the goals that we are looking for. And I see that all healthcare providers are really blessed and fortunate because they are working on saving lives of people. So the slides of reports about patient safety harm that we have seen in NHS system, in US, and in different countries around the world give us the opportunity that we can contribute. nurses in the triage area in the ICU, physicians in the operation theater, if they do things right every time, regardless is it in the weekend or in the night, is it in a crowding situation, it's a panicking situation, but always focus on patient care. A lot of healthcare providers, those who participated in root cause analysis and interviewed when sentinel event happens, they admitted that we could avoid it if we did the right thing. So it's very critical for all of us to spread this message and to start from ourselves, that if you save one life, you are really saving all the mankind's life. These people are individuals with families, with kids. Maybe they are kids as well. They are wives, husbands. And for us, sometimes, unfortunately, we see them as next patients in the row, or their diagnosis, or we add them to our logbook. But they are humans with their families. Some of them, some of the family members, they got some mental diseases because of harm of one of their loved members of the family. And that happens in our hospitals, where they come in the first place for healing and for treatment. But unfortunately, we get harm them. So involving them in the care is really critical. I just want to share with you this very simple scenario. Maybe happens every day in our hospitals. Mr. Mubarak received a call from Customer Happiness Department through a telephone. It received a call or a message that his 9 a.m. appointment of the cardiology clinic with Dr. Yasser is modified to be at 11 a.m. with Dr. Azhar. It was the time 8:35, and Mr. Mubarak was in his way to the hospital. I don't know if you agree with me, that happens in most of healthcare systems around the world. Mr. Mubarak, this is the real story, and he told me about this story when we were talking about improving our appointment system. And when we interviewed the staff said, we informed the patient. Are you serious? So the patient already, and when we interviewed Mr. Mubarak, he said, I took off that day from work, and the appointment was for me and for other 2 kids in my family, so they were absent from school that day, and we were very close to the hospital to catch our appointment. So this is how we take decision on behalf of patients, and we think from our side that we are doing the right thing by informing them through SMS. It's another scenario. The data of compliance with the implementing the clinical practice guidelines never met the agreed upon targets. The medical director of the hospital sent an email followed by a written circular on the importance of all medical staff to strictly follow the approved clinical practice guideline. Why I'm sharing these 2 scenarios, I'm sharing them with you to talk about the execution, the implementation. We think by this way, we did our assignment, we did our responsibility. Do you think somebody in the leadership position to send a circular or a message through an email to people to do 1, 2, 3? I'm not sure that is the best way to do things in hospitals. So moving from what we know to what we do, actionable change in empowering patients in our organization. I work for EHS, Emirates Health Services, which is the execution or the healthcare delivery part of the Ministry of Health in United Arab Emirates. I'm sorry for the adjustment after we send the presentation. So maybe, anyway, I hope I will be able to cover the components. So our model is about utilizing the dictate from the government about patient empowerment. You will be surprised that the government of UAE focused on empowering customers in general, including patients. The board of EHS, they are involved, the executive committee at the leadership level, line managers, and frontline staff in the organization, including patients and family. We believe they should be part of course, this model. So this is from the government of UAE. This is the model which is developed by the UAE government, talking about a global star rating system for service, for customer service, including healthcare organization. When they ask us to implement this with this 8-pillar, 35 sub-pillars, 233 criteria related to service in general, we told them we are different. We are unique industry. We are healthcare. We deal with patients. It is different. But that has to be implemented across the government department. So we took it. We don't have any other option. So we found that two main criteria are very much related to what we do. One of them is customer focus, and the other one is customer experience. And the other components talking about the infrastructure, how to make it happen. But when it comes to customer focus and customer experience, when we read into the criteria and the details, we found that it is very much supporting the patient empowerment and the patient engagement. We took it and we start working on it with different terminology, different concepts. We tried many times to talk to the assessors that we are really unique and different. They said, why you are different? We said our patients, they come with different expectations. They are in pain. How we talk about happiness. They said, what about, the police department? They should be part of this. Their customers, sometimes they are in the jail, and they need also to make sure that they meet their expectations. So the criteria has to be implemented across the country. And in the first cycle, we achieved 76%, and the target was 80%. We were not really doing what it's supposed to be done. So the leadership asked us to review the whole process, and they got involved. And we believe the leaders of EHS and the leaders everywhere, it's about influence. It's about influencing people, move the vision. It's about giving a role model of discipline for others. We were asked to have immediate meetings. Immediately, it was weekend. So we start working together on improving all the points. And one of very important components where we need to improve is about empowering patient in the service. We thought that healthcare providers, again, at the end of the day, they are the decision maker about patients' care in general. But the model here asks us to empower the patient more, involve them more in the care. And we found it from our point of view is really very good motivating approach to engage patient more and more. We found that motivation of the leadership to the staff is very critical, but the most important thing is the role model from discipline point of view of the leadership, those who put the direction and put the vision for us to follow. So we start doing the root cause analysis, and we start using the fishbone, different tools to understand why we were not able to achieve the target of the government and empower our patients and get them more engaged in the care. So we use this model of iceberg. We start, asking questions about what we know about what we do, what we don't know, and it is possible to be known. And there are maybe certain things where still we don't know, and we don't know that we don't know them. So we keep the room open for any idea. There is no wrong idea when we start our process of the root cause analysis of the situation, why patient empowerment is not achieved as expected by the government, and we went through the whole process. We found that some doctors, they said this is not the business of the patients. And we found also the other extreme, that we are busy in doing some more important thing. This is what some healthcare providers told us. So it's about not only just the action and the implementation, but also it's about the belief, and it's about the mindset. It's about how they believe about it, that patients is really, they are critical and they are very important component of the process. So again, the leadership, they got engaged in the process. So our Director General meet with us and ask about the details. And the interesting thing from the government, we receive a report on daily basis. So it's actually a live dashboard. You can access every comment from customers of our 17 hospitals and around 100 primary healthcare centers and specialized centers. For example, if someone received the message like the example I shared with you that your appointment is canceled, he has the right to comment immediately. This comment can be accessed by 11,000 staff in the organization, including the Director General. On daily basis, we get report about our average of performance of those who participate in the process. So the leadership, the Director General, the Executive Committee, and the line managers, all of them, they got involved. So everybody, for example, if we have a primary healthcare center in Sharjah or in Ras Al Khaimah or Fujairah, the director of that center get the data related to his center, and he tried to communicate immediately on daily basis with the customers, those who give this feedback, when it comes to their comments and their experience about the service they went through. We always share with the staff why. We started actually a weekly meeting on a Friday morning. We work on a Friday, so between 8 to 8:30, it's a meeting just only to discuss the report. Still, it's going. So it's now close to 1 year. We meet every week, regardless to the occasion. So between 8 to 8:30, we discuss the report with all directors of hospitals and centers. We give them feedback. We follow up with them, and we keep listening for things that we think it's not appropriate. The problem is the expectations of patients is increasing with these reports. They are really empowered, and some patients, they misuse it. Other patients, they are very fair about the comments. Some patients, they told us, if you don't give me what I really want, I will write in the system called MARSAD. I will write in the MARSAD about you. So patients, they are aware about it, and they talk about it. And so there is some areas where we have to involve leaders of the community catchment area of different hospitals and centers to balance between, the purpose of the system and how we utilize the system in a proper way. Keep improving is very important concept for us. So we believe that, consistency and keep doing the right thing is the key factor. So success has 1% of luck, maybe 2% has to do with competency, 20% of team player. This is one of debatable statement, but the rest of achieving the rest of the percentage to achieve the performance is keep doing the right thing. Consistency is the secret. Not to get fed up, but always believe that tomorrow is much better. So I have a passion that if we don't achieve it all about patient safety, but at least we can start with different functions to achieve zero harm. So we hear in between, colleagues and leaders in patient safety, they say it's impossible. I do believe that preventable harm is possible. And it's about us. If we have the will, we have the way. If we have the passion, we can achieve it. And we are going to start next year in our organization small objectives of achieving zero harm for certain avoidable, preventable sentinel events. For example, harm related to fall. So this is our challenge. We are going to challenge 17 hospitals to achieve that about fall. And we have a reason why we selected fall, for example. So self-awareness, we increase the awareness among staff, because when we did the root cause analysis, we found some of the staff, they believe that this is not really, realistic. I need to focus on the surgery. I need to focus on the consultation, writing the medication. Involving the patient is maybe not the priority. When I have time, I will do it. When I don't have time, maybe it's not a priority. So it's about the empathy with patients, it's about the courage of the staff, it's about respect, and it's about the knowledge why it is important to involve patients and their family in the care and empower them in the care, which will have impact, of course, on the outcome of care, and one of my slides talk about that. So people is really critical, and here we talk about our staff. We got them involved in the process, and people, it's about having high caliber individuals in the organization, those who can make the difference. Whatever you want to do, the theme of this conference is about action. Those who can make the action are not really the leaders in their offices, but the people in the front line. So having the high caliber individuals is really critical job of the leaders, and I do believe that the best thing leader can do in any organization is to have the high caliber individuals in their positions. So high caliber individual in the ICU, in the human resource, in the material management, in the purchasing department, in the customer happiness department, and in all departments in the hospital. Keep following up about what people should do. So if the line manager in his position, we need to make sure that he or she, they are really doing what they're supposed to do. Link that with performance, and that's really important. So we need to link the, the reward, everything with the performance of individuals, and that has to do with the motivation and has to do with, the nature of the human. Discipline is really critical, and this is one of the success factors for any organization. When you have people disciplined about what they do, then the outcome will appear and will arise, and it will happen in the organization. We have a second victim program as well for people to take care of them and their well-being if there is something happening in the organization and they got affected psychologically or, even socially, or the perception about what they do in the organization. We do believe that keep people informed, keep them interested, and keep them informed about what's happening in the organization. So people, it's about, dealing with them very well. It's not just only about training them, because if you train them, maybe they will leave, but if you, take care of them and deal with them very well, they will stay. This is Richard Branson. He's the CEO of Vision Airline in UK. And Steve said, it doesn't make sense to hire smart people and tell them what to do. They are smart, they are qualified, empower them. And this is something where we do believe always. We use the concept of design about the patient empowerment in our organization. So we develop our policies. We develop our medical record to involve the patient in the care. We mandate certain requirements in the clinic and in the hospital and in every transaction with patients and any of the healthcare providers to mandate that healthcare providers are going to empower patients and involve them in the care. And I will share with you some of the examples. As you know, Deming, one of the, maybe he's the gurus, one of the most important gurus in quality management. And he is the person who always believes that system design is the critical success factor for any healthcare for any organization in general, and of course healthcare is involved. So if you design things to make it easy for people to do the right thing and make it difficult for them to do the wrong thing, that will be very helpful. It's not about taking the autonomy of the clinician, but it's about helping them to do the right thing in the organization. And maybe at that time of Deming, we were not talking about the high reliability organization, but Deming is a person who believes in that philosophy since a long time when he focused indirectly about the concept of, business is always preoccupied of failure. In a high reliability organization, we believe that complex system, you cannot simplify it. Always you need to think about where we may go wrong. So that's why to design it in advance to be safe. So we also believe when we did this process that organization is not just only about achieving the goal and the vision of the organization, but also it's about achieving the individual goal of our individuals, because this is a common question. We are human. What is in it for me? So we use a lot of programs to encourage staff, rewards, appreciation. In our weekly meeting, the Director General appreciates those who achieve higher in their dashboard, in their score. So the culture, we found it's very helpful, and it is very much affected with the leader of specific center and hospitals. So we found that there are hospitals, they are much better in their empowerment with patients and engagement because of the leader of that hospital, because of the CEO of that hospital. So hospitals, maybe when it comes to infrastructure of the hospitals around the world, they are the same. But it's about, when you enter this hospital, you can feel or smell or taste that this hospital is different. And the main important factor of the culture of the organization is the leader. So this is one of the initiatives we promoted in our organization. We call it Hermes initiative. It is a simple initiative where we promote patient engagement. We ask patients to focus on their rights, and after they leave the clinic, we ask them questions about if the doctor introduced himself to you and greeted you. Number two, if the physician tells you what's wrong with you. And number three, if the physician told you what you need to do about it. And then number four, why. And number five, if the physician give you the opportunity to ask questions. We found it very helpful. And, we have long way to do it. We train people. We get a lot of resistance in the beginning, but then we found doctors really doing it right. We started in 2017 with 68%, people, those who follow this guidelines or this approach, and last year the measure was close to 100, which we believe is something very important about patient empowerment and patient involvement. We develop patient and family advisory council in the organization across the EHS system. 60% of the members are from patients. They participate. Some of them are with determinants, أصحاب الهمم بنسميهم. Some of them students, some of them young people, leaders in the community, and they actually came of a lot of good ideas for us to improve in our organization, and we found it very helpful. It improved transparency. They start to understand what we do, the complexity of healthcare. They used to do round with us in between. We meet with them quarterly, but in between, when we have any situation, we need consultation from them, we get them involved in the process. We found it very helpful, and for hospitals, those who don't implement this, we really encourage you to do. It has some challenges. The expectations of people will increase, which is fine, but it is very helpful when you talk about it. These are some of examples where we involve them. So they want to expand in their parking, waiting area, Arabic, English language, so they prefer certain language. Of course, they prefer Arabic language, male, female issue, explanation, and so on. Some of them, they prefer digital access to appointment system, to their results, to the medical records. Some, they still prefer manual. So we need to accommodate all of these needs. And then the results again. So this is from the government, very influential. It is announced by the Prime Minister about hospitals, about government department, what they achieved. This is the global star, 7-star system, they call it. So our organization, we achieved 10 hospitals, those who participated in the process. 8 of them, they achieved 4-star, one of them 5-star, and one of them 3-star. The one with the 3-star has to do action plan, so now we are working on that to improve. We learn from the hospital, those who achieved 5 stars, why they could achieve that, so we learn from each other, and we found it very helpful. So after the 3-star concept, we met with the Patient and Family Advisory Council in that catchment area of the hospital. They felt sad, and they said it's shared experience, so want to improve, so they start working with us. So many expectations they share with us. Some of the expectations we don't see it appropriate. Some of them, they, for example, they prefer, for example, one hospital is 15 minutes away from their hospital. They don't prefer to go to that hospital. They want all the specialties to be in their hospital. So we need to spend some time with them about, the concept of healthcare system rather than to have all the specialties in one community-based hospital, etc. So we found it very helpful. I got the notice that I need to close my presentation. So we found that empowering patient is very helpful. At least we understand that they are part of the process. The outcome improve. We don't decide on their behalf. We ask them what they really want from us, and that will be very helpful. We focus on the health literacy concept. A lot of our doctors, they speak to patients in the language of doctors. Not necessarily it is understood by patients. We are not talking here about using the Arabic language which the patient speaks, but we talk about using appropriate terminology which can be interpreted in appropriate way by patients, and they can really utilize it to do the right thing which is expected from them, and we have so many examples related to that. We empower them through different applications to choose their doctor, to choose their appointment, timing, to access their medical record, to access their result. And as I mentioned yesterday, we have a national-wide Riayati medical record where patients, they enjoy accessing the medical record. Still some patients, they don't prefer digital. They like to use the manual thing, which is, we totally understand. We offer the e-clinic, we call it, where we use it if the patient meet a criteria. Some patients, they are okay with that. Some patients, they are not, and we need to accommodate that as well. This is one of the examples where we start using the vaccines based on patients' preference. They don't want to come to the clinic. They want to have it while they are in the car, drive-through vaccine. So we do that. We found it helpful because through this, no need for parking, no need to go to the clinic, no need for waiting area, and no need to spend some time waiting to see the doctor. So that, save a lot of steps and a lot of process. So dreams without goals, they are just dreams. If you start without consistency, you will never finish. So it's really very critical to continue in this process. Our next steps is to have patients attending our executive committees in hospitals, and that's going to start in 2024. We want to have them also part of reporting incidents as well, not only complaints. So we are looking at the visibility of making that happen, participating in the root cause analysis process, and promoting fair disclosure, which is we have challenges still about it. So this is our future plan. This is my Francis, and thank you for listening to me. I will be happy to take questions in the panel discussion if you have.
Thank you, Dr. Zakaria, for this presentation that sums up what we all need to know and do to change patient empowerment and improve patient empowerment. As all of us have heard from the Prince Faisal bin Mish'al yesterday, we can't stress enough the burden and what are the solutions to diagnostic errors, how important it is. So Dr. Peter Anton Najjar will present us the third keynote session of the day about diagnostic safety. Dr. Najjar is the Medical Director of Clinical Operation for Johns Hopkins Medicine's Armstrong Institute for Patient Safety and Quality, responsible for system-wide operational oversight, program building, and clinical innovation. He is also the Assistant Professor of Surgery in Ravitch Division of Colorectal Surgery at Johns Hopkins Hospital, specializing in complex robotic colorectal surgery. He completed his surgical training at Harvard's Brigham and Women's Hospital Dana-Farber. Where he also completed the Harvard Medical School Fellowship in Patient Safety and Quality, served as a senior quality consultant. Please join me in welcoming Dr. Peter.
Perfect. Thank you very much. It's a pleasure to be here and an honor to be invited to speak with you all today about diagnostic safety and the burdens and challenges that it poses in our ability to care for patients. I work at the Armstrong Institute at Johns Hopkins Hospital, and so we oversee 6 hospitals across the eastern coast of the United States. And we have a Center for Diagnostic Excellence who's led by a colleague of mine, Dr. David Newman-Toker, who spends essentially all of his time thinking through how to help us improve the care of patients with respect to diagnosis, which is oftentimes underappreciated in terms of the impact it has on outcomes. So this is what we'll talk about today. It's an ambitious agenda to go through in a half hour. But we'll talk about the burden and the impact. We'll define what misdiagnosis and diagnostic-related harms are. We'll talk about some common causes, some proposed solutions, and then summarize our key takeaways. But I'd like to first start with a story, and this is a true story that's shared with permission of the patient and his family. This is a patient of Dr. Newman-Toker's who is a stroke neurologist at Johns Hopkins. The patient's name is John Michael Knight, and he was a superstar 18-year-old lacrosse player. He ended up presenting to the emergency department with dizziness, vertigo, unsteady walking, and a general sense that the room was spinning a couple of days after the last game that he played in high school. And he's a star athlete, very, very healthy, and his patients are very, very worried. He's never been sick like this before. He's never really been to the emergency department. And so they let the doctors know. But the chief complaint is really just dizziness, a little bit of room spinning. And so the doctors kind of dismiss the most severe potential scenarios that are going on here. And they reassure the family that there's, I think we lost our slides here. Can we get the slides back up? Great, thank you. Much better looking than I am. So the doctors, they don't listen to the parents, and they haven't considered a really key potential cause of dizziness in young and healthy patients because they're not specialists and they haven't looked at the signs. And that underlying cause is a brainstem stroke from the occlusion of one of the main arteries that feeds the base of the brain. And when that artery gets blocked, there's no blood flow to the brain, and it can result in dizziness as a very, very early symptom. And unfortunately, if that stroke is not diagnosed, it can become extremely damaging to the patient. And in Michael's case, it resulted in what we call locked-in syndrome. So it resulted in this star 18-year-old high school athlete being quadriplegic, confined to a chair, unable to speak, and only really able to communicate by moving his eyes and blinking. So this is a really devastating consequence of misdiagnosis, but unfortunately, this exact scenario or scenarios very similar to it happen virtually every day across the world, and it's underappreciated because our systems of detecting and preventing harm are generally biased towards treatment-related harm. That is, did we do what we said we were going to do safely for the patient? And they're less tuned to detect diagnostic harms. That is, was the treatment that we even prescribed, regardless of whether it was error-free, appropriate, and did we make the right diagnosis? And so I just want you to keep that story in your mind as we kind of go through this, and what I'll try to do is talk about the high-level sort of theoretical system changes that we need to pursue, but then link them back to this base case because I think it's critical to really understand what it means on a practical level. And so we'll use dizziness and stroke as a model concept, and the idea is that it's a clinical symptom that's too commonly due to stroke to ignore. A significant percentage of patients who present with dizziness are going to have an underlying stroke, but it's too common to get an MRI on every single patient. The bedside findings are a little unfamiliar to most clinicians. Most clinicians don't feel comfortable working up dizziness and diagnosing stroke. And there are too few subspecialists who specialize in stroke diagnostics or dizziness diagnostics to be able to consult on all patients. And so the underlying problem of this base case, which translates to a lot of diagnostic-related harm, is one of translation from bedside, an individual expert at the bedside, to an entire population. That's a big challenge. To generate scalable safety solutions, and then be able to implement them reliably and effectively at scale to move the needle reliably on public health and be able to impact the population at large. And so let's spend a little bit of time talking about the burden here and the impact it has on patients. And so the National Academy of Medicine released this report in 2015 around improving diagnosis in healthcare. And really diagnostic excellence, I think, is sort of 5 to 10 years behind treatment-related harm with respect to our level of public awareness and the interventions that we're putting into place around it. So this was a really seminal report. Some key quotes from this report are that one is the delivery of healthcare has proceeded for decades with a blind spot, diagnostic errors. Most people will experience at least one diagnostic error in their lifetime, sometimes with devastating consequences. And improving the diagnostic process is not only possible, but it also represents a moral, professional, and public health imperative. We can't have high school athletes like John Michael Knight suffer the diagnostic harms that he suffered. And so when we look at the overall prevalence of diagnostic error, and of course these are difficult estimates to make and they're contested in much the same way that the error-related harms are contested. But a recent study that actually just came out as a landmark study just a few months ago in BMJ Quality and Safety that came out of our diagnostic excellence team at the Armstrong Institute suggests that in the US alone, there are likely 50 million diagnostic errors a year. About 1% of those likely lead to serious harm, so that's about 500,000 to 1 million serious diagnostic harm-related events per year, and that the estimated societal cost is about $100 billion a year, and that's just for the United States alone. We lack very reliable estimates globally, but there's no reason to expect that these numbers will be different across the world. And when we look at all other errors combined, that is treatment-related errors, they're really dwarfed in comparison to diagnostic errors. They're much smaller. So diagnostic errors are the most common, the most catastrophic, and the most costly sort of errors. Because following a diagnostic error, all treatment related to the misdiagnosis is in and of itself harm. If you have the wrong diagnosis, then you can do everything right. You can proceed to the operating room and execute a flawless surgical procedure and protect the patient from blood clots and surgical site infections. And all of that care is harm because the diagnosis was incorrect at the outset of treatment. And that's what's responsible for this massive impact that we believe diagnostic errors has on our patient populations. So it's really the tip of the iceberg. When we seek to understand what the main drivers of diagnostic error are, we land in three broad categories. We call these the big three. And that is vascular events, strokes being chief amongst them, infection-related diagnostic errors, chief amongst them being recognition and diagnosis and prompt treatment of sepsis, and cancer-related harms, delays or misdiagnoses of cancers that then delay treatment and result in cancers that would otherwise be readily treatable being diagnosed at the later stage when treatments are much less effective. And these big three causes of serious harm account for about 75% of the harm in both malpractice claims in the US medical legal system and also in clinical studies of diagnostic-related error. And diagnostic error is really sort of unique in that there are no real global solutions. And so it really is important to understand the details of the individual conditions that result in diagnostic harm or create the risk of diagnostic error. And so when we look at the little bit more detail here on the harms, again, we see those big three are represented. 34% of diagnostic-related harms are infection-related, about 30% vascular, 13% cancer, and the remaining 1 in 4 diagnostic harms are not part of those big three. These are data from about 2014 in the US, so they're probably underestimates for 2023. These harms are probably not decreasing, but rather increasing. And so when we get into the specifics of these big three, we see these categories, and none of these should present, surprises here, especially to the clinicians in the audience. For vascular, it's stroke, venous thromboembolism, arterial thromboembolism, aortic aneurysm and dissection, and myocardial infarction or heart attacks. For infection, that's sepsis, which I think we're all very aware of, but also pneumonia, meningitis, spinal abscesses, which are notoriously difficult to diagnose, especially for non-specialists, and endocarditis, infection of the heart valves. And for cancer, it tracks roughly with the prevalence of cancers in the general population, and so the most common cancers tend to produce the most misdiagnoses, which is intuitive, but lung, breast, colorectal, melanoma, and prostate cancer. And as a practicing colon and rectal surgeon who deals with colon and rectal cancer, I can tell you that early diagnosis of colorectal cancer in my patients, anecdotally in the clinic, it makes a world of difference. Those patients who come and see me because they had an appropriately timed screening colonoscopy and they have a stage 1 or stage 2 cancer, I can do a 2-hour operation on them. They're home within 48 hours and they're cured, and long-term survival rates are over 90%. For patients with stage 4 cancer, long-term survival rates drop to about 15%, and they require not only surgery, but also chemo and radiation therapy, which is hugely expensive, hugely impactful on their life, and treatment ends up taking 4 to 6 months instead of 4 to 6 days, which is the case for early colorectal cancer that's surgically treatable. And so relating this back to the base case of that missed stroke, we see that stroke itself is the #1 harm across all clinical settings, and it's particularly important in emergency departments. The most commonly missed vascular diagnosis here is stroke, and it's significantly more likely to be missed than heart attack, about 10 times more likely. And we likely miss about 200,000 strokes a year, and we likely harm about 100,000 people because of that. Luckily, a certain percentage of people with missed strokes will seek care later, but still be able to be treated appropriately, and they won't suffer a harm. But a significant percentage of patients who have a misdiagnosis will suffer harm because of that misdiagnosis. And what's critical to note here, and it's true in stroke and it's true in virtually all of the other disease processes, is that the risk of diagnosis-related errors rises with atypical presentation. That is, when patients present with symptoms that are a little bit different than what we see in the textbook. So when it's a wrong patient group, for example, when it's a young patient as opposed to an old patient who's presenting with stroke symptoms, the risk of misdiagnosis increases. When the symptoms are milder, for example, when there's dizziness as opposed to hemiplegia or facial drooping, that's a very obvious symptom, the risk of misdiagnosis increases. When the symptoms are transient, that is, they come and go in the form of a transient ischemic attack versus persistent, the risk of misdiagnosis increases. And when the symptoms are non-specific and non-localizing, as is the case with our example scenario here, like dizziness as opposed to a localizing neurological lesion, the risk increases. So when you look at all of these sorts of odds ratios and you calculate the likelihood of a diagnostic error in our initial patient, in the young, healthy 18-year-old lacrosse player, he fell into almost all of these buckets. And given that, we can calculate that our base case, John Michael Knight, had a 95% chance of being misdiagnosed in an average emergency department with that constellation of symptoms, with an underlying brainstem stroke in a young and healthy patient with an atypical presentation. And so there's a lot of work to be done here. There are very few treatment-related harms where we would expect a 95% failure rate with any subgroup. And so the fact that there are subgroups in whom we have a 95% expected error rate with known disease presentations kind of pushes us towards action. So a couple of core definitions here. Diagnostic error in and of itself is the failure to establish a timely and accurate explanation of the patient's health problems. And then critically, and as it relates to the earlier talk, the importance of also then communicating that diagnosis to the patient in a way that they can understand so that they receive appropriate follow-up care. And so both of these things have to occur with a critical diagnosis. And the failure to make that diagnosis in a timely fashion or to communicate that diagnosis appropriately to the patient and their family is a significant source of harm, and we classify those as diagnostic errors. A couple of subcategories here. A missed opportunity, we call that a failure to make a correct or timely diagnosis resulting from a preventable process failure. And so that does not necessitate that harm reaches the patient. The patient might not be harmed, but rather we missed an opportunity to make care more efficient, more safe, and more convenient for the patient and their family. And then, of course, a misdiagnosis-related harm is harm that results from a diagnostic error. So virtually all diagnostic errors can fall into these two categories, either a missed opportunity, if we're lucky. We spent some more time and resources than were necessary, but we eventually made the right diagnosis, communicated to the patient, and the patient received the appropriate treatment without significant harm, or a misdiagnosis-related harm where that failure to diagnose resulted in harm to the patient or their family. So, what are the causes? And I don't necessarily mean the diseases here, but what are the underlying sort of challenges in our healthcare system and the way that we function as individual providers that lead us to make these sorts of errors? And when we survey the population, we investigate these diagnosis-related harm, the most common source is clinical judgment. And this is a really challenging problem to solve because clinical judgment really kind of takes a lot of things into account. But in contrast to a lot of our other sort of treatment-related harms, where we think about systemic approaches and sort of reducing the risk of error. Here, if the initial clinical judgment is off, it's very, very difficult to rescue that with systems approaches. And so that's why diagnostic-related harms are so unique and present such a unique sort of area of work where we have to think in different ways about addressing this when the underlying source of the harm is clinical judgment. So a couple of perhaps intuitive statements or obvious statements. That is that obviousness predicts correct diagnosis. So when patients present with very, very classical symptoms that are right out of a textbook, we're much, much less likely to misdiagnose them. And then, of course, the other side of that coin is that subtlety predicts incorrect diagnoses. So when there's a very rare disease that's not very common and folks aren't very familiar with, when the degree of difficulty is high, and when the training background, knowledge, familiarity, and expertise of the diagnosing provider is low, the risk of misdiagnosis rises significantly. I don't know if this is out of batteries or... I can't advance the slide, sorry. Is there a... Oh, there we go. Great. So there are two dominant theories as to how we make these cognitive errors. And I'm going to make an argument to you today that one is the one that we should really focus on and is likely responsible for most of these kind of misconceptions, and we'll go into some detail about why that's the case. The first argument is the cognitive bias argument. And that's the idea that clinicians generally know what to do, but in the moment they sort of forget. And remedying cognitive biases would revolve around using checklists, timeouts, pauses, and just giving people time to think to increase the likelihood that they actually make the decision that they are well equipped to make. Expertise gaps imply something different. It implies that you could give a clinician all the time and kind of decisional aids and checklists in the world, but they simply lack the requisite knowledge that they need to make subtle diagnoses. And our argument really is that it's expertise gaps that are responsible for the bulk of diagnostic-related harms. And that has really profound implications for the types of interventions that we put into place here. Treatment-related harms are oftentimes driven by cognitive bias. We know what we should do in a particular situation, but we fail to do it, right? And that's where checklists, for example, become very, very helpful, right? It's a reminder to do what you should do every time. It's not that you don't know that you should do it, it's just that you're at risk of forgetting or lapsing or omitting a particular step. Whereas for diagnoses, it's really an expertise gap. And so the types of interventions are very, very different to reduce diagnostic-related harm. And we have a little bit of a framework out of our Center for Diagnostic Excellence, which is the 4 T's. That is team, train, tech, and tune, and we'll go through that. But first, a little bit of evidence in support of this idea that it's an expertise gap rather than cognitive bias that results in the majority of cognitive harm. The first, again, relating to our base case, is that specialists do better with difficult diagnoses than generalists. And this is perhaps an obvious statement, but it's important to quantify this. When we look at the number of days from presentation with dizziness and the likelihood that you were diagnosed with a stroke, what that implies is that if you were diagnosed with dizziness, sent home, and then came back 2, 3, 4, 5 days later and were diagnosed with a stroke, there was likely a diagnostic error at the time of your initial presentation. And we see that the dark line, where generalists, internal medicine, emergency doctors, family medicine doctors, there is a higher rate of being diagnosed with a stroke after presentation for dizziness or vertigo than there is if that initial presentation was with a specialty provider, an ENT or a neurologist with subspecialty expertise. So that's the first sort of case that expertise and content knowledge actually drives diagnostic error. Then drilling down on this further, specifically related to stroke, we administered a survey, a simple 10-question true-false sort of knowledge check for physicians. And we looked at the number of correct responses that they got. And these are non-neurologist, non-specialist clinicians. And these were relatively straightforward correct questions around stroke diagnostics in dizzy patients. And what we found is that the actual performance was worse than that would be predicted by chance. So what that means is if the actual performance were in the middle of the bell curve there, that's about a 50-50 response rate. It's a true false exam. So if you just picked randomly, you should get a 50% on this exam. But actually, the majority of providers scored lower than 50%. And this was reliable, which means that these providers weren't just rushing and making random errors. They actually had misconceptions, inappropriate ideas that they had learned about stroke diagnostics in dizzy patients. And then, of course, towards the higher end would be a normal would be understanding, and experts, when they take this exam, obviously do better than 50%. So this is really powerful evidence here that these aren't just lapses or sort of transient errors, but these are actually misconceptions in training. And we know that these are misconceptions in training because these same misconceptions, these physicians, they're dutifully studying what's in the textbooks. But in generalist textbooks, we see these kinds of misconceptions around stroke diagnostics and broadly in the medical literature. And so they are reproduced by clinicians in practice. And so it's perhaps not surprising that we see this kind of distribution where chance would predict better performance on subspecialty expertise. And so how do we solve these challenges? You know, if we agree that there's a significant risk here, and we agree also that those risks are driven by specific deficits in content knowledge and availability and information availability by generalists. And we agree also that we will not be able to provide subspecialty expertise in the form of a fellowship-trained physician to every single patient who is at risk of diagnostic error. You know, this is not meant to be a critique of generalists. Generalists have an extremely difficult job. They see a wide variety of diseases, and they have to make snap decisions and recognize potential high-harm diagnoses and atypical presentations from a massive patient population who present with all sorts of different diseases and challenges. And so we really have to kind of work with them to understand and prevent these sorts of errors. So this is how our failed processes work. We have cognitive and system failures resulting in a wrong or delayed diagnosis, resulting in wrong or delayed treatment and preventable patient harm. And this is our ideal state. We have a supportive system and culture where we help our generalists at the front lines and make correct, timely diagnoses, have correct, timely treatment, and I would say also error-free treatment and resulting in improved patient outcomes. And our 4 T's dictate the following interventions. 1 is training to develop experts. 2 is teamwork to provide support to experts on the front line that's guilt-free, kind of shame-free, so they can phone a friend. 3 is to bottle expertise, to use technology to deploy it more broadly. And 4 is tuning to monitor success to ensure that we're having the impact that we want to have on our patient populations. And so in the interest of time, I won't go through in great detail all of these, but just a word on each. For stroke diagnosis, we're developing a portable, what we call the eye-EKG, to help with our non-experts at the front line in doing stroke diagnostics using eye movement. We're training non-expert clinicians to perform these exams so that they have the requisite expertise necessary. We're using technology, even in the form of iPhone apps and portable eye EKG and video oculography to help deploy this expertise more broadly. And we're tracking our compliance. And you can see that improvement is possible because, for example, years ago we had this issue with myocardial infarction, but you can see that stroke diagnosis in the black line there, there's a significant increase, it's a significantly higher rate of misdiagnoses, whereas myocardial infarction, in the red down there, we've got significantly better performance because we've developed the tools, technologies, and training like cardiac enzymes, high sensitivity troponins, serial EKG, and very standardized myocardial infarction diagnosis and rule-out protocols, again, to aid the non-cardiologist expert at the front line in accurately diagnosing myocardial infarction. And we shouldn't take it for granted that those improvements were achieved with a great amount of effort and subspecialist knowledge and training. And so we just need to replicate those successes across all of the diagnostic categories that result in most harm for our patients. So I very much appreciate your time, and I'm happy to take questions during our panel later on. And thank you again for the opportunity to chat with you today.
Thank you very much, Dr. Peter, for sharing this information that paves the way for us in understanding how important it is to act quickly on diagnostic safety. I would like to remind everyone to scan the barcode for the questions in the panel discussion. And I would like to announce that we will have the break after the panel discussion. So we will continue to receive your questions in the barcode and answering them in the panel discussion. So let's take 20 seconds. Please scan the barcode. يلي تصورون الباركود وتكتبون أسئلتكم عشان نتجاوب عليها في الجلسة الحوارية. So everybody loves to hear a story, and our story today comes all the way from Somaliland, presented by Dr. Hamdi Mohammed Isa. Dr. Hamdi Isa is a freelance health consultant supporting projects in the field of global health, sexual reproductive health, health partnership, and quality care. She is a former director of community health services at the Ministry of Health Development in Somaliland, where she provides a technical and programmatic leadership to strengthen community health systems. She has previously led the design, implementation, and evaluation of the first national quality care and patient safety initiative in Somaliland. She is a member in the International Technical Advisory Group reviewing WHO's infection prevention control course material for low and middle income countries. She has held health policy, academic, and research role in both UK and Somaliland and published several papers in the space of mutual learning, international health partnership, and reserve innovation. She holds a PhD in global health and master's in public health, both from Imperial College. Please join me in welcoming Dr. Hamdi.
Assalamu alaikum wa rahmatullahi wa barakatuh. It's a pleasure being here today. I thank SPSC for inviting me. It's been really interesting for the last 2.5 days learning about the different experiences from different individuals and the countries that they're representing, and also firsthand receiving the Saudi hospitality. So I really appreciate that. As I was just introduced, my name is Hamdi Isa. I grew up in the UK. I am one of the African diaspora who's moved back to the continent to do some work back in my home country. So I relocated 4.5 years ago, where I was, as of last month, the Director of Community Health Services. And during my time there is where we started the first Quality Care and Patient Safety Initiative. So that's what I will be focusing this presentation on. So my presentation really will be about a background, a country context, to introduce some of you who are not familiar with Somaliland, the need, the project initiation, the what's, the hows, the who's, and the whys, some activities and achieved results, the challenges that we face, and the next steps. So this is a map of the Horn of Africa. At the top there, you will see Somaliland, bordered by Djibouti, Somalia, and Ethiopia. For those of you who don't know, following the 1991 civil war in Somalia, Somaliland separated. It is considered a de facto state, so it does not have UN recognition. But for the past 32 years, it's been functioning as its own country. And with the lack of international recognition, you can imagine the emphasis on resources and health and governance challenges that you would see in an already fragile state. To give you some demographics about Somaliland, so the population was estimated to be about 4.3 million in 2021. It is now estimated to be about 5 million. There isn't really a national census that happens generally, but that's the estimate. In terms of the age structure, we have a really young population. About 40% is under 15 years and 72% is under 30 years. And in terms of the health sector, 60% of the health sector is dominated by the private sector, which unfortunately falls outside of the control of much of the government governance. But in terms of the Ministry of Health, which is responsible for the public health sector, it's designed with sort of a 5-tier system. At the bottom is the community level, where you will have the female health worker interventions, for example. Then we have the PHU, the health center. The health center is where most of the primary level work takes place, really maternal and child health. Then we have the referral health centers, which for us is the district hospitals, then our regional hospitals and the national referral hospital. Just in terms of some key health indicators, Somaliland's maternal mortality, like much of sub-Saharan Africa, it is a huge challenge, but it has dropped drastically. We've seen improvements from 724 around 2015 to 396. The leading causes of maternal mortality are hemorrhage, sepsis, and eclampsia. Infant mortality rate, you can see shocking numbers, 72 deaths per 1,000. Neonatal mortality, 42 deaths per 1,000. And the leading causes of death are pneumonia, diarrhea, and malnutrition. So that really was just to provide a context of the country in which this quality care initiative that I will be talking about has taken place, and so you can familiarize yourself with it. So, what was the need? For the past 2 decades, Somaliland's healthcare sector reform has been focusing on access, and the country has done really well in increasing the number of health facilities, namely the health centers and the PHUs across the country. But during this era, it was very evident that quality care took a back seat, and the need for quality and patient safety reform across Somaliland is very evident. Like much fragile states, it is burdened by low-quality healthcare services, inadequate or unsafe clinical facilities, which increase the poor intractable health indices, a poor adherence to clinical guidelines. While there are numerous guidelines, all clinicians may not adhere to it in the same way. Hospital-acquired infections, mainly due to inadequate practices of IPC, and then a lack of accountability for safe care. So what we witnessed was an absence of a strong leadership culture that created and promoted a culture of accountability for healthcare. But more recently, with the evolution of the healthcare system and perhaps the external shocks to the system, such as the cyclic droughts, the COVID-19 pandemic, the aftermath of the Ukraine crisis, what we're starting to see that is quality has to be center stage in all healthcare systems, both high-income and low-middle-income country. And nationally, many departments across the ministry are recognizing the importance of ensuring that all health programs and health initiatives are centered around this quality agenda. So in 2020-2021, what we saw was a shift in the wording in our national strategies to be centered, and there was an acknowledgement of this quality term. However, there was an absence of a well-articulated common understanding of this term and what it's meant in practice. So through numerous conversations around a new approach to strengthening Somaliland's healthcare system, the Ministry of Health partnered with its long-term partners, King's Global Health Partnership, who have been working in Somaliland for the past 2 decades to start the first quality care patient safety initiative. During the proposal writing stage, we appreciated that there needed to be a partner that could offer some technical expertise, and that's where we drew on WHO, in particular the HQ team and the EMRO team. And in fact, Dr. Manda Latif, who is a friend of many of you here, led on a lot of the activities and support that we were receiving at the EMRO level. So the partnership was called UK Somaliland Partnership for Improving Quality Care. It lasted for about a year. So it was funded by the UK Department of Health and Social Care. Initially, we had a larger funding, but because of COVID-19, UK funding to overseas aids was reduced, so we had to work with a smaller pot of money. And then we decided to focus in one region out of the 6 regions in Somaliland. So that regional hospital based in that region became the lead partner. The ministry took the role of governance and ensuring that the initiative fell within the national priorities. KGHP was the lead UK partner, and as I said, WHO was our technical partner. So the targeted facilities were 8 facilities, 1 regional hospital and 7 health centers in 1 region. And this is just the logos of the different partners. So the Quality and Patient Safety Initiative in Somaliland was phased in sort of 5 different activities. And these activities sometimes happened sequentially and sometimes in parallel. And I will go in detail over these different activities in the next slides. The first one was a national capacity workshop and helping to deliver sort of this tailored webinar. There was this appreciation that not all Somaliland stakeholders had an understanding or a common understanding of quality care and what was needed to deliver quality care. So WHO Geneva colleagues supported us in delivering a 2-day workshop on WHO's approach to quality care, which focused on improving knowledge and understanding of health system leaders on quality care. Essentially, it was a quick crash course to ensure that when we started implementation on the ground, that all stakeholders were sort of familiar with the concept and it was not a shock to the system. And then our second activity was to complete a national situational analysis. This was really important to help us understand the quality care situation in Somaliland. Anecdotally, we had an understanding of where we were at, but this really offered for the first time capturing the evidence base of the quality care situation in Somaliland. So we recruited a national consultant to lead on this work, and it was really important for us that it was a national consultant because they had a better understanding of the nuances and the complexities of Somaliland's healthcare system. Now, whilst this project only focused in 1 region as a pilot, by supplementing it with a national situational analysis, we were able to bring about a national conversation on quality. The findings of this situational analysis was presented in a multi-stakeholder forum attended by WHO, KGHP, and Somaliland stakeholders. And what we found was that there was this appetite for tangible steps for improvement in quality care. It also highlighted a need for nationally endorsed quality standards and frameworks, alongside a need to develop standardized benchmarks to support facility-level quality improvement. It also revealed to us that the patient voice and any public feedback and mechanisms were missing from the healthcare system in Somaliland, and therefore it put into question the patient-centered approach to care. And the real highlight was the strong commitment across stakeholders, spearheaded by the Minister of Health, reiterating the commitment to improve quality and patient safety in Somaliland and the confidence that improvements are achievable. To gauge the quality of care situation in the target facilities, the 1 regional hospital and 7 health facilities, WHO EMRO supported us in hiring 2 consultants who were expert consultants supporting other countries in assessing and achieving their patient safety adequate indicators. The 2 consultants came to Somaliland and to provide facilities with a baseline to measure their improvement against a clear set of priorities to move towards patient safety. So when they arrived in December 2021, they worked with the project's focal point to visit all 8 health facilities, and using the WHO patient safety, EMRO patient safety friendly hospital initiative, they assessed the hospital. Using the WHO EMRO patient safety friendly primary care framework, they assessed the 7 health facilities. And the assessments identified several areas for improvement, including infection prevention control, medication management, safe use, emergency management systems. These findings were presented to the Ministry of Health, the hospital leadership team, and the regional leadership team. And the idea was that there would be space for the teams to identify 1 clinical area where we could target in this intervention to support. And following consultation, the regional teams and the hospital decided that infection prevention control was a running issue across the 8 health facilities, and that would be their area for priority intervention. So again, under this project, we hired another national consultant with expertise in IPC. The consultant was tasked to support the hospital management team and the district healthcare teams in establishing a systematic approach to improving IPC. This included a combination of clinical training, capacity building, and reform of any key activities. So the consultant started delivering trainings for healthcare staff responsible for establishing a safe environment. There was a localization of the training material. and guidelines with advice from volunteers and WHO colleagues. In particular, the training consciously incorporated cleaners to elevate their status and contribution in breaking the chain of infection at health facility level. And therefore, for the first time ever, the guidelines, the international guidelines, were adapted for an illiterate Somali-speaking cadre of professionals by using role plays and by using visuals. The consultant also helped establish an IPC committee for the hospital by developing some terms of reference and ensuring the leadership team nominated a committee, also developed IPC monitoring checklists for each hospital, developed SOPs so that they could be used around their different health facilities. We procured some items, color-coded cleaning equipment and waste management to support any infection prevention control activities. So the intervention really targeted different areas to ensure a holistic approach to improving IPC. And what we saw as an outcome of this package of activities designed to target IPC was that across the target facilities, 159 health workers and health leaders, of whom 109 were female, were trained and supported in quality improvement approaches and infection prevention control. Following the IPC training, of the cohorts that were immediately tested, 96 individuals, 100% of them showed an improvement in post-training tests, with an average increase in knowledge about 42%. An assessment of Boromo Regional Hospital showed that IPC had improved, where in 2020, the hospital was previously assessed against WHO's IPC-AF tool to measure IPC level, where it gained a score of 152.5 out of the minimum required 800 for a separate project. And then in May 2022, after the project intervention, when it was assessed again, the score had increased to 457, showing that the hospital had moved from an inadequate to an intermediate level based on WHO's IPC-AF. One final activity was a short course on quality improvement to supplement the hospital assessments and the training. Volunteers from South London Moseley NHS Foundation Trust and their quality improvement teams supported us in adapting their QI training sessions to 3 sessions. And the idea was here to teach quality improvement methodologies to frontline staff, but also to ensure that we were establishing a culture of learning rather than a culture of blame. We had 27 participants, of whom 13 were female. And the participants joined from several locations, including the ministry, the regional level, universities, so there was a mix of policymakers, academics, and clinical experts. As part of the course, participants did not only receive theoretical knowledge, they were also invited to engage in some practical hands-on experiences of implementing a quality care strategy. They were asked to identify 2 quality improvement projects in their setting, and volunteers were available online remotely to support these interventions. The colleagues worked in 2 teams, and the 2 projects that they worked on were strengthening IPC and improving medication errors. So for us, this was a very successful initial pilot project, but of course we came across some challenges. There were a number of challenges noted from the situational analysis and also from the implementation stage. And to ensure that this wider quality care initiative is actionable in Somaliland, we really need to get ahead of some of these challenges in order to drive the national priorities. First, there was this lack of common understanding or definition for quality care, which makes it really hard to implement any patient safety initiative if we don't have this foundational understanding of what it means in practice. Second, there was this evident absence of a national policy quality care strategy guiding the national priorities for quality care. Third, there was an absence of mechanisms that capture the patient's voice and the patient's experiences. And there was lack of standardized benchmarks, which is probably an outcome of having a lack of a strategy or a national priority set for patient safety. And then there's this weak relationship between the public and private sector. And if Somaliland is to strengthen its patient safety initiative across the country, then there needs to be a stronger collaboration, given that 60% of the health facilities fall under the private sector. And of course, there is this pervasive human resources for health crisis, which is affecting the number of health professionals that are adequately trained in quality improvement and patient safety. So as a way forward and as immediate next step, the project team worked together to write a new proposal where we have, the ministry has received funding from Qatar Charity to do a 2-year project on quality care and patient safety. This project will include the development of the first national quality and patient safety strategy for Somaliland. It will strengthen government capacity to lead and oversee quality in the health system by training middle management and senior management in quality improvement methodologies. It will involve training for all 6 regional hospitals, whereas before we only focused on 1. And the project has the objective to capture the patient voice and the family voice by piloting the People's Voice Survey, which is a telephone-based survey designed by Harvard University. This is a very ambitious project, and its scope is much larger than the initial phase. A, because there are more resources available, but B, because there is now a better understanding of the different levels that require support to meet Somaliland's ambition for better quality and improved patient safety. And it is designed with the sustainability elements at mind so that the efforts and activities can exist beyond the lifetime of this project. For example, in the previous phase, we recruited consultants to complete the facility assessment training. Now the consultants will be training individuals from each healthcare facility from the 6 hospitals to be able to understand the frameworks and deliver these trainings themselves and do the assessments at local level themselves. We have hired 3 individuals for the Ministry of Health through this project to support the different streams, and through the support and mentorship of WHO and KGHP, they will remain as a human resource to the ministry. The technical working groups that have been set up to shape the quality care activities in this project are made up of local stakeholders, and they are led by local teams. This ensures that it is locally led and locally owned so that there is momentum for these task forces to exist beyond the lifetime of this project. So overall, Somaliland's effort shows that quality and patient safety is possible even in fragile settings, and it is not exclusive to richer, more stable countries. If I was to summarize what I think were some of the key lessons for similar settings, but actually even other settings, because there's always a learning opportunity from high income to low income and low income to middle income. First, I would summarize it in 4 key areas. First, I would say it's really important to develop strong partnerships for knowledge exchange. Embarking on any health system change initiative is complex, but by having strong partnerships, we are able to leverage the expertise of different partners. The country cannot do it alone, especially at the beginning, and especially when it requires support in training and building the local knowledge in quality improvement and patient safety. Second, we really need to understand that the catalyst to change has to be localized. Grassroots localized movements are critical to affecting change. In the case of Somaliland, the quality agenda, even before the project, and what made the project successful, was the grassroots movement from a group of committed civil servants who believe and continue to believe that Somaliland's healthcare system needs to be centered around a quality agenda. And it was through them that we were able to synthesize senior management, including ministerial level, where now the Minister of Health and guiding Somaliland health strategic documents are advocating for the importance of quality care in all health programs. Third, small changes can lead to wider improvements. It's easy to focus and be overwhelmed by the large ideas, but when we're starting an ambitious change project, we need to leverage some of the low-hanging fruits. In our case, by designing and implementing the first national situational analysis, which could be considered a low-hanging fruit, we were able to undertake a quick assessment of the quality care situation in Somaliland and map the wider challenges and potential solutions. And last but not least, changes in quality care and patient safety need to be owned and driven by local institutions and their stakeholders. This key lesson has synergies to the first key lesson, but really now looking at it at the lens of the health facility. We know that change on quality needs to be driven by health system leaders, and the role of the health partners should be that of only a supporting role. Projects that leverage health partnerships and that implement activities at the facility level really need to invest in modalities that can secure buy-in from senior leadership at these facilities to ensure that these activities are locally led and they continue even after the project's funding period. Thank you very much. And that's yours to end my presentation. I wonder if we could ask a few questions, because I won't be part of the panel discussion. So if there was a couple of questions.
Thank you very much. What a brilliant presentation and brilliant efforts. Just for the audience, in 2020, there was a group that was established called the G20 Global Patient Safety Leaders Group, and actually one of the things that the group is focused on is to establish these collaboratives, or what we call, twinning between, different countries. So the UK Somaliland collaborative is the, a prime example of that, and, right on the money, localization. I think that's a key word. How do you, if you want to turbocharge this efforts that, or the outcomes that came out of this collaborative, 10 times, 100 times, what would you need? What would you kind of be interested in because as we're kind of looking at what worked and what didn't work in such collaboratives, we want to make sure that we engage into a global collaboratives, if you will, between, which is a two-way street, actually. I want to also learn from you about what Somaliland taught the UK in that collaborative.
I just okay. Thank you so much. I think it's really important, as you said, the partnership that we were leveraging with the King's Global Health Partnership, and they've been a partner to Somaliland for the past 20 years. But equally, WHO have been a huge support because they come with the technical expertise, and we're really supporting, incapacitating, and providing knowledge to the individuals. As I said, this 2-year project is ambitious, so if we start with our national quality care strategy, we really need support in implementing it. And implementing it would need individuals on the ground who are able to lead on quality improvement strategies, who are actually have the knowledge and the capacity and the leadership to do so. So if, for example, we don't receive any further funding, does the project stop? How will it be continued and maintained? So for me, it's really important to find some coaches or individuals within the country that can be the go-to for knowledge beyond the lifetime of this project. I really think as well there's an element of research that needs to be done. I think in countries where there is a lot of, it depends on donor money, a lot of the development programs are not centered around research but more short evaluations, and I think at every time point we should be looking at evaluating and researching what we've done and what we want to continue to do, but also reform in academia. These institutions that are producing these frontline healthcare workers, we cannot start at the health facility. We really need to be embedding this at the academic level. So how would that look? And for countries, not the UK, but other countries in similar settings or who are a little ahead of Somaliland, what they have done in terms of trying to transform academia and ensuring that quality is and patient safety is a component for healthcare professionals there would be really important and something that we would like to see at country level.
Thank you very much, Dr. Hamdi, for the great overview on this excellent partnership program. It's clear that there is a lot of successes. So what do you think from your experience in this program is the success factors? What made your program successful? What's your recommendation to others who want to start similar program in their countries to ensure that their efforts will lead to the desired outcomes? Thank you.
Thank you. I think, first of all, what I touched on was about developing strong partnerships and looking for partners that have different expertise so that you can draw on those different expertise. You don't just need to look for one partner. But I really believe it is about that grassroots movement that I touched on. If individuals, civil servants that are running these programs, that are overseeing these programs, really believe in the quality care agenda, it's very easy for them to influence senior management, sensitize them, and to get that government buy-in, because without that government buy-in, nothing really works. And I really believe this project was successful now. Maybe 5 years ago it wouldn't have worked, is because there was a group of committed individuals at the ministry ensuring that we were moving from access and now we were actually looking at our health facilities, that they were quality-based.
Dr. Hamdi, thank you very much. I enjoyed your presentation. I congratulate you also personally because you decided to go back to your home country to help your country. So my question for you is, what is your next theme or area that you are going to work on as a priority in the coming 3 years? I hope my question is clear.
Maybe it wasn't clear at the beginning, but unfortunately I've moved on since from the Ministry of Health. But so I would talk on two folds maybe. For the Ministry of Health, after this project, the idea is really to strengthen have a costed implementation strategy of this national strategy that we have in place, and then really think about the different partners on the ground, how we can support those different areas. For me, I've moved on to the university at the moment, local university, and I would rather focus on really looking at the research side and academia side, and really pushing for quality care and patient safety initiatives in there, and providing opportunities for individuals in patient safety and quality care training on that side. Thank you.
So to keep time, so we're not going to have any other questions. But thank you very much, Dr. Hamdi, for sharing the marvelous efforts made by you to enhance the quality of care and patient safety in Somaliland. So now we will move to Dr. Noura Nwaiser, who will be moderating a panel discussion about nursing safe staffing and discussing the questions submitted by our delegate audience to our keynote speakers. Dr. Noura Nwaiser is Director of Continuous Quality Improvement and Patient Safety and Strategy at Health Services General Directorate, Ministry of Defense. Dr. Noura has more than 30 years experience of clinical experiences with 15 years of senior executive leadership posts in quality management, patient safety, evidence-based healthcare, medical education, healthcare management, transformation and accreditation, and contributed as a research and a speaker at national, regional, and international conferences in these areas. She is also a board member of the Saudi Patient Safety Center and an International Joint Commission consultant and a member of the American Health Information and Management Association, Middle East Advisory Council. Dr. Noura, please join us in the stage along with our panelists, Dr. Ali Asiri, Dr. Abdullah Housawi, Dr. Neelam, Dr. Zakaria Al-Attal, and Dr. Peter Najjar. Please join us.
Good morning, everybody. Assalamu alaikum wa rahmatullahi wa barakatuh. I'm delighted to be part of this exquisite elite speakers and attendees for the 4th Patient Safety Center annual conference. Our panel is going to talk about some important aspect of staffing ratio at healthcare. So personally, I will just open that, and I know that the report of our Saudi Center have said it, the culture of safety survey every year gives the top risk or a negative is staff shortage or not meeting the staff requirement. And we will concentrate on the nursing category because they constitute 60% of healthcare workforce, as published by WHO and International Council of Nursing. So my first question will be to Dr. Abdullah, who have led as a previous CEO, ex-CEO of the center, a well-written paper about the safe nursing staff level and its impact on patient safety outcome. Doctor, what triggered that white paper decision to be developed, and where do you see the implementation of it now?
Thank you very much, Dr. Noura. If you allow me, I just want to be opportunistic and take just 30 seconds to send a message in Arabic, because we have some high school students, some university students, and we want to plant the seeds for the future patient safety leaders in the kingdom. يعني الله يعطيكم العافية على الحضور. يمكن في حضور من ثانوي، من المدارس، في حضور من الكليات. فأبغى أوصل لكم رسالتين بس. الرسالة الأولى، سمو الأمير خالد الفيصل عنده مقولة مشهورة إنه إحنا في السعودية هنا مكاننا الطبيعي في العالم الأول، في الصف الأول من العالم الأول. فشفت يمكن في المحاضرة اللي ألقتها الدكتورة نيلم الجهود اللي سوتها المملكة في دعم سلامة المرضى على المستوى العالمي. هذا يعني إن شاء الله يعطينا حماس وفرصة للمستقبل بدعمكم إن شاء الله وبجهودكم، إنه ناخذ إحنا الدعم هذا والجهود اللي بذلت ونطلع فيها كمان لمستوى أعلى. فأتمنى إنه كثير منكم سواء كانوا في المدارس أو في مرحلة كلية ولا كذا، إنهم يهتموا بموضوع سلامة المرضى. الرسالة الثانية، ترى ما تحتاج إنك تدخل كلية طب ولا كلية تمريض عشان تدعم سلامة المرضى. ابتداء ممكن إنه الواحد يكون جزء من جمعية أصدقاء مرضى، جزء من أي من الأمور اللي هي تدعم سلامة المرضى. فممكن يعني ندعم سلامة المرضى من اليوم، ما يحتاج إنه والله لازم أدخل كلية وأدخل. الرسول صلى الله عليه وسلم يقول أحب الناس إلى الله أنفعهم لعياله، فما باله لما العيال هذول هم المرضى. فممكن تدعم سلامة المرضى من اليوم. Sorry, Dr. Noura, what really triggered the efforts for the nursing staffing ratios is the fact that, you know, you mentioned in the National Patient Safety Culture survey where staffing is always a problem. 50-60% of the health workforce is nurses. So as Dr. Tedros, the DG for the WHO mentioned, that there's no transformation that can happen in healthcare without addressing that issue. And unfortunately, we see in some critical areas, you know, ICUs, NICUs, etc., very unacceptable ratios, and that results and keep resulting in you know, harm to which is preventable harm. So we were lucky during the preparation for the 4th Global Ministerial Summit to work with the ICN, International Council of Nurses, on writing that white paper, which, you know, with the efforts moved to the next level and became, you know, something that we're trying to achieve here in the kingdom.
Do you have any knowledge about its implementation in different sectors?
That's a good question. So we, you know, when the white paper was established, we also had a press conference that included the Saudi Commission for Healthcare Specialties, the Secretary General at that time, and the Saudi Nursing Association, to really, you know, announce that we're pushing into that direction. I think different sectors are at different stages of implementation. It is still kind of, you know, what I would say, a work in progress. I think because of, especially with COVID and the turnover of nurses, it is still a challenge. I cannot give you a specific number, but I think it is always important to really, you know, keep referring to it, talk to the leadership, make sure that this is when we're talking about recruitment, we don't just talk about it in general, but then really bring it down to the facility level and do that kind of bottom up, not just top down strategic planning for nurses' ratios.
I can speak from our perspective at the health services. We have used it as a reference for our safe ratio, but honestly, it is difficult to implement because of the challenges all of us know about recruiting nurses and the gap of nursing workforce, but it is maintained at the high-risk units, the ratio. And I think that's a start before we push it to the other area. I hope that this get implemented in all health sectors, and we look forward for Dr. Ali to push this on other health sectors and monitor it and have a feedback about its implementation. My other question is for Dr. Zakaria. What is the significance, in your opinion, of establishing of a safe nurse-to-patient ratio in healthcare? And do you see that will impact patient safety outcomes?
Very interesting question, thank you. I like the word that today we emphasize a lot about localization. Of course, we need to benchmark and think globally, but we need to act locally. So we need to adopt, I believe, appropriate approach to do the exercise internally within the organization to evaluate the staffing and to develop maybe the ratios, of course, considering some recommendation at the national level or international level. But if you see different hospitals, nurses, they do different tasks and different works. There is some initiatives I had the opportunity to look at in my organization where the chief nursing officer, she did the study to analyze the tasks that nurses they do, and she found that up to 25% of nursing task is not really related to nursing scope. So they do a lot of work because of lack of logistic or, let us say, administrative support. So she could demonstrate that nurses, they do clerical job, financial job, coordination job with, things that could be done or supposed to be done by non-nursing staff. So I do believe that we need to consider the scope and the local, situation of the hospital. This is one area. The other area, and especially in maybe our region, that we don't have the situation of nurses, they have specialization and they have specific competencies in certain specializations. So when the physician or the doctor graduate from medical school, after the internship, he has to go through a residency program for maybe 4 years or 5 years, and sometimes for a fellowship, while nurses, they go and start practicing immediately. That has a lot of consequences. One big part of it is safety, patient safety. The other part of it is hospitals, they need to invest a lot in the orientation program, and sometimes this orientation program extend up to 6 months or 1 year to get the assurance that these nurses are really competent to practice independently and to provide safe care. The last point in this regard, which is, I want to be very sensitive politically, the model of education in universities for nurses needs to be looked at again when it comes to critical thinking. So if you compare different models or different, let us say, systems in different, maybe I have the opportunity to have some training in US hospitals and visit some UK hospitals. I could see that nurses, they get the opportunity to act and to take certain decisions based on critical and clinical thinking, to analyze situations and independently act in a safe manner, and they are prepared to that scenario. I think looking at our curriculums and our nursing education system, if we can emphasize more into a critical thinking where nurses are encouraged and empowered based on evidence to take decisions related to patient care, this will help. Thank you.
If we can pick on that, Dr. Peter, regarding the mixed skill required in the nursing staff, do you see this affecting patient outcomes in terms of safety?
Yeah, no, thank you. It's a great question. And I think following along on the point that Dr. Zakaria, I think, was introducing around the importance of enabling all of our providers to operate at the top of their license. And that is to say, we know that we're going to have a global workforce shortage in general across all specialties. And what that means is that every specialty and every provider, whether that's a nurse, a physician, a physician assistant, ancillary providers, respiratory therapists, it's critical, I think, to create cultures and frameworks within we can empower folks to upskill themselves and feel confident expressing their skills and opinions within a clinical context to maximize essentially the brain power that we're devoting to each individual patient we're caring for. A really practical example of that we are starting to rely more heavily on is something called NIPOs, or Nurse-Initiated Provider Order Sets. And what those are for patients who come in, we recognize at Hopkins that the nurses are oftentimes best positioned to identify a specific need or make a specific diagnosis. An example is around wound assessment, for patients who are coming in from nursing homes, et cetera. And we rely on those nurses to do those assessments, essentially to make a diagnosis and suggest a course of treatment, and suggest that to the provider electronically, essentially, so that the provider just has to authorize that order set, and then the nurse can kind of carry out his or her treatment plan. So that's going to be critical in any strategy to address a workforce shortage that is global and very likely to be persistent over time.
Right. Do you think that what I will also extend what Dr. Zakaria said about the education bit of nursing to redesign, do you think that is one of the reasons nursing is not holding high leadership, though they constitute the 60% of the healthcare workforce?
Yeah, I'm not...
Because physician dominates that.
Yeah, there are probably a lot of reasons for that, and I'm not an expert in nursing education or physician education per se, so I have to issue that disclaimer. I also have to issue the disclaimer that actually the Johns Hopkins Health System, our president is a nurse.
Okay.
Well done.
Yep, Mr. Kevin Sowers, and he's a experienced former bedside oncology nurse. So I think there are a variety of obstacles that have limited nurses from ascending to senior leadership roles. But I'm hopeful that those obstacles are coming down, and I think certainly education, both in terms of content, but also in terms of empowerment and kind of creating a culture of leadership, of a sense of obligation amongst nurses. I can't imagine that wouldn't be a critical piece of increasing the percentage of nurses represented in leadership roles.
Dr. Neelam, can you comment on this point, please, also, regarding leadership of nursing and education requirement?
Thank you. So building on to what my fellow panelists have mentioned, I think the two two points I want to mention. One is about top-down leadership role. The other is looking into innovative and creative ways of how we can provide safer care, utilizing, the entire health system, particularly the patients and families, which have huge untapped potential of participation. So the concepts are very clear, I think, in terms of what needs to be done. It's how you implement them. One of the very effective strategies is multidisciplinary teams. And how do you have each member of the team, healthcare provider team, giving care to the patient in a most patient-centered approach? And so the leaders have a role to create multidisciplinary teams and make sure that nurses are fully empowered to take decisions, as was mentioned by Dr. Zakaria. The other important point I want to emphasize is safety culture, just culture, and removal of hierarchical barriers. I come from India originally, and we visited many developing countries. Huge hierarchical barriers. We cannot challenge, the nurses cannot challenge physicians and doctors, even if they are taking wrong decisions. So it is a whole change in mind shift and change in culture where the leaders have to take responsibility, where the nursing leaders or doctors who are leaders have to take responsibility to break the hierarchical barriers so that each and every member of the team is equally empowered to take decision in a patient-centered approach. So removing hierarchical barriers, strengthening leadership capacity for empowering nurses, and having patients and families more empowered to be part of the multidisciplinary team as well. And they can actually play a very important role, even addressing acute shortages in staff. And some of the roles actually patients can play themselves for their own safety. So that has to be really implemented. And last but not least is extremely important role of education and training of nurses. Equal opportunities have to be provided to nursing managers, nursing students, nursing leaders, through interprofessional approaches, because now more and more trainings are being designed as interprofessional, so that not only we ask them to practice together, but they actually study together as well. Yeah. And that would play a tremendous role in also breaking hierarchical barriers. I mean, challenges are huge because shortages, and also when there are shortages, they have direct impact on patient safety through burnouts, through fatigue, through not able to perform duties. And when there's a huge workload, there's ample evidence that it compromises patient safety, increases the risk of errors. So we need to have innovative solutions for different settings and different category of countries. So particularly in low and middle income countries, we have to find very creative and innovative ways, even if we are not able to increase our workforce, how do we plan things like task shifting, empowerment, multidisciplinary teams, to emphasize few. Thank you very much.
That's an excellent. Can I ask you, in 2020 there was a report from the WHO with the International Council of Nursing, which was stating the status of the nursing staff all around the world, globally. I think about 190 countries have contributed in that report. And it have calculated that a requirement of around 6,000 nursing is a deficit in 2020, or 5,000 something. And it estimated to reach what we require globally in workforce, in nursing specifically, we need to get to the workforce annually around 8% of that, of the 28 million nursing existing now. So do you have in the WHO, any initiative to address this globally, or to work with the International Council of Nursing, or do you just cascade that report to the countries and just from knowledge, awareness, and leave it for them?
So at the global level, there is a global strategy on health workforce development. And WHO reports regularly to the World Health Assembly, reaches out to member states similar to the Global Patient Safety Action Plan, reaches out to member states to report on the progress on how the health workforce policies and plans are being developed at national level. And that actually, is a very important advocacy instrument to countries to prioritize. I truly believe there is, what needs to be done is to prioritize having enough number of nurses and making sure that they get opportunities for education and training. It's basically political leaders who have to prioritize health, and when health is prioritized, we will have sufficient number of nurses. So ongoing high-level advocacy on these issues is very important. But from WHO, we have, as I said, the global instruments related to the strategy and asking countries to report on it. And as well as we have strategic frameworks and guidelines and tools to ensure how countries develop the workforce. And so definitely, we work very closely with the Health Workforce Department. And if there are any follow-up questions related to specifics of this, I'll be very happy to provide further information and communication with them. Thank you.
Good, thank you very much. Dr. Ali, given the discussion of this global shortage of nursing or other healthcare staff and the booming of artificial intelligence into the healthcare system, do you see that can close such a gap in healthcare?
Thank you very much for the question. My view to the healthcare system is that it is a human-based practice. And technology in general, and specifically AI or any other new sort of picture of technology, should be taken as an enabler. And I don't think in the near future there is any chance that it will replace human, or it will be a major solution to the shortages we have. It may help addressing some gaps, but I don't think that we need to rely a lot on technology and try to solve all our problems with technology. Because I've seen that sometimes it fires back on us if we just reduce or eliminate the human aspect of care and try to get technology instead of that. So I don't think it is the solution. It is part of the solution. It is an enabler. It's an important aspect of care that we need to adapt in the near and medium and long-term future. But it should be given the attention and the role that it is within its capacity, but not beyond that, in fact. And I think because sometimes between one-on-one discussions with some colleagues, they think that it is bring technology and everything will be solved. Clear, like, in our hospitals, when we're having issues pre the electronic medical records era, people, they thought that bring EMR, every problem will be solved. We'll be in heaven. But believe it or not, sometimes bringing EMR, paying a lot of money to bring it, training people created more problems.
Yes.
So we need to plan it well and see where the AI or the technology in general will fit, and not to expand their role beyond that, and try to make it the solution for the problems.
Right, we have 5 exquisite brains. I will ask you one question. If everyone please answer. So what is the solution, Dr. Zakaria, from your perspective? You have the magic stick. Short answer,
For
please.
me, the short answer, and the one long answer is one sentence. But the short answer is just a quick one. We need to take care of them. That's it. If we take care of nurses more and more, then they will stay in the profession.
True.
Yeah.
We would like to, from this platform, we would like to thank all our nursing heroes. They have done a great job during COVID, and they have been supporting the healthcare system all over. Dr. Abdulillah?
Yeah.
تفضل دكتور
Yeah,
زكريا.
just one thing I want to say about the lifespan of nursing profession is not really as long as some other lighter profession.
True.
So one of my colleagues mentioned about retention indirectly. So I see that nurses after some time, if we have very good career path, where we can, utilize their expertise after they have very good clinical exposure in healthcare, then they take leadership position. They do work in some other supporting position like quality management, risk management, patient safety, discharge planning, clinical pathways, infection control. And we can have that planned in advance. So we promote them to go for some certification, some exposure, competency. Then they can be very good model for junior nursing staff. Thus, when they join the profession, they can see somewhere in the hierarchy that they will, be influential at one point of their time, and that may motivate other nurses to join the profession.
Thank you, Dr. Zakaria. Dr. Abdullah.
It looks like we have so many nurses here, so
So that's why you need to.
I have to be careful. Well, it's a complex problem, and there's a saying that we can't solve the problems by the same level of thinking that created them. I think in healthcare, one thing that we need to think about is to rethink even the way that we do service provision. And what do I mean by that? Currently, if a patient who's admitted for 3-4 days probably is seen by 12, maybe 18 healthcare professional, and the outcome of that patient, if we want to go back to patient safety, because I think that's the true north of what we're trying to do here, is dependent on the collective efforts of that team working together. Patients could care less about me as a physician or a nurse or whatever in particular, but they're interested in making sure that they get safe care and effective care with good experience. I think if we think multidisciplinary team, kind of team-based approach to service provision, which starts from universities. I've tried during my time in the Saudi Patient Safety Center to talk to some universities about having that team-based education at very early in training, for healthcare-related colleges. So it really starts from there, and then people could work together. Simply, even in our electronic health records, we have nurses' notes that are separate from physicians' notes, that are separate from, like even physically now, in the days of the paper health records, it's literally you have like nurses' notes section and physicians' notes section. And if you really want to get a good information about the patient, I think it should be the collective aspects of both. So let's break down those silos. Let's rethink how can we have kind of a team-based approach to things, because that would result in reducing the gap. The gap is huge, but if we continue to provide care like it was 100 years ago, we're no longer, when you think about it, the service provision did not see any innovation over the past 100 years. We still provide care today like it was being done 100 years ago. So part of innovation in reducing the gap, I'm with the idea of also having support, getting AI and technology to help us in making sure that humans do what humans do best, and be part of that healing journey while the technology does what it does best. I think we can reach a happy medium. So I don't know if I gave you an answer, but I think it needs to be based on team-based approach. It needs to leverage technology in trying to reduce some of the gap, and it needs to be patient-centered at the end.
I know it's complex, but if we can, Dr. Peter, give me one word. I know it's difficult.
Evolution.
Sorry?
Evolution.
Evolution.
So I think just evolution of the role of the nurse, of their self-perception of what they're able to do, and at least as critically, evolution of how physicians, ancillary staff, and health system leadership view nurses and their capabilities.
Yeah. Dr. Neelam, one word.
I will give 4 words, not one. Inspire, educate, skill, and protect.
True.
And I think under those 4 heads, we can, of course, have subheadings like inspire.
That's a good recipe.
So inspire also requires incentivization, career opportunities, but those are the 4 words: inspire, educate, skill, and protect.
Okay, Dr. Ali?
Yeah, I agree with what has been mentioned. Just I'll add a few words from our role in the SPAC. I think we can do more than what we are doing now. I know that leaders, they take the excuse that there is a global shortage in nursing, so we cannot hire and we have to live with what we have. I think we can produce, we may produce like standards of numbers, how many, like patient-nurse ratio, and take it as a standard and press on the organizations and systems to comply with that. This is one. The other thing, we always say empower, speak up, but we don't protect nurses.
True.
I know that some nurses, the environment, they are at risk. If they speak up, they might have repercussions to that. So we need to pass
You crossed one word.
Okay, so protect them. And also, if something happens to them, we need to provide them with, heal them with like second victim
Take
programs
care of
or
them.
something.
Yeah.
Take care of them.
Yeah. Thank you. I would like to thank you all, but I have some questions for our speakers. We'll start, I'll try to give one question for each speaker because I think we are short of time. Dr. Neelam, how can risk management be implemented more efficiently to patient safety? This is from the audience.
Excellent question, because we should not protect patients from, when harm has happened, we should not only learn from harm, but we should actually introduce mechanisms that the harm does not happen. So risk management is an extremely effective strategy to prevent harm before it occurs. And there are simple tools and mechanisms which can be put in place by actually assessing the risk and identifying the risk and putting in place simple risk mitigation strategies. For example, we are now developing a VTE risk assessment tool to identify patients who are at the risk of VTE in hospital settings to start with, and then we can go to specialized patient groups as well. And once we have once we apply the risk assessment tool, we will be able to make sure that patients who are at higher risk, risk mitigation steps are taken so that they actually do not suffer VTE. So I just want to emphasize risk management approach applied to patient safety is the safety one approach. So proactively identify risks and then look into how do we make the procedures risk-proof and reduce the risk of harm and actual harm.
Thank you, Dr. Neelam. Dr. Peter, how can we overcome the challenge of some general physicians' resistance to be trained to prevent diagnostic errors? The generalist to be trained.
Yeah, so it's a great question, and I think the framework that we're deploying are those 4 T's. So that's training, teaming, technology, and tuning. And the first 2 apply really to upskilling the generalist. So I think a very good case study is the improvement in heart attack diagnostics. We've known for a while that cardiologists are obviously better at diagnosing MI than a generalist. And we've also known that we're not going to be able to deliver a cardiologist to the bedside of every patient who may potentially be experiencing an MI. And so there's been a large body of evidence with specific attention focused not just to the underlying science or biochemistry of MI diagnostics, but also to the implementation science of what we measure as door-to-balloon time, for example. And prior to that, diagnostic modalities that allow us to rule in or rule out an MI quickly, efficiently, safely, without a specialist being necessarily there available to read subtle EKG findings through the evolution in cardiac enzymes and those sorts of things. And so the way to do this, the only real path forward, because of the heterogeneity in diagnostics, is to take a look at each of those symptom diagnosis pairs, those big three categories rather, and the 3 or 4 or 5 conditions that comprise each of those, and approach those in the same way that we have with heart attack diagnostic excellence, and to develop carefully honed, scalable, customized, unique strategies for each of those potential diagnostic errors to be minimized, and equip generalists at the bedside with reliable algorithms and technologies to enhance their ability to make those diagnoses quickly, efficiently, and more accurately. It's really the only way to do it, because the same workforce shortages that apply to our nursing staff also apply to physician staff as well. And we know that we are going to be facing a worsening shortage of physicians, and in particular subspecialty trained physicians. And so the ability to sort of extend that knowledge, make it algorithmic,
Yeah.
and then deliver it to more patients is really the only path forward.
Yeah. Thank you, Dr. Peter. Dr. Zakaria, patient and family empowerment, how do you make sure they are empowered, and how do you measure that? So can you press the, sorry, I can't hear.
So, okay, if I get the question very well, how you make sure that patients are empowered and how you
Patient family empowerment.
Sure.
Yeah, how do you make sure that it is implemented, and how do you measure it?
Actually, this is a very good question, and what we did in our organization, we asked them based on a survey, and we look at the government feedback report from a mystery shopper tool. They use it. So we analyze all the feedback which comes from patients when they visited our clinics, and they get also inpatient services. So they come back with their experience, and they give us a lot of feedback. One big part of it is about patient focus and patient empowerment. So we look at that, and we start developing certain strategies how we can really respond as much as we can. We prioritize that, and we start implementing it. We took all the feedback, we got it from that report and the survey to the Patient and Family Advisory Council, and we asked them from their point of view to prioritize, because, you know, not everything we got from the report we can do it tomorrow. So we prioritize, and accordingly we start working on it. How we measure this? We measure it in 2 ways. We measure the effectiveness of our action, and that we have a model for that in our organization. And the other important thing is we follow up on the government report, because the government report is a third party. They evaluate our patient experience, and they come back to us with the improvement if we could achieve it. So again, we use the actually patient perception reports. We analyze it and we quantify it, and then we see it. It's maybe one of the available tools to measure the effectiveness of our empowerment strategies for patients.
Thank you, Dr. Zakaria. Last question, last but not least, Dr. Ali. Non-punitive response to error is one of the lowest results in patient safety culture survey. Is there a national strategy to address this challenge?
No doubt, it is a challenge, not only in Saudi Arabia, even outside, culture, specifically how to build non-punitive culture or just culture. There is a just culture sort of training and regulation, and I would say guidelines. We don't have a policy yet, and because it's a culture, so it is sort of training and education and trying to show the importance. And we have highlighted this an issue, and we passed the and share the countrywide report to the leaders on the culture survey result. And we always highlight the issue like work on the creation of just culture within the organizations. One good, I would say, pilot was done in one of the areas in Saudi Arabia where leaders of that province realized this, and they said, let's work together, the center and that area, to showcase that it works. Because some people, they don't believe in culture. They say this soft skill and, it's minor. Yeah. So that we worked with that leadership in that area on that aspect, which is the non-punitive culture, just culture, and it showed results. It has improved significantly because of leadership support and buy-in and commitment, because of the willingness of the people in the field to adapt that. So it is a challenge. However, it is manageable if there is leadership support and if there's understanding of the importance of this aspect.
That's the key word, the password, if you ask me, is leadership. I would like to thank our panelists for their time and input for this panel discussion. I think this is the only time we have for questions, though I have a list of them. So there is a lot of eager learners out there. Thank you all. I would like to see you in future events.
Thank you to our panelists and Dr. Noura for this informative discussion on really important trending topics for the past couple of years. Now let's turn our attention to the heart of innovation and education at this conference, the patient safety poster competition. These posters are a statement to diverse and brilliant minds working toward advancing patient safety. Our panel expert judges has faced the challenging task of selecting the winners from a pool of outstanding submissions. The time has come to acknowledge those who have not only shown excellence in their fields, but have also significantly contributed to shaping the future of patient safety. Without further delay, let's applaud to our remarkable efforts to our participation and announce the well-deserved winner for patient safety poster competition. I would like to invite Dr. Ali, Dr. Noura, and Dr. Suji to the stage to recognize efforts to our competitors. Please join us to the stage. Our fourth place winner is Dr. Abdullah Al-Ataibi, study title Manzil Healthcare Immunology Adherence Program. Welcome, Dr. Abdullah. Our fourth place winner is Malak Ad-Dosari, study title Reducing the Time Required to Report Biochemistry and Hematology Critical Results by Alert Code Station Activation Deactivation to 95% from July to September in Al Madina. Welcome, Dr. Malak. Our third place winner is Albert G. Pauls. The study title is Impact of the Innovation System Generated Adverse Event on Enhancing the Blame-Free Culture with Johns Hopkins. Our second place winner is Ibtisam Al-Hihi, study title Revitalization ICU Safety, Achieving Zero Central Line Association Bloodstream Infection Through Strategic Multimodal Interventions. And now, to the first place winner, please applaud for Dr. Abdulaziz Al-Sha'ir, poster title Improving Patient Safety and Quality of Care by Reducing the Incidence of Hospital-Related VTE via ensuring the accuracy of VTE assessment and implementation of prophylaxis measurement at Al-Dhahran. Thank you to all our winners. Thank you, Dr. Anora. Thank you, Dr. Ali. Thank you, Dr. Soji. Our last talk before the break is presented by Mr. Author Gutierrez, sorry for the pronunciation, Director of Clinical Services from DaVita Kidney Care. Welcome, Dr. Author.
Thank you so much for a wonderful presentation. So good morning still, right? Good morning, everyone. So I'm Arthur Gutierrez, Director of Clinical Services. Our topic for today is like a real-time decade of experience in the field of integrated quality of care. So this is mainly focusing on kidney care, of which we have in Saudi Arabia. So I'll be speaking in behalf of Dr. Wissam Al-Badr, of which is our Chief Medical Officer and Chief Transformation Officer of DaVita Saudi Arabia. Dr. Wissam Al-Badr gears towards on promoting clinical safety, operational efficiency, and of course, clinical governance. So if we're going to go over what we really do as a company, as a DaVita, so we are the ones partnering with Johns Hopkins and alongside with the Ministry of Health to provide integrated kidney care. So we're covering all domains of kidney care except for the ones hospitalized and the ones on transplantation. So let's take a step back and move back to the basics. If we're going to go over, World Health Organization has been identified like high quality of care, high quality health care for our patients. If we're going to go over with that, is all of the countries around the world is looking over for universal health care. And on the universal health care that we have, it must be imperative that we are providing a health care to our patients with utmost efficiency, clinical safety, and alongside with it is of a clinical governance. So it covers both. A quality healthcare must be integrated, at the same time, a quality healthcare must be safe. Another thing that we need to look forward to is that the role of learning system. The role of learning system in the society that we have right now is that we're looking over the internal and external information that we have. So for us, we're looking over the internal information in terms of the evidence-based practices that we're doing in our clinics and apply it real time to the patient's needs that we have. At the same time, we're looking over the external information provided to us by the expert, the best practice guidelines provided by KDOGI, KDIGO, and these enabled bodies that are governing nephrology all over the world. So as we are part and in line with our 2030 vision, of which is healthcare transformation, we are going over on the strategic cornerstones, which includes better health, better care, better sustainability, and better workforce. So, our story as DaVita. If you're going to look over, we migrated the knowledge and experiences that we have from DaVita US, going to DaVita International, which is in London, and then here, DaVita Saudi Arabia. It is an extensive experience in clinical practice in nephrology and caring for our patients with kidney diseases. So what do we have? Of course, building culture and provision of tools for our teammates alongside providing the care for our patients. So, building culture. If we're going to go over, DaVita has a very distinct culture of which every teammate we have are proud of. This is a culture of no-blame environment, a culture of safety, but alongside with it, a culture of providing care and a community-first, company-second. During 2014 and 2016, as we started our endeavor here in Saudi Arabia, we focused on culture of change on the following aspects. First one, in the openness, outcomes measures, and the development of our information technology. Openness, we want to have something of, as I said a while ago, a culture of no blame. A safety culture, psychologically safe culture for our teammates, of which they're going to open up whatever they have in mind in terms of safety particularly. And we look over different outcomes measures. Are we doing good? Are we doing not? And of course, delving ourselves in new information technology innovations to our system. 2017-2018, we go over three main points on clinical governance, which is training and leadership, audits, and risk management. So, as we're talking about safety, audits and risk management are the primary things that we have for us to improve safety in our facilities, especially kidney care. As we move forward on moving over training and leadership, we identify a triangle of which covers clinical, medical, and operations to sustain our effectiveness in terms of the field of kidney care. 2017-2018, everything else has been blended out. All clinical governance pillars has been there to facilitate our care for our patients. 2019, we test what we have by going over the outcomes measures that we have in the kingdom, of which takes a lot of things that we need to do. So from going to the clinics, integrating what we need to have in there as per the leadership. So these are the things that we have alongside on promoting a culture of safety in our environment. At the same time, we study our team. Most probably, some of our facilities have done the same thing, of which 79% of our teammates are millennials. So being a millennial, you need to go over on identifying their whys, going over their intentions, and see to it that you approach them on the same perspective that they want to be approached. So that's how we delve our culture in DaVita. So from 2014, we have a total of 2.8 million dialysis provided to our patients. And if you're going to go over the data, our clinical outcomes from day zero or zero data of our patients are increasing from both ends, from our in-center hemodialysis, at the same time our home hemodialysis. But at the corner front of it, we're also looking over patient and public involvement. So as of the moment, from 2 years ago, we hired patients, of which are currently a patient advocate. So these patients are the one looking over the patient's needs and giving it to us as on a leadership perspective. At the same time, we're looking over in 2024 on having a patient group, of which our psychologists will be looking over different depression, anxiety that our patients came across as having a chronic kidney disease. Provision of tools. As we said, our main cornerstone is our culture, but building that culture without a tool or an enabler will not be sufficient enough for our teammates on providing care for our patients. So as I said, we need to connect with their whys, especially given amount of 79% of our workforce are millennials. They should know why they need to do something and what are the driving force for them to do it. Do simple and better, at the same time, consistently. So providing the tools, we look over a program, which is Summit. Summit Elevating Patient Care. Summit is a quality management system program that has been integrated in the Vita Saudi Arabia, of which focuses on quality improvement and clinical safety. This focuses on these three top clinical goals. First one is creating a culture of patient safety. The second one, using quality improvement methods for all of our activities. Third one is to transition to high reliability organization. But how? Summit is a combination of education and tools, of which works hand in hand with different activities and behaviors of our teammates on the floor. We hold the teammate accountable for whatever they're going to do, and we have certain measures in terms of data, audits, and we're presenting it to them alongside the discussion on promoting quality improvement in our clinics. So Summit for us has 4 levels. So 4 levels of Summit are the following: Summit Walker level, Summit Trekker level, Summit Climber level, and Summit Mountaineer level. So as I said a while ago, Summit is a quality improvement and clinical safety. So what we're doing there is like, we have several levels of Summit, of which the other one builds on the first level. So the Walker level starts with daily huddles. So the daily huddles, as we all know, this is a face-to-face gathering of which we're going to present some data. At the same time, we're going to ask for your ideas. What are your concerns? What are the current things that you think might cause a safety issue for our patients? On the first level of Summit, which is Walker, we see to it that we are consistent of doing a daily huddles for our teammates. So this provides an avenue for them to have a team gathering, at the same time discuss any upfront safety issues that we have in the clinic. After maintaining a daily huddles, consistent daily huddles in our facility, we move towards safety reviews. Safety reviews are the ones we have as a safety briefing. Safety briefing covers the top 3 sentinel events that we have in the clinic, the recurrent ones, what are the things that we need to do, how we enable team or even our individuals in the clinics to look over these safety issues that we have. Moving forward, the next level is Climber level, of which focuses on improvement through different quality improvement initiatives or quality improvement projects. The third one is moving towards a high reliability organization, of which a collaborative approach and learning process. This way, we're also integrating patient-public involvement, of which we have a patient on board on a daily huddle to identify what are the things that are of a priority for them. This provides us an avenue for an outright feedback from our patients, of our care receivers, so to say. This is our daily huddle board. Our daily huddle board, as I said a while ago, is focusing on some ideas, some concerns, some upfront safety issues that we have in the clinic. These things are coming from our teammates. So once we initiate the huddle, we're going to open the floor for any ideas that a teammate might have, for any concerns. So going over that, we are looking over the down-up approach of getting ideas and even pulling it up for implementation across the kingdom or across different clinics that we have in Saudi Arabia. So our daily huddle board focuses on safety and quality, of which covers different parameters. And of course, as I said, culture for the Vita is something that we are proud of because we embedded a core value of fun. I believe majority of you already experienced daily huddles initiating into your facility. But one of the upfront problem on doing this, it causes boredom for the team to go and present themselves on the huddle. It causes for what we call a huddle fatigue. So what stops us from having this huddle fatigue for our teammates? This is what we're doing. We have a so-called wisdom activities. So for a 6 days operation that we have for our clinics, we see to it that 1 day of that will be dedicated purely for fun. So it's either one, we're going to share experiences, other, we're going to share their interests, personal interests, and one, we're going to just have fun, just have a games. So this causes for the team to still present themselves on the huddle and avoid this huddle boredom or huddle fatigue, so to say. So, Summit is our avenue for every programs that we have in the Vita, which includes Bugbuster program, which is the infection control program that we have, Hard Hats program, which is a safety program that we have, Fluid Focus program, which is a fluid management program, Access Aware program, the vascular access program that we have in the Vita. So across all those programs that we have, Summit is our avenue to see to it that everyone in the clinic is updated. At the same time, all directions or instructions coming from leadership are directly going towards a teammate. So those are the beautiful stuff that we have in Summit and daily huddles. But 2019 struck us with COVID. And then another challenge came in, which is the pandemic. The problem with the huddle is that it's face-to-face. And pandemic limits us from doing that. But that doesn't stop us on striving for a patient safety and a culture of a no-blame environment, providing quality care for our patients. So what we did is that use the technology. We did a Summit virtual huddle. So what's Summit virtual huddle? Instead of them having face-to-face, we're going over and then having them online, using the same huddle board, but they are online telling the ideas, concerns, and safety issues that they have. Good thing with the Summit virtual huddle is that we even use this for our home dialysis service. Home dialysis service, I would just like to give you a view. This is like one patient, one nurse at their comfort of their own home. So the nurse in there cannot present themselves in the clinic to join the huddle, so we are doing it virtually to identify, again, any safety issues that might happen inside the house of the patient. So that's our Summit huddle, and that's the culture of the Vita on how we provide tools for our patients and teammates to enable them to do and deliver the care that we want them to deliver. So on my last note, I would just like to give this final message as stated by Ms. Maureen, President Emerita of IHI, that everyone in healthcare should have 2 jobs: to do the work and improve how the work is done. Thank you so much.
Thank you very much, Mr. Arthur, and thank you for our audience. So we will start our break in 5 minutes. I would like to remind everyone that we have 2 tracks, track A and B, with significant speakers coming from overseas and from other countries. And I would like to remind everyone also that at the end of the day, we will have puzzles with prizes. So we want you to join us in the puzzles. Now, I would like to also invite our winners again, our 5 winners to the stage, with Dr. Ali, Dr. Suji, and Dr. Noura Nwaiser, to take a group picture, please. Our winners, first, yes, Dr. Ali, Dr. Noura, and Dr. Suji again, so we can take a group picture. Thank you. تفضلي. Yes. Thank you for our winners. Please join us to the stage with Dr. Ali, Dr. Noura, and Dr. Suji. Please stay on the stage. I would like also to invite our competitors, other competitors, to the stage so we can have a group picture. Please stay on the stage. Please stay on the stage. I would like to invite all the competitors because we had amazing posters. Please join us to the stage, our competitors. Yes, yes. I would like to remind all the competitors to join us on the stage to have a group pictures. Thank you very much. We will come back and start at 12:45 in track A and track B. We'll start at 12:45. We can start our break now. Thank you very much. الله يعافيك. لأنهم طلبوا الcompetitors. We will have other pictures. Please, Muad, our photographer. Thank you everyone. We invite all the speakers to come to the stage if you want to take a group photo. We invite all the speakers to come to the stage to take a group photo if you want. We invite all the speakers to come to the stage and take a group photo if you would like.
السلام عليكم ورحمة الله وبركاته. مساكم الله بالخير جميعا. يمكن هذا أول لقاء حضوري لجميع الفريق، حضوريا مع بعض كلنا، بالعادة متفرقين كل فريق لوحده. اليوم الله أكرمنا واجتمعنا مع بعض لإتمام إنهاء المشروع بإذن الله على أكمل وجه ونجاح هذا المؤتمر. ما راح ناخذ من وقتكم كثير. تعلمنا حاجة في التمييز المؤسسي، أنه لا يوجد في إدارة المشاريع صح وخطأ، بل هناك مشاريع للتحسين. فنستأذنكم أن نأخذ من وقتكم دقائق معدودة في هذا الاستبيان، الدروس المستفادة لكل العمليات، لكل المراحل التي تمت في إنجاح هذا المؤتمر، ما قبل المؤتمر حتى إنهائه. كل معلومة تكتبها أو كل مصطلح يذكر في هذا الرابط تأكد تماماً أنه مهم جداً لمشاريعنا القادمة في إنجاح أي مؤتمر، سواء مؤتمر سلامة المرضى أو أي مؤتمرات أخرى. وشكراً لكم مقدماً.
Sorry for the delay. We'll be starting in 10 minutes, okay? At 1 p.m. if you can come to the front, please, it would be better. إذا تقدرون تقدمون للكراسي اللي قدام أفضل.
Seems not working. Hello. Please give me your attention, please. Can we have a seat? We need to start our session about WHO Global Movement for Patient Safety. Our guest today is Dr. Nilma what we call? Sorry? Huh? I need to pronounce it very well. Dingra. Okay. Nilma Dingra. Dr. Nilma Dingra, MD, heads WHO flagship, a decade of patient safety from 2021 to 2030 at WH headquarters, Geneva. In this role, Dr. Nilma lead global efforts in providing strategic leadership on patient safety within the context of UHC and health security. This includes implementation of WHA resolution, Global Action on Patient Safety, Global Patient Safety Action Plan 2021-2030, World Patient Safety Day. A global patient safety challenges, medication without harm, global patient safety network, leadership and safety culture, engaging patients for patient safety, education and training, adverse events reporting and learning. Dr. Nilma joined WHO Geneva in 2000 and led WHO Blood Safety Unit till 2014 and heading the Patient Safety Unit since 2015. Dr. Nilma was a faculty member in a university hospital in New Delhi for 14 years. Also, coordinating transfusion services after MBBS from Lady Harding Medical College, MD from AMS New Delhi and UK fellowship for 2 years. Please join me to more welcome to Dr. Nilma and most welcome for you. Thank you.
Thank you, Mr. Chairperson, for your kind introduction. And welcome to all of you after lunch session. Today, actually, I'm at this time filling it for my colleague, Dr. Mondela Taif. He's attending a meeting in UAE for COP28. And I hope that I can do justice to the work. And although Mondel and I were actually closely involved in this work, but it was led by the Eastern Mediterranean Regional Office, what I'm going to present today, this afternoon. So what I'm presenting is patient safety in fragile, conflict-affected, and vulnerable settings, called as FCV settings. What are the special considerations to be given for FCV settings, and how do we address those? So I present to you the Eastern Mediterranean region, which has 21 countries, member states, which are in this region of Eastern Mediterranean. And broadly, these are categorized in 3 categories, group 1, 2, and 3. And there's a 4th group as well, which I'll come to later on. So group 1 is countries which have strong governance and mature health systems. And those in green you see are the ones which have mature health systems. Group 2 are the ones which are mostly middle-income countries and have developing systems, and which are in yellow color. And group 3 are the ones which are either in acute or in emergencies, but most of these are low-income countries. Some of these countries which are in group 3 are also involved in emergencies, but broadly in this region, entire region, there are 10 countries which are involved in either acute or protracted emergencies. 5 of them actually are in acute emergencies and 5 of them are in protracted emergencies. So with this, I would like to share with you the overall situation of quality and safety in extreme adverse situations, particularly focusing on the work in the Eastern Mediterranean region. Now, I also want to mention that if you look at the entire refugee population and the migrant population across the world, 60% of population actually lives in this region. So there are many, many challenges which these countries are facing in this region because of this crisis. So how do we ensure safe care in FCV settings globally? So I want to share with you some statistics, all particularly related to fragile situations. 2 billion people actually are affected in the fragile and conflict-affected and vulnerable settings, FCV settings, around the world. 131.7 million people are in need of humanitarian aid. 30 million children are now forcibly displaced by conflict. 1 in every 70 people around the world is in crisis in this situation, and fragile states receive around 50% less aid than predicted. And if you look at the impact on health systems and safety in FCV settings, there's a huge challenge. In these settings, challenge on health system, which also affects safety. So there's lack of infrastructure, like facilities, human resources, equipment, supplies, and medicines. And particularly, I want to mention here things like fuel crisis. Recently in Yemen, there was an example which was shared that because of the fuel crisis, some of the hospitals were not able to operate and run, and which affected the actual care provision. And when the care is not provided, then there's delay in treatment, delay in diagnosis, delay in treatment, which leads to major safety issues as well. So there's a heavy burden of safety issues in the countries which are affected by FCV settings. Inability to provide and coordinate health services is a major, major challenge. Lack of equity in who receives available health services. Inadequate capacity building mechanisms and systems. For example, training may not be available to everyone who requires training. Insufficient coordination, oversight, and monitoring of health services. Lack of policy mechanism for developing and implementing national policies. Challenges related to deficient health information systems for planning, management, and surveillance, and also inadequate management capacity, for example, budgeting, accounting, and human resource. The other challenge, particularly related to human resource, which has been seen in these countries, is violence. So countries which are in FCV settings, health workers are really exposed and they suffer violence in many, many situations. And we need to develop, particularly to have our health workers protected, which was discussed in the morning as well. We really need to have strategies which will protect health workers from violence in FCV settings, such as having community leaders so that they are engaged in this situation, and the importance of health workers. Of course, health workers are vital to provide care in FCV settings, but if they are themselves exposed to violence, it can lead to very difficult situations where care provision is seriously affected and also compromising safety in those situations. Now, there are major differences when we look at FCV setting. There are multiple and major differences. So national governments may be weak in some of these situations if the regulations are not very effective. In that case, there will be no accountability, no transparency. You know, particularly when there's private sector, there's no accountability. It's very difficult to regulate what's going on. So weak health system and governance can lead to compromised capacity, legitimacy, and authority. Health systems are damaged and collapse. Financing and funding complex situations are unstable and it's inadequate funding. Workforce is insufficient or often transitional because sometimes there may be a health workforce which is shifted for task and brought to handle FCV situations and may be very transitional and may not be fully trained as well to perform the work. Infrastructure is damaged or destroyed, affecting several issues like structure, water, power, and supply chains. Security is problematic, and there are diverse stakeholders, particularly humanitarian actors, UN agencies, and NGOs, and international NGOs, and it becomes a challenge to coordinate the response with several stakeholders involved. So these are major differences from a normal setting to FCV setting. And it's a moral imperative in these situations to be practical and action-oriented and do only the essentials and only if it can make a meaningful change. So one has to really prioritize. When we are introducing solutions in FCV setting, we need to prioritize what is really essential, which is action-oriented, and which will really make a difference. So I show you an organogram or a relationship in a health sector governance illustrative model. In FCV settings, you can see there's governmental organizations, there are multilateral donors, and then non-state actors. There's so many stakeholders are involved, and one of the major challenges in this is coordination. So effective coordination will be better delivery of services and definitely will improve safety. So once we recognize that in FCV settings, there are going to be multiple stakeholders, and you need to really address the issue of governance. What are the relationship of governance in this situation when there are multiple stakeholders involved who have very legitimate involvement in this situation? Either they are providing funding or technical support, and as well as governmental, non-governmental, and multilateral organizations and donors. So the mechanisms need to be put in place, led by the government, to have effective coordination and better care provision in these situations. So if we look at the current status for safety in FCV settings, safety is not usually an explicit priority. And this was also mentioned this morning by our colleague, Dr. Isa, about that access really has always taken priority over safety and quality issues. So this is, in FCV settings, the main focus is on access. Can we really ensure that access is available, maternal and child care, immunization services, the access is available. So safety and quality issues are not given the priority what it deserves. And they're not usually standardized also in systems. Most safety projects which are done are ad hoc by a donor, country, or NGO. And sometimes data on safety is hard to find as well, so it's not standardized. And comparisons are very difficult, so hard to identify best practices. How do we say these are best practices in FCV settings when we have very few examples? So there are major safety issues in FCV settings. Now, some essentials. So this is a result of a study which was done by the Eastern Mediterranean Office of WHO in collaboration with the University of North Carolina, and looking into, what priority interventions need to be placed and what needs to be highlighted, and what the findings of this study show what was not highlighted in this study. So what was not highlighted was the quality and safety for extreme adversities was not highlighted. It's not quality and safety in extreme adversities, but it's for extreme adversity. Then the role of private sector on providing healthcare and leveraging on existing opportunities, this was also not explicitly identified in this study. Accountability of actions taken for tackling identified challenges like reporting and transparency. These were another issues these were safety enhancing factors, but they were not highlighted in this study, and they were not, when they were evaluating these priority intervention, they recognized that these were not really sufficiently highlighted. The value of community engagement in providing integrated people-centered care. The orientation regarding minimum healthcare services platform, which includes minimum service packages and support of mental health. These issues were more or less ignored. Mental health issues, which are so crucial, were ignored in these settings. And preparedness and in advance reliable planning for emergency also was not well highlighted. So looking at patient safety gaps, how do you address patient safety gaps in these situations? So extremely important that we prioritize in this situation saving lives as the ultimate goal of healthcare services in extreme adversities. We need to adopt guidelines and protocols, make resources available, apply human factors, particularly looking into the safety of health professionals so that they can perform their responsibilities. Issue of gender inequity and discrimination were other gaps, and how to ensure infection prevention control and in extreme adversities, minimum standards for IPC, they were also not implemented and they were major gaps. So we need to really look into the minimum standards, minimum service packages, and also prioritize those interventions which are going to directly contribute to saving lives. I want to show you with, how do you actually apply systems thinking for patient safety in FCV settings, because there's a need for coordination across different levels of the health system and across different stakeholders as well. So if you see in this diagram, from the bottom up, health service provision, professional patient responsibility, good governance, competent operations, service delivery management, policy and infrastructure. So these are some of the functions which are taking place at different level, and there's a need really to, when we are looking at systems capacity, how we have to create systems capacity through coordination, better coordination of multiple levels of the health system, and the role at individual level, at facility level, at regional district level, as well as national level. So individually looking into supervision, performance feedback, patient education, at facility level looking into infection prevention control, simple measures, medications, procedures, training and development, inspection and external evaluation, peer review against standards. At regional district level, performance contracts, performance monitoring, human workforce capacity, and national level looking into regulation, health information system, licensing, payments and standard setting. So there's a need to create capacity at systems level if we want to address safety in HCV settings in a systematic and sustainable way. So these are some of the better bets for quality and safety in HCV interventions. And these were, again, part of a study which was conducted by the Eastern Mediterranean region, looking into interventions which had 4 criteria in terms of its generalizability, feasibility, results, and also looking into preparedness and representativeness. And then settings were hospital, primary care, and obstetric setting. And there were the features which were looked into. The interventions were external readiness assessment inspection, IPC, engaging and empowering communities, strengthen accountability, and provide peer support counseling, staff training. So different interventions were then looked into whether they need to be focusing on, and the crosses you see were actually the better bets for ensuring quality and safety. Staff training and supervision, use guidelines and standards for training, use of safety tools and practices, particularly safety checklists. So I'm almost coming to the end of the presentation because time is limited, and I just want to mention that WHO, MRO, and headquarters are working together to develop some sort of a training course which can then build capacity of health workers and leaders in how do you manage patient safety in FCV settings. And we see this as a part aligned with the Global Patient Safety Action Plan as well, which is in Strategic Objective 2, it actually addresses building reliable, high reliability systems and health organizations that protect patients daily through safety culture, leadership, governance, human factors. Very important to make sure that high reliability systems also have strategies and actions in place for handling patient safety in emergency and disasters and extreme adverse situations. So with this, we look forward to opportunities with partners around in this room, particularly with the Saudi Patient Safety Center, with the expertise of Saudi Patient Safety Center, to jointly host a virtual course for patient safety in FCV settings to build capacity of those who are interested, and then also utilize this platform to disseminate knowledge on what works and know-how of the priority interventions, what works, what doesn't, and the opportunity for cross-learning from countries who have established effective systems for safety in healthcare. So with that, I would like to thank you for your attention, and I really hope that I've done justice to Dr. Mondas Latif's works. Thank you so much indeed.
Thank you very much, Dr. Neelma, for this valuable presentation. And now, let's go with our second speaker, Dr. Sanaz Masoumi. Dr. Sanaz Masoumi is the Chief Operating Officer of the Patient Safety Movement Foundation. In addition to deep passion for patient safety, she has extensive experience in working to create more reliable healthcare system. Her role with the foundation involves overseeing the operation, a growing partnership with other patient safety organizations, and working to spread awareness of industry best practices. Inspired by the many accomplished and caring patient safety experts she has encountered throughout their careers, she is committed to leveraging her knowledge and experience to bring necessary and positive changes to benefit patients worldwide. Please join me to warm welcome to Dr. Sanaz.
Perfect. Good afternoon. Thank you for joining this breakout session. I'm Sanaz Masoumi, Chief Operating Officer at the Patient Safety Movement Foundation. This is my pleasure to be here, and I'm very thankful and grateful for the Saudi Patient Safety Center for their kind invitation. After Dr. Neelam's wonderful presentation, it's very difficult to do anything to do justice. And such an important topic you addressed, and thank you for sharing your knowledge and wisdom with us. I hope through my talk, we walk the journey of safe care together. Please allow me to give you a quick background about our foundation and the significance of the efforts to address the challenges in the ecosystem of healthcare. Patient Safety Movement Foundation was founded by Joe Kiani in 2012 to address the unmet need of eliminating patient harm in healthcare settings. In 2013, we officially became a 501c nonprofit organization in the United States. Since the beginning and to this date, the Massimo Foundation for Ethics, Innovation, and Competition in Healthcare has been our biggest supporter. They're committed to advancing positive change for the benefits of clinicians and patients everywhere, and that is our aim too, to bring about optimal patient care for patients and healthcare workers in this two-way equation. We have a holistic approach to safety. In all our efforts throughout the past decade, we have always involved patients, clinicians, academicians, healthcare organizations, safety organizations, payers, and policymakers to address the complexity of healthcare challenges and develop systemic solutions. We've always tried to give a voice to patients and their families and advocates, and patient safety activists, and strengthen their message. We've always worked very collaboratively with other patient safety organizations. And general public, the biggest force to make the change happen. We've tried to educate and inform them of the magnitude of the problem we face in healthcare and the level of trauma every single harm creates for both patients and caregivers. And that's why we believe that even one preventable patient harm is far too many. Our vision is to reach the point of zero, and we will get there by disseminating evidence-based practices in healthcare organizations and cultivate data transparency. Safe care save lives, which is most important, but also save a ton of money. I apologize, I'm here. that can be redirected to improving our healthcare settings, advancing the technology, hiring more staff to address the staff shortage, educating staff and keeping them up to date with advanced knowledge, and building the infrastructures that we need, like more ICU beds. The current state of safety is pretty shocking in two ways. One is merely the sheer volume of adverse events we observe on a daily basis. In the United States, and these are just estimates, we have over 200,000 patients who die from preventable medical errors. The cost of medical errors surpass $30 million. 25% of patients, hospitalized patients, experience harm. Examples of hospital-acquired infections are many, sadly. We have over 40,000 CLABSI cases every year that cost an additional $48,000 per patient to treat. We have 300,000 preventable ventilator-associated pneumonia that cost our healthcare system about $50,000 for patients to treat. 11% of surgical cases end up with surgical site infections that results in over $3 billion. There are about 50 million sepsis cases globally each year that results in 11 million deaths. 40% of them are children under 5. That's brutal. We experience 7.5 million misdiagnoses in the United States every year, out of which 2.5 million results in adverse events and 500,000 deaths eventually. We have 900,000 healthcare-associated VTE resulting in 100,000 premature deaths every year in the United States. The volume of adverse events by itself indicates the burden that unsafe care has brought upon us. But simultaneously, it is shocking that we still do not have accurate numbers. We do not know exactly how many people experience preventable harm because the data is not captured nor identified properly, and it is not shared very much beyond borders of our healthcare systems. When we talk about patient safety equation, we need to address how adverse events affect three groups. The obvious group, patients. Adverse events prolong their hospitalization that can result in other adverse events such as hospital-acquired infections. It causes disability, shortened life expectancy, trauma, reduced quality of life, and death. The second victim is our clinical team. Adverse events also cause trauma for them, which results in self-blame. It causes burnout on top of their very difficult daily long hours of work. It causes job dissatisfaction. We see a lot of nurses who quit and they go to other fields. And those who remain to provide care may be disappointed in the system, and that's why we probably see that's what we see that is reflected in the annual employee surveys that we run in our healthcare organizations. Finally, the general public pays for unsafe care. All of us at a point in time will be patients, and so we will be recipients of care, safe or unsafe. But even if you are not the patient today, in most countries, the additional incurred cost of unsafe care is distributed to the general public financially and emotionally, and will be paid one way or the other. What this causes is a distrust in the system. Our challenges continue. Research indicates that 17 to 70% of CAUTI cases are preventable. Well, this is a really large spectrum, and that shows the lack of proper data collection and analysis. And still the number is significant. Preventable CAUTI cases cost an additional $450 million annually. Medication errors cost about $42 billion worldwide. 1 in every 20 medication administration results in an error. Hand hygiene compliance is less than 50% globally. I want to say something in a parenthesis. Yesterday, I had the pleasure and the chance of meeting a very brilliant physician here in the exposition area. If I'm not mistaken, she was from the Al Qasim Medical City and Hospital, and she informed me that they have been able to improve their hand hygiene to 82%. That is significant. That's amazing what they have done is brilliant because we know in America, the hand hygiene in some of our really great academic centers is not more than 40%. So whatever you've done, kudos to you, keep up the good job. WHO reports that patient harm reduces economic growth by 0.7% a year. So an example of a really good return on investment is patient engagement, which can reduce the harm by 15%. We have 4 strategies to zero. When I say we, I'm referring to the Patient Safety Movement Foundation. Actionable evidence-based practices or guidelines proven to significantly reduce patient harm and simplify the understanding of best practices. Data transparency so that we are able to identify the actual number of preventable medical errors and better track the progress towards zero harm. Aligned incentives to promote value-based care delivery models where provider financial compensation does not depend on the sheer volume of the cases, and clinical team can focus on delivering high-quality services across the continuum of care. And finally, creation of a national patient safety team as a multidisciplinary group of individuals to independently investigate major sources of harm in a non-punitive fashion. In the United States, Executive Office of the President has a council of advisors on science and technology. These individuals come from different disciplines and collaboratively develop and propose solutions to the President to address the most critical challenges of the society in different fields. In September of this year, just 3 months ago, President's Council of Advisors on Science and Technology presented a report to President Biden as a transformational effort on patient safety. They proposed 4 recommendations to help move the needle towards zero patient harm and better outcomes for patients and healthcare workers. It was recommended that they establish and maintain federal leadership for the improvement of patient safety as a national priority by appointing a patient safety coordinator who reports to the President directly. They also recommend establishing a multidisciplinary national patient safety team. It was recommended that our system need to ensure that patients receive evidence-based practices for preventing harm and addressing risks. They have recommended advanced interoperability of healthcare data and talked about improving safety of all healthcare workers and their patients through supporting a just culture. Third recommendation was to propose partnering with patients to reduce disparities and implementing a whole society approach while improving data transparency. And the final recommendation was to accelerate research and the deployment of practices and technologies by developing a national patient safety research agenda, harnessing revolutionary advances in information and technologies. It became even more evident for us at the Patient Safety Movement Foundation that our strategies to zero is meaningful as they all match with proposed recommendations to President Biden. Patient Safety Movement Foundation Chief Executive Officer, my boss, Dr. Michael Ramsey, who many of you may know as a world-renowned anesthesiologist, once said, "Our healthcare facilities should be safe havens for patients and healthcare workers, nor a danger zone." What do we do to get there? Awareness, advocacy, and action. General public is our biggest allies and the largest force behind making this change happen. We have to inform them and create the awareness around what can go wrong when they seek care and how they would be able to partner with clinical team to avoid and eliminate errors. We have to give a voice to our patients and patient advocates so that we can create a learning environment. Otherwise, errors happen in silos and this vicious cycle continues. We need to develop practical and realistic action plans to address our safety challenges with project plans that have been created in a thoughtful and meaningful way. There are 3 pillars to safety: incorporating a safety culture that requires a significant change in our current system and prioritizing patients' needs at the core. implementing culture of transparency, which entails involving patients in developing solutions from step one, and addressing the culture of inclusion that demands hearing patients' experiences and their goals, values, and preferences. There are some simple tools to help us with the journey to zero. We need to start with building a reporting system, if you already don't have one, that helps with a deep dive in root cause analysis. Then we need to make sure we allow a learning environment where people think of sharing failures as a means to improve. We need to run safety assessments in a systematic way. And if our team is making improvements, no matter how small, we need to make sure we recognize it and we celebrate, so we show that as leaders we are committed. And engage our patients, allow them to be part of the problem solving, hear their feedback, and build your actions on what matters to them. Creating change always comes with resistance and a series of challenges. Like a toddler who wants to walk, she falls many times, but in pursuit of something far more valuable, she tries again. Creating a change we talked about in our healthcare systems help us with building the awareness that currently lacks in our system. Our founder, Joe Kiani, said, take action out of kindness. And oh my God, these words, especially in the context of healthcare, is just so meaningful, because we all have came to this field to help. Take action out of kindness. Do the right thing. Stay on track. Be persistent. And the good will follow. At the Patient Safety Movement Foundation, we have a series of shared values as a common ground to unite our efforts in creating transformative changes in healthcare ecosystem and to move towards the zero harm. We thrive to establish a culture of safety, commit to culture of transparency, practice innovative solutions, incorporate evidence-based practices, advocate for safety of healthcare workers, develop resilience, and promote joy, humanity, and diversity in healthcare. I want to wrap up my talk with bringing attention awareness to something that Dr. Neelam beautifully and eloquently walked us through. At a point that we are trying to walk this journey towards zero harm, sometimes we encounter external challenges far beyond our healthcare organization. So resilience becomes exceptionally important. Incorporating patient safety initiatives in a normal situation of our daily lives is already a difficult task. That's why we gather here to help each other through this journey. Healthcare organizations and patients encounter difficult times, such as natural disasters that we have so many of them these days, from tsunamis and earthquakes, conflict zones, pandemics that we all experienced for 5 years with COVID, and economic challenges of the 21st centuries. They affect patient outcomes and patient safety initiatives. Delayed treatments, trauma, being continuously in the state of survival affects both patients and healthcare workers. While we make improvements in our systems, if there is something we can do to help other organizations and patients beyond our borders, beyond our healthcare organizations and beyond our region, perhaps we need to get involved and act. We believe that patient safety is a human right beyond borders. Thank you.
Thank you very much, Dr. Sanaz, for this valuable presentation. And let's go with our last speaker in this session, Dr. Peter Najjar. He is a medical director of clinical operation for Johns Hopkins Medicine's Armstrong Institute for Patient Safety and Quality, responsible for system-wide operational oversight, program building, and clinical innovation. He is also an assistant professor of surgery in the Ravitch Division of Colorectal Surgery at Johns Hopkins Hospital, specializing in the complex and robotic colorectal surgery. He completed his surgical training at Harvard's Brigham and Women's Hospital, Dana-Farber Cancer Institute in Boston, where he also completed the Harvard Medical School Fellowship in Patient Safety and Quality and served as a senior quality consultant. Dr. Najjar also serves on multiple boards, including Safe Tower Incorporation, an artificial intelligence enabling patient safety platform, as well as a priority partner, the largest medical managed care organization in Maryland. Please welcome Dr. Najjar to this presentation. Thank you.
Thank you. Thank you for the kind welcome. And again, it's a privilege and an honor to be here to speak with you today. I'll try to keep my remarks brief because I think I'm standing between the group and a break. So we'll spend just a few minutes talking about how to stay ahead of the curve on patient safety. I'll try to spend a little bit of time kind of talking about the practical ways in which we try to do this at Johns Hopkins back in the US. So we'll talk a little bit about the principles of high reliability organizations, and I think that you'll see yourselves in those principles, the organizational commitments that are required to act on those principles, and then we'll talk a little bit about what practical implementation of those principles when it comes to safety events and learning from those safety events look like, specifically as it relates to reporting, investigation, and accountability. So, ambitious agenda in 15 minutes. So high reliability organizations conceptually. So high reliability organizations share a few characteristics, and what these characteristics are really what requires an organization to behave as a high reliability organization. And I think that we'll all see ourselves in this set of requirements that are placed on our organizations. One is that they operate in unforgiving social and political environments. Things like nuclear power, commercial airlines, healthcare delivery. There's a spotlight on what we do, and the consequences of failure are very public and can be very extreme. They use complex processes to manage complex technologies with the potential for surprises and adverse consequences. Again, you can think of examples in a whole host of different industries where this may be true, but it's true in healthcare as well. We have limited opportunities for learning through experimentation. So in contrast to, say, a consumer technology company that releases an app, they may beta test something in the 1.0 version. If it doesn't work, it's okay. You spent $2 on the app, no harm, no foul. They'll get better next year. We can't do that in healthcare, right? We can't introduce a beta surgery, right? 1.0. It has to be kind of the full release version every time. And lastly is we have widespread accountability with sanctions for substandard performance. Nobody buys the app, no big deal. But in healthcare, if we fail to deliver our services, there are significant and appropriate sanctions placed on us, oftentimes officially through regulatory channels and governments, and perhaps more importantly, unofficially through our communities and the patients and the populations that we serve. So, needless to say, it's difficult to be forced to kind of adhere to these kinds of constraints. And sometimes when I stand and look at this, I said, gee, I should just make apps for a living. That'd be easier than what we do. But nevertheless, these are the set of requirements that we have to operate within. And so how do we cope with them? So this concept of a high reliability organization evolved to sort of characterize the types of attributes that are required in organizations who successfully meet these operational challenges. And what are these? They are, one, as a preoccupation with failure. That is, that we don't sit and wait for something to be a huge problem to act on it. We're constantly asking ourselves, in a high reliability organization, what's the next thing that can go wrong? And if something went wrong and there was no harm, we're curious because we're concerned that the next time that same thing goes wrong, that there may be significant harm associated with it. So we're preoccupied with the possibilities of failure. Two is a reluctance to simplify. So it's very tempting to sit in a boardroom or in a wood-paneled meeting room and sort of hypothesize and create elegant, simple theories to kind of boil the real world down. And we can't do that in healthcare if we want to be high reliability organizations. We have to really understand the complexity and the nuance, the variability in patient populations, differences in health literacy, all of these sorts of things that come into play in delivering a highly reliable service offering. 3 is that high reliability organizations are sensitive to operations. They are attentive to the front line where the real work is done. And I think, we've all, those of us who've worked on the front line, have all seen examples where a policy gets written that's completely impossible to practically implement in the day-to-day, right? And that's an example of a failure to be sensitive to frontline operations. It's something that sounded good in a meeting room and looked good on a piece of paper, but doesn't actually work in real life. And so we aim for the opposite of that in high reliability organizing, to be sensitive to operations and how the work is actually done. We pay visits, we speak with frontline providers, and we try to understand exactly what the challenges are and what's a realistic solution to a certain set of problems. The 4th is a commitment to resilience, and this is very, very critical because it's a subtle but really important difference between being resilient and being error-free. High reliability organizations deeply understand and accept the reality of human fallibility and error. They view it as not something to be avoided or minimized, but rather something to embrace and deeply understand and accept. And they design their systems such that errors and unexpected disruptions to operations don't result in harm and don't paralyze the system. So that's a very, very different mindset from sort of expecting things to be error-free. Systems that are designed with the expectation that error should not occur are very brittle. And when error does inevitably occur, those systems are paralyzed and they fail catastrophically. Systems that are resilient plan for and expect error to occur. And in many ways, error actually makes them stronger because it exposes variability that the system can learn from. And lastly, it's a deference to expertise, not hierarchical authority. And this is a very, very, this is an ongoing sort of cultural journey that high reliability organizations take where decisions and decision-making migrates to people with the most expertise, the most practical experience, the most knowledge about a particular problem or issue that requires a decision to be made. And that is not necessarily the most senior hierarchical leader in the organization. In fact, it almost always is not. And so while leaders take responsibility for decisions in high reliability organizations, they defer and they are heavily informed by the people in the organization that have the most experience and expertise, regardless of their position in the formal hierarchy. So this is the goal. And in order to pursue that goal, there are a whole host of cultural changes that need to occur within our organizations to be able to really live out the promise of what we call HRO, or high reliability organizing. And we think of these as sort of 4 legs of a stool. The first is a reporting culture. So if we're trying to solicit preoccupation with failure, we need people to be able to tell us and tell us openly when failure occurs. So we have to support that reporting culture to say, we're going to talk about things when they go wrong, and you're going to be rewarded for talking about them, not punished. And we certainly don't want you to sweep things under the rug. We seek to implement a just culture so that we thoroughly disaggregate blame from the outcome, so that we hold people accountable only for the decisions that they make that are within their control and not for outcomes that are beyond their control. And we make sure that people feel safe and supported and understand that they're not going to be punished unfairly or unjustly within the organization. The third is a flexible culture, to be able to adapt quickly to new technologies, changes, environmental demands, etc. And the fourth is a learning culture. And that's really about the speed with which we can convert lessons into actual operational changes, so that the organization actually learns in response to new information. And so at Hopkins, the way we think about error and our kind of journey to becoming error-free, whether or not we ever achieve that, what we're talking about really is not the avoidance of error, but it's really harm. And so it may be difficult, it's impossible to say that we're not going to make mistakes. It's impossible to say that we're error-free. But what we do try to target is the minimization and elimination of harm. And so when we have harm events, we think about kind of 3 layers of investigation and forward motion in the organization and response. First, we say never again here. So we report and disclose and investigate all harm events that occur and near misses that occur within a hospital. And we work very, very hard to try to make sure that within that environment they initially occur, that they don't happen again. And the next level up is to learn as a system. So we happen to have 6 hospitals and a handful of ambulatory surgery centers and a network of ambulatory clinics. And so what we don't want to do is wait for a risk or a harm that occurred in one hospital to occur in a second hospital before we prevent it from happening there as well. So we create a system-wide learning network across JHM and ideally the world to be able to prevent errors that occur outside of the walls of a given hospital or entity without waiting for those same errors to occur locally. So we say never again anywhere. And then kind of the final destination that we're all trying to reach is just to say never. And that's no preventable harm. And that's the only way that we can get there is to firmly establish a culture of safety that's rooted in these high reliability organizational principles that proactively seeks to understand and avoid the risk of error and harm. So this is in contrast to a reactive stance where we wait for something bad to happen and then we try to understand it and prevent it from happening again. That's great as the first step. But where we really need to land is to proactively seek out risk and eliminate it before it becomes harm. And we don't wait for the harm to occur before reacting to the risk of harm. Now, are we there yet? No. But this is the goal. And how do we try to think about that at the system level? You know, we like to think of ourselves as kind of a mini health system. We've got kind of all the pieces of that puzzle. And so we try to strategically bucket risk reduction activities based on an assessment of the unique gains and losses associated with centralization versus local autonomy. We want people to be locally creative and responsive to the unique challenges that they face and the unique resources and the microenvironments and microcultures that they operate within. But we also don't want to make everybody reinvent the wheel. So we think of everything that we do kind of on a spectrum at the Armstrong Institute, wherein we think about doing it for them, which is a centralized shared service. An example of that is our event reporting software. We're not going to expect each individual clinic to develop its own event reporting software. Fixed costs are high, and there's not going to be the expertise in software and artificial intelligence and machine learning and technology to be able to do that. So we do that for them. That's a centralized shared service. The second bucket is to do it with them. So that's shared resources for unique expertise in air support. Examples of that are human factors engineers. Where there's a redesign or a harm event or investigation, we deploy our human factors engineers. It's not realistic to have a human factors engineer embedded in every clinic and in every hospital. And so we share that expertise, and we do investigations collaboratively with our local entities. And then the final is really capacity building around local autonomy. And that's really kind of embedding expertise, embedding local QI professionals, teaching, enhancing the culture so that local entities, local clinic managers have the autonomy that they need to be able to react quickly and continuously learn and implement these HR principles, but they are supported in doing so, and they've got the tools and the resources that they need to be able to do it. And this is the last slide that we'll spend a little bit of time on, is what are the practical ways in which we kind of live this out, and how do you think about translating these high-minded concepts into really practical, deployed, day-to-day tools and operational protocols. And what we really try to do is to strategically use safety events to drive trust and improvement. And it's a little bit counterintuitive. I think there was a time in the past in which the impulse was to kind of hide safety events and errors and make people feel like an organization was safe, regardless of whether it was or not. There's a really wonderful trial that was put together by a friend and mentor of mine, Amy Edmondson, who's a professor at Harvard Business School, who pioneered this culture of psychological safety. And I love the story because it gives a counterintuitive result, but they followed the data, they followed the evidence and tried to understand it. And they did a study on ICU mortality and reported error rates. And unexpectedly, paradoxically, when they did this multi-center trial, they found that the ICUs that had higher error rates had lower risk-adjusted mortality. And this is a surprising finding to them at the time. It was very difficult to explain, and they thought at first, and if you listen to Amy Edmondson telling the story, they thought there was something wrong with their data collection. They thought that their data had been corrupted, or that the trial just hadn't been run correctly. And they sort of checked everything 3 times, and the finding held. And that's where they realized that actually the ICUs in which the errors were reported did not necessarily reflect the fact that the underlying error rate was higher, but rather that errors were reported. And then in reporting the errors, the ICU team could then understand them and seek to mitigate the risk of their recurrence in the future. And that started this whole kind of global movement towards psychological safety and using events to learn. And so this is kind of how we've practically implemented this. And when we look at this chart here on the right, we see all events. That's the actual universe of risk and events that occurs. And the reported events are green. So the first thing that we try to do is to get people to report events. And what I tell my physicians, for example, where it's always difficult to get physicians to file event reports. It's commonly viewed as kind of the nursing thing to do, and sometimes it's weaponized. We want our nurses to report, we want our students to report, we want our physicians to report too. And what I tell them is, listen, unless you want to sit through another boring patient safety meeting that doesn't address the problems that you actually care about, you've got to make sure that the yellow turns into green, because if we don't know about the events, if we don't report them, then we're not going to be able to address them, and we're not going to be able to put resources into them. Those reported events take reality, turn it into data. The data are useless without analysis. And so we take those data and we analyze them, we turn them into information that we can act on. And we act on that information. We learn from these events and we fix the system, and that results in safer care. And what we also do is we take that action, we make it very visible and transparent to the reporters. So we let them know, hey, listen, you reported this event, and here's what we did, here are the results of the investigation, and here's how it changed care. And that reinforces the culture of reporting, the culture of safety, the culture of reliability, the culture of learning, and it gets that green square to get a little bit bigger. So we get a little bit more data, and we get a little bit more information, and we can make care a little bit safer. And we do that through these very specific practical programs. One is our online event reporting software. It's a custom-developed piece of software that we're actually in the process of commercializing. That's Safe Tower, and full disclosure, I sit on the board of that. But it uses essentially Twitter-like algorithms to read natural language and automatically route and understand and categorize event reports based on a free text narrative report without forcing characterization, in much the same way Twitter or Facebook suggests tweets based on kind of what you're interested in, what you've read before. And it's a beautiful graphical user interface that encourages people to participate and report. We have a very comprehensive just culture implementation where we make sure that we don't punish people for reporting mistakes or having their mistakes reported. We investigate rapidly. We commit to doing 30-day RCAs so we can understand root causes quickly and feed them back to the reporters to keep that cycle tight and short. We do 100% mortality review, so every single inpatient death that occurs within our hospital generates an automatic required survey that goes out to the entire care team, nurses, respiratory therapists, physicians, residents, students who are involved in the patient's care. We pull that data from the chart, so the folks who interacted with the chart, and we ask them very simple but very focused questions about whether the death was preventable and whether there was any medical error associated with the death. And we investigate those in a very standardized way, in a very non-punitive way, so that we try to learn from every single death in the hospital. It doesn't mean every death is preventable, but we also can learn from the good deaths as well. And lastly, we hold ourselves transparent and accountable. So, a basic business principle is the power of what we call an unconditional service guarantee. And good service providers and product providers, they provide the unconditional service guarantee in order to force their own organization to absorb the externalities of error. And what do I mean by that? What I mean by that is, if a local unit manager doesn't, see the consequences of an error, then it's very difficult to kind of set that feedback system up so that we're incentivized to continuously improve. And if we just rely on the court system and medical legal systems and malpractice law, that feedback cycle is 5 to 7 years long, and it's inaccurate, right? The Venn diagram of people who are harmed by medical error and people who are awarded settlements and medical legal judgments, there's very little overlap between those. So we set up a communication resolution program where we proactively commit to, when harm occurs, or when an error occurs, that we disclose it immediately on recognition to the patient and the family, and we have coaches, and we sit with physicians and we coach them through these conversations, nurses as well. And we commit to investigating the error quickly, and we make the results of those investigations immediately available to patients and their families, oftentimes even in the form of the actual written RCA. We provide that to the patient and the family. And we make things right. Sometimes that can take the form of paying for a hotel for a family member for an extended length of stay because of an error that we made. Sometimes that means waiving bills. Sometimes that means ensuring that the follow-up ultrasounds that a patient needs to get because we lost a particular specimen are not billed. And it can include cash settlements in the case of our claims department agreeing that this is a potentially compensable medical event. We don't force families and patients to go through the court system, an adversarial system that destroys the doctor-patient relationship, and wait 7 years for the promise of some sort of financial compensation that may or may not come. And in so doing, we try to create a system that is closed-loop learning, that is reinforcing the types of behaviors and cultures that we want to see, and that rewards us for improving the quality and safety of the actual service offering in a way that is replicable and practical. And so what we try to do is view staying ahead of the curve on safety as both a moral but also a practical logistical imperative that we try to bring to life through strategic planning, careful and intentional development of culture, and implementation of practical tools, policies, and procedures. So thank you very much for your time.
Thank you very much, Dr. Najjar, for this valuable information. And now, let me invite you, Dr. Peter, can you have, and Dr. Nilma, Dr. Sanaz, please. Could you join me to this panel discussion, please? Have a seat, please. Okay, thank you all. Let's me trying this. Yeah, fine. Thank you very much for this valuable presentation. And it was very interesting to meet with you and discuss and ask some questions about your presentation. Dr. Nilma, you talked about the policy and intervention in FCV settings. And as you know, the patient culture is very important in this aspect. How we could address patient culture to improve and enhance the intervention that could help to improve the quality of healthcare services provided for the community or for the patients.
So if I understand correctly, that how safety culture could be applied to FCV settings?
Yes, from the side of patient culture. So as we have different policy and interventions. If we don't have a good patient safety culture, so that will not align and will not help us to improve and go furthermore to sustain and establish our intervention.
Thank you. So I think particularly the entire approach of openness and transparency is absolutely vital for safety culture. Because for people to recognize if in the service which is provided, particularly in the FCV settings where things may be very fragile, there may be risk of errors at every stage. So unless we have a culture of openness and transparency, people will not share those high-risk procedures or actions which have been taken. And if you don't learn from those weaknesses and those errors, you will not be able to improve. So openness and transparency for reporting, and as Dr. Peter Nijar also mentioned, extremely important to set systems accountability and individual accountability. So we have to ensure that the system design is such that it will address those weaknesses. Particularly in FCV setting, the situation can be very, very diverse. It could be war-like situation, or it could be handling natural disasters. So each situation will demand specific interventions. But when it comes to patient safety culture, transparency, openness, removing hierarchy, working as teams, and ensuring that wherever their weaknesses are in health system, when we are providing care in FCV settings, those need to be addressed in the design. So those are the principles I would like to apply as part of patient safety culture.
Thank you very much. If we back to Dr. Nilma, you talked about the strategies, vision and mission, and process that you think you're going to furthermore implement and to help in patient safety aspect. What about patient engagement? Do you think that patient engagement in any steps help to improve the quality of care and patient safety?
Absolutely. Patient engagement, not only helps, is that it's one of the most important pillars of reaching zero. We need to understand that all of us will be patients at a point in time. We all will be recipient of a care. And if you're not engaged, and if you're not partners with our clinical team, the change will not happen in a fast pace that we expect this to happen. When patients are engaged and informed, they will take the actions themselves to prevent the harm. If I understand that when I'm having a surgery tomorrow morning, that when I go to the pre-op setting, I share the medications that I take with my clinical team, I share the allergies that I may have with the clinical team. If I am engaged to a point that I feel comfortable asking my clinical team that, have you washed your hands? If I'm engaged in a point and have this awareness around the point that I need to make sure if the operation is supposed to happen in my right hand, whether they're actually marking my right hand instead of left hand, all these are steps that will help the clinical team to prevent the error. This is a two-way equation. As much as we expect our clinical team, physicians and surgeons, nurses, everyone else who in the front line is involved in providing the care, to be aware of the evidence-based practices, to be aware of steps they take to avoid harm and for patients to be the recipient of a harm. Simultaneously, we need to engage patients so they become partners. This partnership is exceptionally valuable. We have seen the improvements that that partnership has brought to healthcare, in our studies to healthcare organizations. And absolutely, this is a major pillar.
Very good, thank you very much. Dr. Peter, you're talking about the implementation of practical steps or used by Johns Hopkins in order to build trust and for the patient. Using, I think, as you said, the safety events, and you have mentioned about data. And we know that the accuracy of data is very important in any reporting. So how you could be assured about the accuracy of the data and the quality of the data in this process?
Thanks. So it's a great question. I want to kind of distinguish between two different types of data. So I think a lot of us in quality and safety are very, very comfortable using quantitative data. a numerator over a denominator, an event rate, a rate of surgical site infections, rate of falls, et cetera, et cetera. And event data is very, very different. These are free text narrative descriptions from frontline providers about things that went wrong or things that could have gone wrong, a piece of equipment that they have been missing, et cetera, et cetera. And that is quantitative data. And in order to use and understand quantitative data, you have to take a very, very different approach than you do with quantitative data. For example, we actually view the number of event reports that are submitted as a positive indicator of an improvement in culture. So more events reported doesn't mean that care is less safe, it probably means that care is safer. And we try to analyze the data in a way that makes themes become apparent so that we can understand, for example, if there's a general issue with medication safety in a certain unit. We analyze these free text narrative event reports using artificial intelligence and machine learning models to categorize them and pull out themes. We get about 45,000 of these event reports a year as a system. It's virtually impossible for a human being to read each and every single one of them. And it's futile to try to turn them into kind of quantitative data, turn them into event rates. So that's how we use safety event data, and that's how we guard against coming to the wrong conclusions because of inaccurate data. I think that happens when you use the wrong analytic techniques and the wrong framing. If we tried to pull quantitative performance data out of our event reports, I think we would run the risk of coming to the wrong conclusions, and that's why we use a completely different approach.
Very good. Any question from the audience? Anyone need to ask questions? تفضل يا دكتور.
Thank you very much. Beautiful presentations, and I enjoyed it all. My first question probably to Dr. Denji. I think one of the things that will cultivate a patient safety culture globally is to create a sort of a competition between different systems. So I would like to know what's your initiatives from a WHO perspective into highlighting probably and prioritizing what sort of patient safety issues that we need to tackle and how you're reporting on that. Because this, I think, will create a sort of a stimulus for different systems to be able to get engaged probably with the WHO efforts and probably to be more open to report. And maybe just a quick follow-up for both Dr. Peter and Mazouni. Also, I enjoyed your presentation very well. I think the issue of tackling confidentialities and its autonomy, how probably you rate this as a challenge, and how would you overcome this challenge to create the culture of patient safety between different organizations? So I hope my question is clear.
Thank you very much. Can I answer, please?
So, although a lot has been said about safety culture, just culture, but when it comes to actually implementing it or creating it at facility level, particularly countries which we serve the most, the low and middle income countries, where there are a lot of hierarchical barriers, a lot of cultural beliefs, it is extremely difficult to create a safety culture. Because until unless leaders empower each and every staff member and give them the assurance that they are not going to be punished, it is very difficult. So in high-income countries, there are some very good examples where their legislation protects the health workers. And until unless there is some sort of protection for health workers to report, they will not come out and open and report, because there's always a risk of being blamed and even to be singled out and punished. So fundamentally, we all recognize the guiding principle is reporting should be non-punitive, but in reality, it is very far from that. So till the time we create some protection mechanism for health workers, and the action lies both at the national level through legislations, but also at the facility level through healthcare leaders and managers by empowering patients. And what we are hearing, the theme of this conference is empowering patients and health workers, because we have to empower health workers and assure them that they are not going to be punished. If there is a real sort of issue of malpractice or a lack of training or lack of competence, which is individual accountability, that also needs to be fixed. But the individual should still be promoted to encouraged to report. There are certain countries which have incentives as well to report. So what WHO has published technical guidance on patient safety incident reporting and learning systems, and how safety culture is a prerequisite for creating a blame-free environment for reporting and providing a safe space for healthcare providers and also for patients and families to report. And in that, we recommend strongly that in countries which have nothing as of now, or we have very small number of centers which are engaging in it, start small in a stepwise manner. Maybe start with some big hospitals where there are leaders who can introduce it. Have some demonstration sites where you can introduce simple but effective strategies, and then those become role models for expanding it to from one center to multiple centers, and from a city to state and national level. Setting up at national level to begin with is very challenging. So it has to start in a stepwise manner to implement such systems. And safety culture is a fundamental guiding principle for any reporting and learning system. Thank you.
Thank you very much. Dr. Peter, if you'd like.
And if I understood your follow-up, it's sort of, if we want to be able to create sort of benchmarking, how do we encourage I think you were asking at the organizational level about encouraging transparency and mitigating risk and concerns about transparency. So I would say, I think that you do that with both with carrots and sticks. So the first is, remember, you don't need everybody to be transparent at once. There's always going to be a high performer. There's always going to be somebody, for whom either the organization is just a little bit further along in their kind of cultural journey, or their performance is really good and they want to brag about it. And so have them go public with their data, and let that stimulate questions to the organizations that don't want to be transparent about why they're not being transparent. Let those assumptions percolate, and oftentimes you can drive adoption by just having the tail end of the curve, the folks who are happy to be early adopters for whatever reason, go out and be early adopters and promote that transparency, and sort of shame the other institutions into following along. That's not ineffective. It works. The other thing is, I can tell you stories, that we've challenges that we faced at Johns Hopkins specifically, where, I'm a surgeon, I teach my residents that, one of the reasons why we like surgery is that, you can't hide your mistakes. Like, eventually they're going to become apparent. And I think at scale for health systems, that's also true. And so, being non-transparent, hiding poor performance will work for a time, but there's a global trend towards ease of access to information, social media, democratization of decision-making and involvement of communities and empowerment of individuals. And, eventually, in this kind of pressure cooker environment, if you're perceived as an organization that knew something was going wrong and then you didn't kind of, report it, you didn't work on it, and that thing sort of explodes in your face, either through regulatory harm or reputational harm, or in the media, or because of a devastating medical legal settlement, these things can end up costing hundreds of millions of dollars. There have been recent settlements in the US that run over $1 billion. And so, you can really convincingly make that argument to even the most cynical sort of, quarter-to-quarter minded operational leader to say, listen, if we're not being open and honest and transparent with ourselves at a bare minimum about the quality of our performance and about the rate of our errors, it's only a matter of time before this insidious risk kind of builds up and explodes. And it's like a massive liability on your balance sheet that's invisible and unmeasured. And in many ways, even the most kind of hard-nosed, business-minded folks can understand that. You do not want massive, unknown, unmeasured liabilities on your balance sheet, and that's what a lack of transparency and a lack of commitment to safety culture will inevitably produce.
Thank you very much. Dr. Nima, do you have anything to add, please?
I absolutely second what Dr. Najjar mentioned. If I want to add something to it, is two things is that the new generation, Gen Z, will want us to make this change happen. These are very different human beings we will soon see as patients, and this generation is very different than my grandparents' generation. My grandparents' generation were going to a hospital or a healthcare system, a physician, and they would barely ask maybe 2 questions. They would just follow through. The new generation, with the power of social media and with the power of the awareness and the knowledge that they have, they want to know what is this health system that I want to, if I want to have a surgery, even if it's an elective surgery, if I want to be seen, the first thing they do is to see the reviews of that healthcare organization, to see the reviews of this physician. They're not going to randomly just show up at someone's door. That's one. And 2, you mentioned, I think, in your question about confidentiality when we are addressing adverse events. At least I can share from the work we do at Patient Safety Movement Foundation, because we do work with a lot of healthcare organizations, to create that benchmark and to address this as a global phenomena. We really don't need to, thankfully, get into details of every single patient's harm to a point that we encounter HIPAA non-compliance in the United States. We are looking at these numbers in clusters. So when we work with an individual healthcare setting, we say like, okay, how many sepsis cases you had, and then we assess what percentage of it was preventable, what are the cases. So from that perspective, we've always tried, and it had worked really well, to keep the confidentiality of the cases from the individual perspective. Also, when we develop the benchmarks in our system, we again try to keep the confidentiality of each healthcare setting also, to a point that they don't feel like, oh, if Johns Hopkins, for example, grades are higher or lower than a competitive healthcare setting and hospital, then they're going to lose their patients to the other healthcare, and it becomes a financial game for them.
Thank you very much. One more question from the audience, please. Okay, please. Anyone? Yes, please. Short question, please. Short question, please.
Yeah, thank you very much. It's like a comment more than a question. We have seen the motto of the conference and other presentations saying from awareness to actions, from advocacy to actions, from vision to reality. All these are very nice as elaborated. Now, we know actions, the most important and ultimate actions are taken in hospitals and facilities that provide health care. I would have been happier to hear the experiences of the hospitals and health facilities, that the struggles they are going through and their successful stories regarding patient safety. We know that in the United Kingdom, safety and human health is given a priority. And I quote the King Salman saying, صحة الإنسان وسلامته أولا. That is very important. And subsequently, we have the Saudi Commission for Health Services, health specialties. We have Sibahi, we have the Patient Safety Institute, recently joined, and a lot of legislations and like. And we need to know where we were before and where are we now. I mean, in Saudi Arabia, in terms of data, our achievements, and even for those young generation or young researchers to know and to take over the next steps. Really, there are a lot of efforts, but for me, maybe I'm not directly engaged in patient safety business, but we need to know where we were and where are we now. I haven't seen any data. We have seen data from America, data from other countries, but from Saudi Arabia, I haven't seen yesterday and today. But we are doing a lot of efforts regarding patient safety. Thank you very much.
Thank you very much. Dr. Nima, would you like to?
I'm actually not sure about the question because the audio is not very good. There's a lot of echo, so if you can repeat your question, please. Is it to myself or to other panel? If it is
if you allow me, thank you very much. I may take this question just to get you out of the embarrassment or the. Thank you for the question. I'm Dr. Asiri, Director of Patient Safety Center. The question was about the Saudi data and efforts in terms of improving patient safety. So I have to say that this is a very important question, and it's something that we are aware of. And you know, we are, as other parts of the world, we have a lot of challenges. However, we believe that the transformation efforts that are happening in the country have really unified the approaches and efforts to improve patient safety, as it is also true for other aspects of healthcare and other fields also in the country. We have plans, and you know, we have pockets of data in some of the specific programs or specific sectors. However, we are trying to get alignment with all sectors in the field in terms of patient safety. So we have initiated studies to assess the situation now in the country. And also we are working with most of the sectors in the healthcare to ensure that there will be sort of, I would say, a country approach instead of a specific or single institution approach. So what I could say in short, I'm aware of time limitation, is that hopefully next year conference, we will have data that will answer in numbers your question. Thank you very much.
Thank you very much, Dr. Ali. I think establishing the Saudi Patient Safety Center, I think is one of the transformational initiatives, and that will help also in improving the patient safety in future. In one word, please, as you know, patient safety is lead to a better healthcare outcome. In one word, how we can reach to better healthcare outcome. In one word, please. Thank you. Yes, yeah, in one word.
It is leadership and leadership and leadership.
Very good.
Transparency.
Transparency, fine.
Following evidence-based practices.
Okay. Thank you very much. Thank you to joining us, and hope to see you next year, inshallah. Thank you.
Because of time, we'll start exactly in 5 minutes. Exactly in 5 minutes.
Good afternoon. Welcome. We okay? Yeah. Hello, everyone. Welcome again to Track A. If you were here for the session before, welcome to those from Track B, if you've moved across and joined us. I'm John McGee. I am Director of Policy and Knowledge at Value and Health in Riyadh. We're a health policy think tank. And today I've got the great pleasure of introducing this session on workforce safety. I was so excited to be asked to facilitate this conversation around what is truly foundational in patient safety, the human factors and how we treat and manage our workforce. Before introducing our first speaker, I'd just like to acknowledge the reality of the situation. We are towards the end of the conference. We have one more set of sessions to go. I don't know about you, but my brain is full of different thoughts and ideas from the last few days. I'm going to offer you a gift before we start. And that gift that I'll offer is just a second or two to reflect on what do I want to get out of the next hour. The one thing I can assure you of is this: you won't get the next hour back. You've chosen to be here for an hour, and I can assure you we've got three terrific speakers. We'll give you some great insights on workforce safety. So just take a second to reflect. What questions do I have around workforce safety? What would be a great outcome for me from the next hour? So thank you. So with that being said, it's my great pleasure to introduce Dr. Sodzi Teti, who's Vice President Global Delivery, providing strategic, technical, and leadership and business development for Africa and Middle East regions. He'll be familiar to anyone who attended his workshops in the pre-workshop, the pre-conference sessions. I know Dr. Sodzi, I've read much of his work, so it's going to be a terrifically interesting presentation. So, without any further ado, please welcome our first speaker.
Thank you very much for your very kind introduction. And as we know, getting to the tail end of the conference, it's only the most faithful who will then stay to the very end. I'll try and keep things moving. So just to thank colleagues at the Saudi Patient Safety Center for the opportunity to present on a very important topic of how we can promote the joy and well-being in the workplace. Increasingly, there's a recognition of the fact that we need to pay equal attention to the health workers who deliver this great work, even as we try to provide safe working conditions for patients. And indeed, as I prepared for this session, I was very happy to learn that as part of the big transformational agenda in Saudi Arabia, there is an ambassador for happiness. And there's a whole quality of care program that is underway where there's a recognition that with happiness, positivity, and cooperation, we will be able to create a better working environment for everybody. And that became a good guidance for me as I put this together. But today I'm going to start with a story. And it's going to be a story about a Ghanaian pediatrician. And as we tell this story, we would realize that it is not unique to this particular doctor, but the circumstances affect all of us as health professionals. And I'm going to end with 5 short lessons that we can take as we try to promote the joy and well-being of healthcare professionals. So this is Dr. Frank Boateng, a Ghanaian pediatrician. He was also the medical director of a hospital. He was very loved by his patients and his colleagues. He often went over, above and beyond in his attempts to deliver high-quality care, and he was very well respected. As a medical director, he was just 40 years old and bustling with life. Sometime in June 2020, he developed some signs and symptoms suggestive of COVID-19. And as the investigations were ordered, he was quarantined at home so that they would await the results and manage him accordingly. At home, his condition got progressively worse, and
he was being managed at home, and for whatever reason, he was not sent to the hospital. One morning, they found Dr. Frank Boateng dead in his bed. 8 days later, his senior brother, who apparently was involved in his care, also succumbed to COVID and died. It was only after Dr. Frank Boateng died that the PCR results came back positive for COVID-19. But by then, of course, it was too late. As improvement specialists, I'm sure we will begin to ask ourselves, what killed Dr. Boateng? We would say that, well, clinically, it's maybe death from COVID-19 and hypoxia. But as we drill down into the root causes, we would look at personal circumstances, and then we would also consider health system barriers. Personally, we may say that perhaps he underestimated the risk. Perhaps he was scared. Maybe he was exhausted from too much work. Maybe he had comorbidities that were not acknowledged at that time. Maybe he was too compassionate, not taking steps to protect himself, even as he looked after patients who were unwell, and so he got COVID-19. When we look at the health system barriers, perhaps there were issues of supplies. There were delays, for sure, why it took him to die first before the lab results could come in. And these were attributable to issues with the health system. Perhaps there was no ambulance system to transport him from home rapidly to the hospital to where he needed care. But as we consider this, let us reflect on the own circumstances under which we work. But at the end of the day, if you look at it at its most basic, this is what I think killed Dr. Frank Boateng. That Dr. Boateng was nothing more than a qualified and compassionate health professional in a flawed health system killed by a little-known disease. Qualified and compassionate. And I think that that is something that we can all identify with. We are qualified, we are working with compassion, we are going over and beyond for our patients, and in so doing, we are exposing ourselves to all kinds of risks. So if today SPSC wants us to talk about promoting the well-being and the joy of the healthcare workforce, then we very much are at risk of suffering the consequences of what happened to Dr. Boateng, which means that we are not particularly unique. And a huge bit of it relates to the pressures that health workers feel mentally. So recently, the Lancet did this publication, did a systematic review of the burdens that are faced by various health professionals as they deliver their work, especially in the heat of emergencies and pandemics like COVID-19. And what they found was that health professionals suffer a disproportionately high burden of mental health conditions. And they also have higher suicidal ideation and lower well-being compared to the general public. We are working in high-risk environments that expose us to all of these things. Many of us may know about Edward Deming, one of the fathers of improvement. And he said that people are entitled to deriving joy from their work. And he says that the overall purpose of managers is to create the environment where people get joy and satisfaction from their workplace. Now, how are you going to be able to get joy if you do not have the tools that you need to work with? How are you going to get joy and feel well at your workplace if you don't feel that your supervisor understands the conditions under which you work and is willing and able to give you the support that you need? How are you going to have joy if you do not have satisfactory working environments? And how can you have joy if you are constantly faced with moral injury? And moral injury is when the places that you are working in are so tough, the circumstances are so difficult, and the choices so hard that sometimes you feel like you are being forced as a healthcare professional to take decisions that are against your own values and your own beliefs. And I spoke to many health workers in the advent of COVID-19 who felt that they were being driven to care for patients and to do things that they would ordinarily not do because they had no control, and they felt like they were being put in the uncomfortable position of determining who should live and who should die. And so many of us are faced with the reality of burnout. And within healthcare professionals, you would know people who have increasing episodes of substance abuse, suicide, depression, and it's not just restricted to the individuals. Within the healthcare system, we are seeing increasing number of medication errors, patient satisfaction going down, and high staff turnover. And so then the question is, as we work with the health professionals, we are no different from the ambitions of general people in the public. People have basic physiological needs. How can we create an environment at work where individuals feel supported and are connected to a higher purpose in terms of what the healthcare system is trying to achieve? And that is the challenge that we are faced with if we are going to promote the joy and the well-being of the staff. In conclusion, I will focus on what we can actually do in terms of actions. And here, we need a mindset shift, starting with the thinking in the old models that when people face burnout, when people come across depression, when people complain about their areas of work, it's because as individuals they are weak. It's because these matters are the responsibility of HR. It's not everybody's work. And to move to a new thinking that it is actually the system that needs to be created to support these individuals, to make them strong and supported to be able to execute this work. And that indeed, we need leaders at all levels of our health system to be responsible for creating a nurturing environment for health workers to be able to thrive. And that healthcare workers thrive in an environment where they feel they are doing good, they are creating better health outcomes, they are getting better results, and they are connected meaningfully to their work. And it is not just a matter of giving staff more money, which is how sometimes people think. Then, as we focus on the individual, the recommendation is that we as healthcare professionals need to pay more attention to ourselves. Sometimes we will prioritize our patients above everything that we can do for ourselves. And so self-care is very important. Whether it means prioritizing your continuing professional education, whether it means taking vacations, whether it means spending time praying because you want to connect spiritually, whether it means exercising, all of these things are important. And you don't have to feel that you're doing anything bad when you begin to take steps to be able to look after yourself. It is okay. And sometimes to knowing your boundaries. If you are tired, at some point being able to say, no, I can't go any longer. I need to be able to sleep. That self-care is important instead of feeling like we have to go over for everybody else at the risk of losing ourselves. And that brings me to the first lesson, which is that we need to reframe, that is, change our thinking and prioritize our own care because it is important. The second one relates to huddles, where we have multidisciplinary teams, managers meeting with staff. And this is borrowed from a project we did in the Western Cape province. Huddles, meeting for half an hour every day, looking at the realities of the problems that the health professionals are facing, with managers taking a step to be able to support them, to be able to address it. And in a survey that was taken, as much as 70% of the health professionals said they felt better supported when they were able to connect with their managers to understand what their daily needs were and to take steps to be able to address it. Which brings me to the second point, which is that we should proactively manage fear and anxiety in the workplace. And that is really for managers. By making yourself accessible, making yourself available on the floor, connecting with the workers and understanding what is of the greatest concern to them, you will be able to proactively manage their daily work. This is an emotional well-being survey. And by taking it, you get to understand what are the concerns, what are the fears, what are the anxieties of various healthcare workers. And you begin to take steps that address issues of their well-being. So yes, it's good to talk about happiness, it's used to talk about burnout, but there are ways in which you can deploy tools that help you to actually diagnose the problem. And so the recommendation is to implement a measurement plan to be able to get feedback about what really is of concern to the health workers and move beyond measures to take steps that would address the concerns of health care workers. This is an example I plucked from the Royal Free Hospital in London, and they were experiencing a very high attrition rate of 47%. And what did they do? They realized that nurses were leaving in large numbers. So then they got the nurse manager to set up coffee breaks where she would connect directly with the nurses. They also realized that they were a bit too rigid in the way they set their shift system. So they made it flexible and gave the nurses the opportunity to decide which shifts will work for them or not. They also created some electronic appointment systems where people would book whatever works well for them. And then they started celebrating individuals, employee of the month, and so on and so forth. That completely changed the atmosphere, and attrition rate was halved in the Royal Free Hospital. Sometimes these things sound so simple, so, something that is easy to do, but if you don't do them, the cost is really very high. And that brings me to the fourth point, which is that we need to ensure psychological safety and allow people to be able to express their true concerns and not feel that they will be punished or they'll be victimized for expressing their concerns as we address their mental well-being. It shouldn't be too difficult to even provide a clinical psychologist who is available also to the health professionals, because like everybody else, they're equally susceptible, so that they can go and seek care and not for that care-seeking behavior to be seen as a sign of weakness. And I believe that brings me to the last point, which has to do with how we can take steps to ensure psychological safety. One, for leaders to be able to demonstrate humility, which is that we need to be able to frame the work and show that we have a deep understanding of the complexities and the challenges that health workers are confronted with, so that we can then work with them to craft solutions together. That takes us to curiosity, which is that we open the platform for people to be able to honestly express their views and not be afraid of any critical comments that they will be able to make, because then we want to create systems together. And finally, not to leave it at just soliciting feedback, but to be able to act genuinely on it to address what they have talked about. And that will take me to the final point, which is that we have to create these opportunities for people to connect to what they are doing. We need to believe that at its very core, health workers want to do good. They want to save lives. They want to help people. That is what they want to do. And so as managers and as health professionals, whatever we can do to help ourselves and to help the people whose work we supervise to be able to achieve the objectives, the better it will be for all of us. And so these are the 5 take-home messages that I have just gone through, as I said at the beginning. And in conclusion, I want to quote Saudi Arabia's Ambassador for Happiness, who says that involving employees in the work environment improvement plan based on survey results creates an environment of shared responsibility for workplace culture and improvement. Once again, thank you for the opportunity.
Thank you, Dr. Sodsi. I think if you're like me, you take a heightened expectation out of that presentation for the level of joy that we should be able to expect in our practice and in our day-to-day work. I think there's something really interesting about treating the symptoms of the stressful, exhausting conditions in which we work versus potentially addressing the causes, which we may touch on in the next presentation. I'm delighted to introduce Dr. Mohammed Al-Nakawi, talking on the topic of re-energizing healthcare providers, innovative approach to combating burnout. Dr. Mohammed is a psychiatric consultant, head of the addiction department at Arada Complex for Mental Health Hospital Dammam in Saudi Arabia, and director of Saudi Board Program for Psychiatry at the Arada Complex. So welcome, Dr. Mohammed.
Assalamu alaikum. good afternoon. Actually, I have a big challenge to present this lecture after Dr. Tsotsi. He had a nice presentation, and he covered most of the top of the things I will talk about. Talk about. Let's start. When I think, I wanted to ask you one question. If we sit with any people outside healthcare services, I think they are thinking we are very happy because they think the healthcare provider, they have good income, they have good prestige, maybe they have comfortable work. Do you agree with this idea about people who are not in our field? No. Huh? Yes, you are true. Actually, anyone outside our field, and they saw us from outside, they are thinking we are happy, have a good income, we are living a good life. But in reality, there is many things they didn't know. Even when Dr. Sati, he mentioned about suicide. I will talk about that. Some healthcare providers, or many of healthcare providers, they are suffering from minor stressor to big stressor. When we talk about physician wellness, it's more than the absence of disease. It's not only stay away from disease. It's maximizing the quality of life in this way. How to improve your quality of life, physical life, mental health, social, all of these we have to take care of it when we talk about wellness. You have to ask yourself this question: how much you enjoy yourself, how much you feel your work makes a difference in people's lives, the quality of your relationship with other people, most important to you. Physicians have unique stressor. If we can talk about stressor, we can divide the stressor into two types: acute stressor or chronic stressor. Acute stressor like patient morbidity and mortality, especially who's working in ER, ICU, they are dealing with critical cases. Medical error, system dissatisfaction, license restriction, malpractice, lawsuit. Chronic stressor, there is a lot of chronic stressor like difficulty emerging from job. Some healthcare provider, physician, nurses, and other, they even when they leave their work, they still preoccupy with their work, they are thinking about their patient, even if they are not on call. Workload compression, professional isolation, and as you know, the impact of COVID-19 on all healthcare professionals. As you see here, burnout rate, up to 60% in late 2021 compared with 45% in 2019. Burnout originally used for the engine malfunction at the beginning, but in mid-70s, it described to stress syndrome. It comes with many symptoms like exhaustion, frustration, anger, carelessness, feeling of ineffectiveness and failure. It has a negative impact on performance for healthcare provider and loss of concern or interest in their patient. The impact of burnout not only in the healthcare provider, but also there is impact on their patient, and we will see. Burnout syndrome. WHO officially it's recognized by WHO with ICD-11 as a syndrome that results from chronic workplace stress that has not been successfully managed. It has three triads or three components, which is emotional exhaustion, depersonalization, decreased sense of personal accomplishment. What do we mean by that? In personal exhaustion, there is loss of emotional resource, unable to deal with the patient and work demand. They start to feel unrecognize their emotion even toward themselves or toward their patient. Depersonalization, it comes a lot of empathy with the patient and deal with the patient as a case or disease or just number. They have medical file number, no empathy, no emotion. need to ventilate about patient or work in sarcastic way, decrease career satisfaction. They start to have a doubt about meaning and quality of their work. They start to ask about themselves. Is there any meaning for my work? Why I'm doing this? Fear of mistake and their consequences. And they will be preoccupied with mistakes, especially if they have high burnout. There will be a lot of medical error they can do for the patient. And if you compare men and women, we will see women are more likely to report emotional exhaustion. On the other hand, men are more likely to describe depersonalization. Burnout syndrome are reported to range from 30 to 60%, different from one specialty to another. For example, critical care physicians are reported at 53% burnout. Who's working in emergency medicine physician, they are reported up to 52%. Other specialty like psychiatry, pathology, and dermatology had lowest rate, which reached up to 37%. Who is the most at risk? Personal characteristics that play a big role in as a risk factor. Whose idealism, perfectionism, preoccupied with detail, they are more risk or more prone to have burnout. Even in our clinic, psychiatric clinic, we notice most of the patients who are suffering from anxiety and depression, they have some of these criteria. Spouse working in healthcare, this last point, younger age, burnout decrease with each additional year. Actually, this information was surprising for me. I was thinking, when the healthcare provider start their work, start their career, they have high motivation, the percentage of burnout will be low. But there are some studies show the opposite. They said burnout decrease with each additional year. The explanation for that is with time, they become more wise, they have more coping skill to deal with, that help them to deal with stress. A sign of burnout, there is some sign and symptom we can, from this sign and symptom, we can know, you can know if you have some of them, or one of your team or your colleague. Decline self-care, fatigue, change in weight, decrease, change in weight, either increase or decrease. Some people under stress, they have emotional eating. They will eat more. And on the other hand, some people will decrease their weight. Performance, decrease in performance or workaholism, apathy, irritability, easily provoked even with their patient or with their colleague. Affect control, difficult in managing emotion, relation. They are struggling with other relationship and socially isolation. In addition to that, it will affect their sleep, insomnia, fatigue, headache, GI symptom, impaired job performance, poor health, and lead to physician error. Unfortunately, sometimes burnout may also lead to increased alcohol or drug abuse, and we saw some physicians in our clinic, they have this problem, substance use disorder. In addition to that, there is decrease in productivity, staff conflict, high physician and staff turnover, short and long-term manpower instability, that which lead to economic, social, and psychological costs to employee and employer. There is, unfortunately, there is a relationship between burnout and suicide. Can occur in any profession that are more than twice the general population. The possible cause, as we mentioned before, emotional stress, sleep deprivation, patient death, long work hour, bullying, especially with 937. Most of the physician or healthcare provider, they are under stress of this number. Sometimes, any patient, they can call this number, and they can, you will be preoccupied with how, with that problem, and you have to answer and explain why you did this and this. Causes of burnout among healthcare provider. There is many causes. For example, electronic health record. As you know, sometimes that will affect the relationship between you and the patient. You will be preoccupied to enter information, progress note, investigation. This will affect the good communication with the patient. Time pressure and workload. More than half the healthcare provider report feeling stressed because of time pressure. Sometimes administrative tasks. Physician reported nearly 50% of work day are spent on administrative tasks, loss of connectiveness with other people, sleep deprivation, staffing and stability. Having a full staff team decrease burnout, and staff turnover increase risk of burnout, also workload. This, we have this survey, which is Mass Large Burnout Inventory, MBI-9, which provide a quick survey tool to judge physician state of burnout. The results scored on 3 axes: depersonalization, emotional exhaustion, and personal accomplishment. We have 9 questions. Each 3 of them will cover one of the triad we mentioned before. And personal accomplishment, if it is below 14, it will be low burnout. If it is, if it is above 14, it will be a low burnout. If it is below 13, that means he has high burnout. Regarding depersonalization, below 4 is low, above 6 is high. Emotional exhaustion below 7 is low, and above 10 is high burnout. Also, there are another self-test you can see in the web. How do we cope with burnout? We can divide the people in dealing with burnout into 2 groups: either adaptive response, or some of them they have maladaptive response in isolation, overeating, poor diet, alcoholic, or substance use. Strategy to deal with the burnout syndrome. First of all, you have to assess yourself. You have to ask yourself about your current situation. Identify the professional goals. You can ask yourself, why did I become a healthcare provider? It's by chance or by choice? What do I like most about my job? What motivates me professionally? By the end of my career, what 3 things do I hope to have accomplished? Anticipate challenge regarding what the challenge you expect in your work, either administrative issue, inadequate staffing, promoting pathway for continuous education. Also, achieve the balance between your personal and professional goals. You can ask yourself, what is my greatest priority in life? Have I been living my life in a way that demonstrates this? What person or activity have I been neglecting? If I could relive the past year, what would I spend more or less time doing? On the individual level, there is many things you can do. As Dr. Sotsi, he talked about self-care. By doing mindfulness, meditation, communicating with others, exercise, healthy eating, and practice some hobbies. On organization intervention, there is many things they can help their staff by call scheduling change, reducing time spent in on inpatient services, protected time meeting with leadership. For the time, I will. This last slide. Other intervention, like identify local factors that could be rapidly altered to improve physician burnout and satisfaction. Physicians must participate in designing change. Celebrate achievement, as support peer through challenge, mentorship, share leading experience and downtime, support culture, art, sport, conversation, last thing, design workspace that foster interaction. Thank you.
Thank you, Dr. Mohammed. The third, I think, of three super interesting and complementary talks in this session will be given by Dr. Ziad Naqshbandi in his capacity as the Chief Executive Officer of the National Centre for Workforce Planning. Dr. Ziad was formerly Chief Academic Officer of the Saudi Commission for Health Specialties and speaks as a clinician, as a paediatric urologist by training. We'll be talking on the topic of tackling the challenge of the global staff shortage. Doctor.
Assalamu alaikum. Thank you very much, John. I think you gave me the most difficult task of the day, to speak about workforce challenges in less than 15 minutes. I'll try to be precise as much as possible, especially after hearing from my previous colleagues about their beautiful, beautiful talks. So I think before I start, the most important thing that we want to focus on, how we're going to be able to foster a culture of patient safety within our ecosystem. And I think in order for us to do that, we need to articulate this with the main reasons for health sector transformation, which is prevention and well-being. And if we want to link this to the value-based healthcare that we're providing to our society, we want to achieve the best quality of care with the lowest cost. So to start with, I think the main engine to drive this health sector transformation are the healthcare workforce. Just to give you a bit of a brief about the work that we're doing. So the Saudi Commission main vision is to have an efficiently healthy society. We're doing this by protecting and promoting health, led by health practitioners who serve the community efficiently and humanely. And for the purpose of our meeting today, I'm going to focus about the main three objective tasks that we do. Of course, everybody probably in this room knows that the Commission oversees the regulatory prospect of postgraduate health training and education in the Kingdom, as well as being involved with regulation of health practice, professional practice in the Kingdom. More recently, the Commission linked one of its mandate objectives, which is the workforce planning, to those two main core businesses. And I'm going to show you how this is going to be very important, because it's going to be the main essence of tackling what kind of workforce the Kingdom will need for the health transformation. In approach to tackle the challenges, I think we're going to focus about these main objectives. Figure out what are the gaps in our system, how we can set a change agenda, and then probably align with the ecosystem to have some sort of solution to overcome these challenges and make a national impact. So bear with me, please. I think I'm going to probably elaborate on some of the challenges that every healthcare system in the world faces, and it's not exclusively for the Kingdom of Saudi Arabia, but these are probably more related to the environment that we're working in today. We need always to monitor the demographic changes and the burden of disease in our country, because it's going to be very important to anticipate what sort of a market demand needed in healthcare workforce to prepare ourselves. The second, we need to be adaptive to the rapid technological advances that are happening in the healthcare sector. I think everybody is hearing about robotics, artificial intelligence, machine learning. All of these are going to impact our future workforce. So how these challenges can be met? The changing workforce roles. We're hearing about multiple new roles that the system is acquiring in order for us to move toward the future. So how are we going to adapt to these changing workforce roles and we have and be able to have a resilient workforce practitioners working in multiple areas within this health sector transformation. We need to have a unified visions. Whenever we set our targets for workforce planning, we need to have a unified vision between different sectors, vertically and horizontally, within the health sector and outside the health sector, in order for us to move forward. We need to rely, and I think everybody can understand the importance of data whenever it comes to workforce. So the data not only pertaining to the workforce practitioners themselves, but also to those who are encountered within healthcare system and those who are going to provide some sort of solution to push the workforce in a more efficient and productive manner. I think one of the most important things that we need to focus on are the shortages and the maldistribution of health workforce between different sectors, different regions, different cities, different entities, and link that in a strategical fashion to move forward. Quality of the skill set and mix. We're speaking now not about a single profession. We ought to think now in an innovative fashion to have a sort of a team-based approach to our healthcare system. So we don't think about physicians in isolation, we don't think about dentists in isolation, we don't think about nurses in isolation, we don't think about allied healthcare workers in isolation, but how we can have a teamwork working together with the proper skill mix to achieve the value-based healthcare that we enlisted initially. And finally, I think it's very important to have an alignment between different stakeholders, and probably I'm going to shed some light on that as we move on. So, what sort of work that we have been doing over the past year or so? We did a sort of a current assessment, stakeholder analysis, benchmarking study, and external environmental studies, and we came up with 5 main common perspectives to identify how we can approach the workforce planning for the future. Number 1, we need to have a very clear governance scheme that starts from the top decision makers all the way to the provisions. Number 2, we need to rely on data, and we need to have some sort of ability to collect this data, analyze it, and then report it again. Number 3 are the capacity planning, And here what we mean by that, we need to approach our workforce planning in a demand-oriented approach rather than focusing on the supply, so that we would be able to identify what sort of gap in the system and try to fulfill it in a reverse manner rather than focusing on the supply as the main initiatives to plan for the future. The 4th are the capabilities. So what sort of skills, experiences that we're going to rely on? It's not going to be only qualifications. It's not going to be only certificate, but what sort of experiences and skills that we need to equip our health workforce to move forward. And finally, what sort of innovative approach that we need to tackle our system with in order to let it a little bit move more in a more resilient fashion to tackle all the challenges that we face in the future. So just bear in mind, those are probably the 5 most important perspectives to tackle workforce as we move forward. So in our center, which is the National Center for Workforce Planning, under the Saudi Commission umbrella, we're trying to do some sort of cultural change, moving from the current status to the future. And we determined 7 dimensions. Number 1, we need to align with the Vision 2030 objectives. And that will push us from a fragmented efforts to aligned health workforce planning, always aligned with the Vision 2030. The second is that we have a unified governance scheme for workforce planning that probably move us from lack of a national strategy to a strategy which is national and based on the country whole perspective. Thirdly, we need to have a stakeholder engagement, so moving from an absence of engagement to an active coordination and systemic engagement. Data and research we should move from an insufficient and reliable dispersed data to a reliable, live, and dynamic data. We need to, in our forecasting and modeling for the future, move from a reactive planning to what we call a demand-led, adaptive, and evidence-based health work simulation and forecasting model. And from a policy perspective, we need to move from an holistic approach to an innovative, agile approach. So I think in order for us to achieve this, and this has been highlighted in many of the talks that I heard over the past 2 days, is the stakeholder engagement and how this is going to be linked to the Vision 2030. So everyone who's attending in this room, I would like you please to think about what you can contribute from your individual perspective and how this is going to be linked to the Vision 2030. And just to highlight how we are approaching this from a strategic level, we do have main 2 important pillars in the Vision 2030, which is the vibrant society and a thriving economy. The first level overarching objectives of these 2 pillars are offering a fulfilling and healthy life and increasing employability. If we move to the level 3 objective, which is the health sector transformation main goal of improving prevention and well-being, basically it focuses on easing of access of healthcare, improving value of healthcare, ensuring alignment of educational outputs and labor market needs, and improving readiness of our youth to enter the labor market. Our work in the center is being probably led by these 4 main drivers. Number 1, balancing between supply and demand in a demand-oriented approach. Number 2, contribute to assure availability of our national health workforce to meet the demand. Number 3, attracting and retaining our healthcare workforces, which is a very important aspect that's being challenged everywhere around the globe. And lastly, is to having a resilient workforce that can assume multiple roles within the health sector transformation. I think this has been mentioned yesterday by the beautiful presentation by Dr. Berwick, and what we are aiming to do is to move from the triple aim of health, which is, was probably introduced by Dr. Berwick, to the modification that we heard about on our previous 2 colleagues' presentations, tackling the well-being. So our aim is not only achieving a better health, a better care, a lower cost, but also improving the provider experience by reducing the burnout and improving the well-being. And I think finally, I will just conclude, just keep this in mind. Whenever we think about workforce, we are an ecosystem that a lot of things are articulating together. So I just want to make sure that everybody understands that we are in an adaptive, complex system. We start by focusing on the demand. So what does the demand need? We want probably to align those with the national perspective of the Vision 2030, but keeping in mind our aim is to reach a value-based healthcare which is based on improving quality and reducing cost, and it needs to provide the best environment for our healthcare workforce to work together, and finally, it needs to solve the prevention, to assure the prevention and well-being. In order to do this, it needs to be aligned with a human-centric approach. So whatever going to be done, it's not going to be systems, it's going to be individuals, and how these individuals are going to articulate within the engine of health sector transformation to achieve its goals. So we need to build it from top down, bottom up, and always I say we need to listen to our workforce, practitioners and encounters, because they do have solutions to move forwards and overcome any challenges that the system might face. I think by that I would conclude. I hope I delivered some sort of few important aspects regarding the challenges that faces our workforce and how they can contribute to cultivating patient safety environment. Thank you very much.
So first of all, I'd like to say I was right. I hope you'll agree. 3 really tremendous presentations there. Can we give all 3 of our presenters another round of applause, please? It really was great. Can I invite the panelists up? We're going to take a small number of questions. Please take a seat. Sure. Yeah. I'm going to ask a series of questions. The first one will be, can you hear me okay? And I'll ask that question again, can you hear me okay? Yeah, terrific. So on the basis of those presentations, I've got maybe 100, 150 questions I would love to ask. I am restricted by time to asking one question each of the panelists, and then we'll open it up to the audience for their thoughts and for questions. So, Dr. Sudsi, I'd like to ask you first. You mentioned Deming's idea of joy at work. I'd like to ask about your thoughts on joy outside work as being a potentially fruitful route to think about our workforce and encouraging safety. Would you place your attention fully on joy at work, or is there at least an element to explore, you think, beyond that?
I think that there's definitely an element to explore, because if the person is wounded, the person can certainly not bring their full professional selves to their environment. I think sometimes we sort of deceive ourselves into thinking that irrespective of the issues outside of work, when they come to work, they would be totally focused on what is happening and there will be no distractions. I think that the evidence points to the contrary, which is that we have to think about the person holistically. And the more we are able to address their total circumstances, the better they are able to bring their full selves to work. And which is why if you look at the hierarchy of needs, if you look at the interventions that I spoke about, it's about focusing on yourself and your needs, both in and outside of work. And for we as health professionals to be more proactive in embracing all of their work. So if a health professional comes to work and talks about a difficult divorce that they may be going through, if they come and you realize that it's because they are not physically healthy that they are not able to deliver, not be dismissive of that, but to help them to come up with a solution that addresses a bit more of their personal circumstances so that they are better able to address what is at work. So I think now my colleague here spoke about the quadruple aim. Indeed, it's about the total well-being of the healthcare professionals so that they can also deliver high-quality care.
I think that's such an important point for individuals who are delivering care at the front line to think about in what ways they bring their whole self to the job. I think potentially it's challenging for those who are managing those who are working in the front line to understand that they have a role beyond the four walls of the hospital and beyond the however many hours, excessive hours people are working to help them in that. So thank you for that. Dr. Mohammed, again, so many questions I would love to ask. I'm just going to focus on one point though, because you mentioned technology as a potential stressor. I think there's always a light side and a dark side to different things. Do you see any potential opportunities in how technology is changing, or is it something that in the context of burnout we're just going to have to learn how to manage and adapt to?
Thank you for your question. I think yesterday I attended a lecture with Dr. Rahil, and he was talking about empowering of the patient. And he mentioned one example, which I like it. He was talking about one case. She came with arthritis, and after investigation, they noticed she need knee replacement, and she's still suffering after operation. After further assessment, her main problem, not her knee, but her mental health. She was suffering from depression, which affect her response to that emotion. When they deal with that, when her depressive symptom, she become better. We can apply this for healthcare provider. Mental health, it will affect your life, not only in your workplace, even outside. For that, in Eastern Health Province, we established well-being clinic now, and the main place for that clinic in our hospital. It was run by a psychologist to help all staff who are suffering from especially people who's working with at mental health services. We are dealing with addict patients, psychotic patients, all people that are under stress. So when we establish that clinic, well-being clinic, and they start to receive the staff and sit with them, teach them how to cope with this stress, they start to do some outside activities, like some celebration that will make dramatic change for our staff. Now this idea will be to be applied in other hospitals in our Eastern Hemisphere because they saw the impact of that idea.
Yeah. Oh, fantastic, fantastic. I think, I mean, again, I'd be very interested in going down with the panel, but we won't have time to think about the things that are unique to people who work in healthcare and things that are just affecting people generally. So you talk about mental health, talk about the impact of technology. We are in the middle of a merely decades-long experiment in technology at the moment, and we're yet to see kind of how it plays out population-wide and how it impacts on our medical community specifically. So thank you for that. I'll maybe build on that with a question to Dr. Ziad around the unenviable challenge of workforce planning, the tremendous technical and engagement challenge of trying to get a good grip on the future likely needs and supply of workforce. I was really interested to ask, and great to see the details about how the challenge is being approached. There is such a lead time in developing workforce that when we're preparing workforce plans, we need to look maybe a little further forward than we do sometimes in healthcare policy. So obviously 2030 is a really important number here, but 2040 and 2050 will still have people entering the workforce now who will still be working in those time periods. There is a question here. So the question is, how do you see the workforce planning approach working to make sure that we're reflecting the needs of the future, our future populations and our future health needs? How can we, what can be done to make sure that what we put in place today is adaptable to that future?
So thank you very much, John. I think this is a very important, a challenging question, and I think everybody ought to ask it in order to understand how we are approaching this from a strategic point of view. I think, as I mentioned to you, we do have the objectives of the Vision 2030 main pillars at the moment, and we're trying to articulate what sort of things that's going to be needed to fulfill the health sector transformation main objective, which is prevention and well-being. So I think everything needs to be formulated around those two important principles. In order for us to achieve that, I think we need to prioritize how we're going to be able to determine our demand. And I think this is also something very important. So I think once we determine that there are certain objectives for the Vision 2030, secondly, we're going to align this with the population health need, which is probably how we're going to improve our primary care delivery system, community-based healthcare system, and articulate this with the rapid epidemiological and burden of disease changes that we're seeing in the country, which is, I think, a very important fundamental aspect. Then try to articulate this also with a more sort of calculated value for value-based healthcare approach, which is how we're going to have a better improvement in our quality of healthcare services to be provided. And I think here the patient safety component comes as a very major aspect. Probably a lot of us spoke about patient safety. Once we improve the quality of care that we're providing to the system, definitely we're going to have some sort of financial rewards as we move forward. And here, the equation of value-based healthcare can be fulfilled. So we're providing a better healthcare quality and we're reducing the cost as we move on. And probably finally, we need to understand that we need to prepare the best ecosystem environment for our health workers to work in. So we need to equip it with the best technological advancement. We need to have a sort of a learning healthcare system for everybody that also articulate very well into the concept of providing the best health with a zero harm to everybody. So once we have that culture developing of understanding what sort of challenges that the system is facing, how we can report it, how we can learn from it, and then how we can implement solution to it, and probably go into that cycle to improve, first of all, to assure, and then probably to improve as we move on. So I think those are the perspective about where we are trying to triangulate and probably link things together in the right perspective. Of course, when it comes to data, that's going to be also a major concept. Data pertaining to the qualification, experiences, and skills of the workforce, data pertaining to the administrative productivity, efficiency, and efficacy of the workforce, and how is this linked to the value-based healthcare and later on to the GDP of the country. So I think that's the sort of a top-down approach to it, but I think we can debate this for a long period of time. Thank you very much.
Thank you. And the follow-up questions, I would love to, you can imagine them in your mind, but I think it's a really helpful reminder of how, not fortunate, but deliberately in Saudi Arabia, you have the ability to plan on a long-term basis. And you also have that, to name drop Deming again, the constancy of purpose, that everyone is aligned towards delivering that one thing. It's certainly not present in every health system, and it will certainly help here. Questions from the audience? Yeah. I'd like to go with the idea that we've 100% answered everybody's questions, but also I refuse to believe it. So we will take at least one question. Thank you.
Thank you all for your magnificent presentations. I have a question for Dr. Muhammad. I want to know how to prepare the work environment to proactively fight the job burnout, and what are the roles of leaders and work teams? Thank you.
Thank you. So the question was, what's the role of leaders and work teams in managing burnout in the work environment?
Okay, well, actually, as I mentioned, if we have to deal with burnout, we have two ways. Either we have to focus on the role of leader in that facility, or your role of how to cope with that stress. For the leader, there is many things they have to do. As I mentioned, they set a meeting, motivate their team, celebrate with the achievement, and so on. So there is many things they can do it for their team. But my opinion, you don't need to wait your leader to do something for you to cope with stress. Okay, that's a good point. It's important. No doubt about that. But how to take care of yourself? There is two things. Something out of control, and you have another thing is under your control, which is something what you can do. Take care of your sleep, your mental health, exercise, good relationship. Many things you can do it. Sometimes some environment, it's what we can say, that leader will stay forever, and he will not change his attitude, and he will not change his behavior. So you have to learn how to cope with that situation, how to cope with that leader. I think this is the thing we need to focus on it.
Could I also invite perhaps Dr. Sodzi, if you'd like to build on that?
I think the first point that I would make is that there needs to be an awareness of the problem, because sometimes these are issues confronting various healthcare workers that managers are, in a sense, blind to. And this is where the measurement frameworks that I shared will become helpful. And I think you also shared a number of them. So it helps you to come to terms with the fact that there is a problem. And it is not beyond health workers. Health workers are not immune to depression, to burnout, to suicide, and all the other issues that I spoke about. Now, having recognized the problem, how can you sort of get yourself closer to those who are at the forefront of it? And I talked about hurdles. So you can be the type of manager that is very distant from the healthcare workers and from the problems that they face, or you can occasionally give yourself the opportunity to come to the hospital floor or to come in touch with multidisciplinary teams and say, what are you struggling with in your day-to-day work? And perhaps is there an opportunity to also connect outside of the work? And you'll be surprised when you invite that kind of conversation, the kinds of things that will come through. And then also providing support programs. So you may not have the solutions yourself, but for example, could you make clinical psychologists available to the health workers and create a safe environment where it's fine for you to consult? I mean, I worked in some hospitals in the advent of COVID, and the management was itself very surprised how many people needed psychotherapy when the service was made available. Prior to that, the issue was non-existent. It was not acknowledged at all. So providing some of these support mechanisms would also prove very helpful. And I think these are three ways in which I think managers can also contribute to addressing the issue.
Thank you. We'll take another view.
Thank you very much. I think I can give you a use case that we built on it during the COVID-19. Coming from an organization that oversees postgraduate health and training in the country, we do realize that burnout is among one of the top issues that trainers go through during their residency training. And compound with the factor of the COVID-19, we thought, why don't we come with a sort of an innovative approach to tackle this challenge? So this is a use case. We came with a program called DAIM, which is to support, that has been provided to every member of our residency training programs across the kingdom. The aim of this program was, first of all, to acquire some sort of information about the magnitude and the presence of this probably issue within our training community, and then probably try to improvise some sort of solutions by providing some sort of counseling service to these trainees and linking them to the proper healthcare workers who can provide for them further sort of management and treatment if they require. This probably raised the awareness about the existence of burnout among our training population, and then provided us some sort of data to quantify the presence of this problem, and then to provide some sort of solution to them. And we expanded this to all of our training programs in different professions, and also we incorporated the families of these trainees in this program, and hopefully one day that this program can be probably propagated at a national scale where it involves all the national healthcare workforce in a sort of a generalized matter. So this is a sort of a situation where you can probably take some sort of benefit of addressing this issue and coming up with a solution to it. So just to complement about what my colleagues mentioned there. Thank you.
So awareness and understanding is a necessary, if not sufficient, step towards resolving some of the issues. Do we have time for one more question? Please.
Excuse me. Yes.
Here. Hello, sir.
So first of all, thank you so much for the amazing presentations. My question is to Dr. Ziad. One of the things that you mentioned in your presentations was an increase in technology in the upcoming years and artificial intelligence. So my question is, where does Saudi Commission or the Saudi Health Council, for that matter, stand in terms of its views of AI's effect on the physicians or healthcare workers and patients both? And is it something good or bad? That's my question. Thank you.
Okay, thank
So
you very much.
good or bad?
Good or bad? Probably we're not going to be able to answer it today, but I think we should seize the opportunity of artificial intelligence, utilize it for the benefit of best health care provision. I think that's my answer to it. So there is always a pros and cons for everything. The role of the Saudi Commission, I think when it comes to machine learning, robotics, now a lot of our competencies framework are based with these competencies included in them. And I think moving forward, we do have, probably a lot of you are aware that we do have an e-learning platform that we provide some sort of educational material to all of our healthcare workforces. And I think this particular subject will be of a great importance to us to adopt it and probably have it available for everybody. It's not yet in, but I think it is in our mind to adopt it and then probably provide it for our health workforce ecosystem for everybody who can probably acquire some sort of continuous medical education hours and probably can enhance their capabilities from artificial intelligence. So thank you very much for raising this important thing, and I think probably we're going to learn as we move on from this. Thank you.
Okay, with the utmost of regrets, I need to bring the session to a close. I will by doing what I think some of the other panels have done, which is invite one word from each of the panelists. But whereas other panels have asked for sort of one word to describe the way forward or what we should know, I think it's probably appropriate in this session to ask each panelist, is there an emotion that you would like people in the audience to take away from the sessions that they've heard, either from the last hour or from the last 2-3 days of discussions? What would you like them to feel as a result of the experience that they've been through over the last 2 days?
I wanted to say, actually, and when I hear about patient safety, usually in our hospital, the quality department, every day they are talking with us about patient safety, patient safety. For me, I don't like, therefore, they are forcing us to about this topic. And sometimes, you know, if you feel you are under pressure, you will take opposite side. During this day, these 2 days, I changed my mind about this. Now I think we are talking about very important topics, either for the patient, because during these 2 days, we are focusing on 2 things, about the patient and also about the staff. Usually when they present patient safety, usually they focus about patient, but we have to take care about the staff. So I think during these 2 days, when I go back, I will support them more.
That's so wonderful. If we can change perspectives through this kind of engagement and open people's window of discourse, that's so great to hear. So great to hear. Dr. Sozi.
Yeah, I'll be probably very brief and to say that prioritize your self-care. Prioritize your self-care. It's okay not to be able to do everything, and you are as important as the patient. And I think that's a message that also needs to come through. So prioritize your self-care and do what also gives you mental, physical, emotional, financial, and spiritual well-being. Because it's only when you are at your best that you can look after the patients. Yeah.
Thank you.
I think our healthcare workforce are the most important assets for us to achieve the objective of health sector transformation. So investing in them, building their capability, assuring that they are equipped with the skills and the experiences that they will need are the most important factor to determine the success of this transformation.
Super. Thank you. Well, I will close by saying perhaps a strange thing to say at the end of 2 days of a very, very long discussion, but I would hope that everyone here feels, as I feel, awake. So awake to the necessity of patient safety, awake to the challenge of achieving it on the front line, and kind of awake and excited about getting to grips with making the necessary changes. So thank you to my panel, and thank you everyone.
So right now, we're going to start the segment for the patient safety puzzle. So first, I want to welcome you all, the distinguished guests and prominent leaders. Welcome to the patient safety puzzle. So today, we're gathered here and united by our shared commitment to promoting safer care for all. Within these three patient safety puzzles, we aim to promote learning in a fun way and an interactive way. So in each puzzle, you have 4 questions, and then it targets different area within patient safety. In each puzzle, we will announce 3 winners, and they will receive a souvenir as well as a voucher to attend the 5th International Quality Ministry of Defense Conference, a free ticket to the conference itself without travel accommodations. So let's start together and solve the puzzle, recognizing that our unique perspective, experiences, and insight enrich the healthcare landscape. So first, we're gonna pull out a barcode for each one of you to scan and enroll in the game. So first, we're gonna start off with the patient safety puzzle number 1. As you can scan the code right there, or enter the pen to join the game. And then your present will be presented to you at your seats, as well as the voucher for the conference. Okay, I see people joining. That's good. You guys are excited. Okay, so we have 13 seconds left to join. Okay, it's 13 now, okay. I guess we can go ahead and start then. Okay, so the question is gonna pop in here and also on your phones. So this is the multiple choice puzzle. So percentage of admitted patients who were screened for VTE and bleeding risk is considered as which of the following? Please select the correct answer. You have less than 13 seconds to answer this question. I believe we have winners in the room. I can see faces of winners over here. Okay, so most of you got it right. Okay, we have Ali, he's on top right now. Okay, that's good. Keep it going. Okay, what does SBAR stands for? What is this acronym symbolizes? What's the meaning behind it? It's a symbol for something. It stands for something. It's a tool. It's an abbreviation for a tool. Okay, that's good. Okay, Faisal is on top right now. Okay, he's the leading winner right now. Okay, the role of patient and family members while they are in the hospitals to be active, blank, to reduce potential of medical errors. They're what, receivers, people, participants, or none the above? This one should be an interesting one. Okay, you got it right. It's gonna be then a close race. Okay, we got Amira here. One last question, so make sure to get that one right. Which of the following is not one of the international patient safety goals? Please select the correct one. This is the last question in the first puzzle. So you wanna make sure you get something. 3, 2, 1, and then we're gonna have a winner for the first puzzle. Okay, we have Emil Anazi and Amira and Muhammad. You're gonna receive your gifts. If you can, show hands so we know where you are seating, and we can give it to you. And also you want a free ticket to the conference as well, for the Ministry of Defense conference. Just show your hands and the gifts will be delivered to you. Please make sure to fill in the card with your email, phone number, and name so we can send you the invitation. Yeah, could you please raise your hands again so we don't miss anyone? Okay, so we're good? Okay, we'll go ahead and start the second puzzle. No, that's the first one. So just make sure to fill in the card and give it back. Raise your hands again so we make sure we didn't miss anyone. Okay, so one here and the second one over there. And where's the third winner? There is Amira as well and Muhammad. I think we're missing one person. Okay, so now we're gonna start with the second puzzle, the patient safety puzzle. Okay. Okay, now so we have our second puzzle. If you can scan and also register your name for this one. This is also going to be a 4-questionnaire puzzle as well. People are excited. I can see 47 registered already, 48 going, okay. So we're gonna start soon in 3 seconds. Be ready. Okay. So this is true and false puzzle. Okay, adverse events in healthcare setting are always preventable. Always. This is your keyword, always preventable. Okay. FEMA is a tool for conducting systematic proactive analysis of process in which harm may occur. So is it true or false? Okay, so 2 more questions left in this puzzle. So cause and effect, an organizational tool that helps team explore and display many causes contributing. So now we're going to our final question in the second puzzle. So is a systematic analysis method using tools that focus on individuals and patients? Okay, so we have our winners. We have Abir, Muhammad, and Safety Joe. Please raise your hands so we can see you. Okay, so I just want to make sure I don't miss anyone. Yeah, just keep your hands up so we can see you. But don't wave them though. Just keep them up. So again, just fill in the ID card with your email, phone number, and name so we can send you the invitation to the conference. Yeah, raise your hands so we don't miss anybody. So we have a winner here too, over there. And then I believe we're missing one more winner, right? We have one more. Where is our mystery guest hiding? He's in here somewhere, or she is. Okay, so now we're going into our final puzzle, the patient safety puzzle 3. So scan the code to join for the last one. So please, if you have a card that you already filled out, please pass it to one of my colleagues so we can collect your information to send you the invitation to the conference afterwards, please. Okay, so puzzle 3 is definitions and terminologies. Our first question, when frontliners are comfortable disclosing errors, including their own, while maintaining professional accountability, what is that? What is this definition? It stands for which one of these options? And we've talked about this topic during our workshops, so I hope everyone knows this definition by heart right now. Okay, good. Where clinicians and patients share the best available evidence to support informed preferences. What does that stand for? Preferences is the key word here. Amazing crowd. I guess we have a lot of nerds today. So an event that could have caused harm to people or group of people stands for what? And now we're going into our last question. And then we're going to announce the last 3 winners for this puzzle. So blank involves exploring the characteristics of components within a system work task, for example, tech culture and how they interact. The key word here is interact. And we also had a workshop about this as well. Great, now we're gonna announce the last 3 winners. We have Sanaz, Hamza, and Dr. M. Please raise your hands so we can see you. Great, keep your hands up so we don't miss you. Thank you guys for the spirit and thank you for participating. I just want to close this by saying, may this event serve as a reminder that our diverse voices and the experiences are invaluable in shaping the safer care for all, and together let us strive for excellence and ensure that every patient receives the care that they deserve. So thank you, and we hope to see you in our conference next year.
Assalamu alaikum. Time flies with the good moments and the good crowd. It's somehow painful moments to close this amazing conference. Emotionally attached to this. Been doing this over the preparation, communication with speakers, meetings across different committees, doing all the necessary steps in planning, risk management, mitigation strategies, but you cannot plan everything. Again, the flexibility that the crowd and the attendees has shown covered the defects that we encountered. I cannot thank you enough for dedicating the time to attend to this amazing city. Sharing your knowledge, your experience has been tremendous. Al-Qasim has been a generous city to us. The culture and the heritage and the love that we had over the last 3 days cannot be compared. Special thanks to one of the benefits of this conference and the challenge that we had, that I got to know a lot of amazing individuals. A very close friends, that this will never end, this relationship with these individuals with the closing ceremony. 2 amazing individuals that I have worked with them over the last 6 months. They have done an amazing job. They have shown true leadership in making this conference happen. I would like you to join me in a round of applause for Mr. Saleh Al-Hijailan, the head of organizing committee. A true leader that I was honored to work with him under his leadership. A humble guy and a very quiet, ethical leader. Again, another round of applause for Dr. Rakan Mghir, who is shy of light. Intentionally left the area, so he's a bit of shy person. A special thanks to our partners from the IHI, Dr. Suji and Ms. Minara, coming all the way at special times when they had to travel again to the States. So thank you for being here. The knowledge and the wisdom that we had over the last 2 weeks, the last 3 days is amazing. We hope to continue having this relationship. I would like to thank the attendees. the colleagues from the Saudi Patient Safety Center, the colleagues from the Directorate of the Healthcare in Al-Qasim. Truly a memorable time. And this will continue in real impact on the groundwork that we will try to translate whatever we learned into bedside care. The scientific committee, with another special thanks to our colleagues from Aramco, Engineer Umar Al-Bassam, for the amazing talk that he put on today, Engineer Khalid Bukhari from GACA. We learned a lot from you, and we hope to have this continuous conversation. How can we learn from each other? The comparabilities and the commonalities and the differences between the two industries, and we agreed on future collaborations. I would like to thank the scientific committee for their amazing job. Just up front for the great minds in the scientific committee. As a scientific committee, participants, speakers, and guests, we formulated a draft for a declaration that we think it is worth to be shared with you. It's going to be publicly reported in the website and in the Twitter feeds of both entities. I'm going to read it, and I'm a crier, so if I cried in the middle, just don't clap. So we, the participants and the organizers of the 4th Saudi Patient Safety Center International Patient Safety Conference, held under the patronage of His Royal Highness Prince Faisal ibn Mash'al Al Saud, recognized the critical importance of patient safety in healthcare. During the conference, two crucial aspects of patient safety were discussed in separate panels: diagnostic safety and benchmarking patient safety regionally. We acknowledge the significance of both topics and affirm our unwavering commitment to addressing them, as they are integral to the overall enhancement of patient safety. Call to action: we believe that addressing both diagnostic safety and benchmarking and measurements of patient safety regionally, we can together create a safer, more efficient patient-centered healthcare system. We call upon all stakeholders, including healthcare organizations, policymakers, professional society, to join us in our commitment in advancing patient safety. By working together, we can strive toward a future where diagnostic errors are minimized, patient safety is continuously improved, and the highest quality of care is provided to all patients in Saudi and GCC countries. With that, we conclude our conference. Thank you for being here.